this special issue, Team VishwaRaj Hospital Pune under VRH GYAAN initiative has arranged a resounding conference on recent advances in sexual medicine, which is being held on 2nd and 3rd December 2023. The goal of this special issue is to update knowledge by providing scientific evidences about the advances in sexual health, sexual functioning, and its dealing. So, as we move further, I am glad to introduce this eminent personality before you, Dr. Sachin Katkade sir, Assistant Medical Superintendent, VishwaRaj Hospital, Pune. Sir has completed MBBS from MAEER College, Pune in 2012. He has completed his post-graduation diploma in anesthesia in 2016. Furthermore, he also worked as consultant in Department of Anesthesia from 2016 to 2019 in VishwaRaj Hospital. Adding on it, sir has worked as an intensivist from 2019 to 2022 in the same organization, and also promoted as a head of department in ER in 2022. And sir currently holds a chair of Assistant Medical Superintendent in VishwaRaj Hospital. What a beautiful journey. May I request Dr. Sachin Katkade sir on stage to introduce our organizing committee and take the charge of this further program. Sir, please.
On behalf of MAEER'S VishwaRaj Hospital, I welcome all the faculty, guest of honor Dr. Rajendra Bangal sir, all the faculty, all the chairperson, and all the delegates. I am here to introduce the organizing committee. Organizing chairperson is a Dr. Sanjay Dhangar. He is a consultant urologist at VishwaRaj Hospital. Dr. Sanjay Dhangar graduated from Mahatma Gandhi Institute of Medical Sciences, Sevagram, Varda. He did his super specialization in urology from Ruby Hall Clinic, Pune. He is a member of editorial board of many urology and reproductive medicine journals. He has associated membership of 40 surgical, urology, scientific and professional societies and organizations. He has received many honors like FACS, FMAS, FAIS and many more. He has received many awards, Best Research Award 2021, Best Teacher Award 2021, Asia's Health Professional Award for Men's Sexual Health 2021, Lifetime Achievement Award 2021, Outstanding Faculty of the Year 2022, Best Editor Award in the years 2021 and 2022. Our next organizer is Dr. Vijay Khandale. He is a consultant and HOD ICU in VishwaRaj Hospital. He has completed his MBBS from MISR Medical College, Latur. He has completed his MD Anesthesia from Tata Memorial Cancer Hospital, Mumbai. He has completed his FNB Critical Care from Kokilaben Dhirubhai Ambani Hospital, Mumbai. He has worked as an ICU consultant in Hiranandani Hospital, Powai. He has worked as a liver transplant ICU consultant in Global Hospital, Parel, Mumbai. Now he is associated with VishwaRaj Hospital since last 4 years as a ICU HOD. Our next organizer is Dr. Mahesh Rokade. He is a consultant nephrologist and transplant physician in VishwaRaj Hospital. He is practicing in Pune since last 14 years. He has completed his MBBS and MD medicine from Vijay Medical College, Pune, and went to his DNB nephrology from MUPH, Nadiad. He is a fellow of International Society of Peritoneal Dialysis. His areas of interest are acute kidney injury, dialysis, and renal transplant. Currently, he is associated with VishwaRaj Hospital as a chief nephrologist and transplant physician. And today's organizing secretary is Dr. Tabrez Pathan. He has completed his UG from Rajiv Gandhi University of Bangalore in 2011. He has completed his post-graduation diploma in emergency medical services. Since 2012, he has worked in various hospitals in critical care area. He has worked as an assistant in charge in ER in VishwaRaj Hospital from 2017 to 2020. In COVID pandemic, he has handled the entire medical part of VishwaRaj Hospital as a nodal officer. From 2022 to 2023 as a manager medical operation. He has worked as a medical admin, research and academic wings of the VishwaRaj Hospital. He is leading the institute ethics committee as a member secretary. He has been promoted as an assistant general manager operation in the VishwaRaj Hospital. Now I would like to invite Dr. Sanjay Dhangar on the stage to take care of the further program.
चेयरपर्सन्स का लगा दो आप चेयरपर्सन्स लगा दो बाकी मैं बोल दूंगा लाइट कम है पूरी लाइट में बढ़ा दो पहले चेयरपर्सन आप इंट्रोड्यूस करने वाले ये बंद हो जाएगा अभी मुझे दे दो मैं आगे बढ़ा दूंगा फिर इसके बाद बता देना अब तब तक वेलकम तो कीजिए फैकल्टी का लगाना चेयरपर्सन गुड मॉर्निंग ऑल ऑफ यू welcome once again to this exciting event. So let's start the session now. I would like to call upon the chairpersons for the first session, Dr. Shamsik Bal and Dr. Deepak Gaikwad. Please come on the dais. Dr. Shamsik Bal is a urologist. He's practicing for last 20 years. At present, he is working in Bharti Hospital as associate professor in the Department of Urology. His special interest is in endourology, laser surgeries for the stone and prostate. Dr. Deepak Gaikwad is physician. He has done his MBBS from Kolhapur, Shivaji University, 1993. He completed his MD medicine from Shivaji University in medicine in 1997. He is working for the last 26 years in the same field, and currently he is working as a consultant physician in Khandale, Pune. So welcome all once again. I now request Chairperson Dr. Shamsik Bal to introduce our faculty for the first session, Dr. Bhupat Singh Bhati. Sir, please come on the dais.
Good morning, everybody. It gives me immense pleasure to be here amongst you all for a very interesting topic, which has come out to be openly now in increasing numbers. I would like to introduce the speaker, Dr. Bhupat Bhatti, who is a consultant urologist and transplant surgeon. He has done his DNB in genitourinary surgery and MS in general surgery. He is director of Eurozone Holistic Kidney Care Clinic, Pune. He is a senior consultant at Manipal Hospital, Pune, also a senior consultant at Ruby Hall Clinic, Pune. He has clinical experience of more than 21 years, 3 years in urology as full-time registrar, including DNB training, 4 years in general surgery as a full-time resident lecturer. He has more than 15 plus scientific papers and posters in national conferences and submitted 2 thesis research at various conferences. He has presented 4 publications in the international journals. His special interests lie in minimally invasive kidney surgery, renal transplant, endourology, reconstructive urology, uro-oncology, neurourology, male sexual dysfunction, infertility, female urology, and advanced laparoscopic and robotic surgeries. The awards and achievements he's got is Icons of Health 2021 Times Award in field of urology, lifetime member of USI, lifetime member of West Zone Urology Society, lifetime member of IMA Pune, and lifetime member of International Association of Sexual Medicine. Now I hand over the program to Dr. Bhupat Bhatti.
Good morning, friends. At the outset, I would like to thank the organizing committee for giving me this opportunity to give a talk on the erectile dysfunction. Topic is quite a broad topic. To start off with, I have given this topic to just give an overview of all the aspects what we are going to cover in the next 20 minutes. Now, to start off with, I will take one quote from the Tolstoy has told. He is a noble literate of 19th century. He said once, "Man survives earthquakes, experiences the horror of illness and all the tortures on the soul. But the most tormenting tragedy of all the time is the tragedy of the bedroom." Yes, it's absolutely correct. He quoted in 1920s this words. And this is what we are going to discuss in the next 20 minutes about the erectile dysfunction. To start off with, what is the definition? How do we say what is erectile dysfunction? Definition states consistent inability to achieve and maintain an erection adequate for the satisfactory sexual intercourse. Seems to be quite simple definition, but the condition is very complex for the patients coming from post to pillars in one to other OPDs. Day to day we are seeing it. Get back to the anatomy of our early days. What we are going to discuss in the next slide, we should know what we are, to start with the anatomy. Organ phallus in a male is has a few components: skin, followed by the fascias, then comes the areolar tissue, followed by the Buck's fascia, then is the tunica albuginea, two corporal bodies from where the blood goes and gives the engorgement and for the erections, urinary pipe covered with the corpus spongiosum, and in the center we have a cavernous arteries are there. What is required for the normal sexual function? To start off with, a gentleman should have a intact libido, one component. Detumescent state should be there. Ability to achieve and maintain an erection and ejaculations. So these are the four components on which all the talks for the next 20 minutes I am going to take it. All the aspects are very important, and it will be covered in next 2 days by all the my colleagues which are going to give the lectures on the libidos, the sexual aspects, from the ejaculatory dysfunctions, erection issues, health aspects, psychological aspects. Physiological part. Penile erection is a neurovascular event which is moderated by the psychological factors and hormonal status. On a sexual stimulation, the blood flows into the organ in the lacunal networks, causes the compression of the trabecular smooth muscles, which leads to the closure of the emissary veins, and it traps the blood in the corpora, and the organ becomes non-compressible. Goes with the innervation. We have a pelvic plexus, which is behind the bladder in front of the seminal vesicles, in which erection is mediated by the parasympathetic nerves, and sympathetic part from T12 to L2 controls the ejaculation in the flaccid state. This is required in the reconstruction, and when we are doing a pelvic surgeries, we should be aware which nerves we are taking care while operating. We should keep these nerves during the surgical aspects. How the erection occurs? Still going into the microscopic level, whenever the sexual arousal or the stimulus comes, nitrous oxide is released. It converts the cGMP into the GTP into cyclic GMP, which releases and causes the relaxation of the arterioles and the trabecular smooth muscles, which leads to the expansion of the corporal bodies. And once the blood flows in the corporal bodies, the subtunical vessels get compressed between the tunica albuginea and resulting into the total occlusion of the venous outflow. So this is the basics of the erection, how the things works in a normal individual. You get a sexual desire, blood flows into the organ, it remains into the organ, veins get compressed, arteries increase the blood flow, and it maintains that, and then sympathetic outflow comes and it started detumescence. This is a normal erectile response in a male. Pressure increases, it goes up to 100 millimeter of mercury during the erect phase in a normal adult. It varies in a different persons, but yes, this is what happens from a dependent flaccid state to the erect phase. This is the response which we get in a normal individual. Classification, there are a lot of classification there in the literature mentioned. As per the guidelines, EUA guidelines 2020, we says it's a organic cause of the erectile dysfunctions, psychological the most important factor, and the mixed variety. Majority of the patients come into the psychological aspects nowadays, considering the lifestyle changes, stress of the works. We see a broadly, in my clinical practice, I am seeing 60% of patients in the psychological aspects, 10 to 15% comes with the organic EDs. And the third part is the erectile. Mixed component is there in the clinical practice. Other classification, broadly, when patient comes in the outpatient department, we tell them either it is a primary erectile dysfunction, it is just he never able to perform an intercourse in his life and first time he is coming with the symptoms, or secondary ED is do call when the patient was normal with one partner and later in the half, as the age advances, he started getting the erectile dysfunctions. So there are different broad classifications are there for the erectile dysfunction. Broadly, organic, psychological and mixed, what we do in the clinical practice in majority of the patients. Now come to the, what are the causes of erectile dysfunction? Let me tell, my talk of discussion is purely on the males. I have not covered the female aspects. That will be taken tomorrow by my colleagues for the female sexual dysfunction. This talk was given me for the male erectile dysfunction. So I have taken into consideration etiology part and the management mainly in the male factors. Psychological aspects, yes, this is the majority of the bulk. Performance anxieties, relationship issues, depression, anxiety, fatigue, guilt, excessive consumption of alcohol, smokings, marital issues. A very broad classification. Experts are sitting in the in our this thing for the today's discussion on these aspects. I won't go into the details how to manage these areas because my colleagues are going to take these issues in detail and in depth. Everything leads to the anxiety and patient is not able to perform. This is what is a psychological or a psychosexual part of the erectile dysfunction. And it is a, let me tell you, it is a most important aspect nowadays which we see in a patients. They are, even if he is having a small element of organic issues, his mental health is what which is get affected in these things. And it is being 20% of organic issues leads to the 80% of the anxiety performance for the next time, which keep on increasing with the every act, which compound to the issues. So it is a very important aspect. Other factors, in 10 to 15% patients, we do see a patient with a vasculogenic causes, that is some accelerated hypertension, atherosclerosis in the small vessels of penile arteries, deep dorsal artery having atherosclerosis, trauma to the organ. This can lead to the erectile dysfunctions. Neurogenic aspects, clinical practice, yes, patient malignancies in the pelvic areas, APR surgeries, what the hysterectomies, radical prostatectomies. Surgeries done in the pelvic area in the organ do causes damage to the pelvic nerves and leading to the erectile issues. Diabetic neuropathies, spinal cord injuries, stroke. These are the neurological factors which affect the erectile dysfunction in the patients. Other factors which take into considerations are long-standing diabetes, uncontrolled diabetes, I would say, elderly patient at the age advances, chronic kidney diseases, CAD, coronary heart disease, very important aspects. I will take that part later on in the discussion, how it is directly connected with the erectile issues. Coronary artery disease is one of the strong risk factors in a patient with erectile dysfunction, either of the ways. Hormonal factors, yes, there are certain conditions like hypogonadisms, patients having erectile issues, and clinical entity treatable conditions of pituitary adenomas with hyperprolactinemia has been seen in 1% of the patients in clinical practice. We do see the patients. Drug factors, there are certain drugs, list of drugs are there, drugs, alcohol abuse, cigarette smokings, chronic smokers. They do affect erectile dysfunctions or erectile issues are there in the patients. This topic has been covered as a different aspect later part of the day. What are the drugs and how to manage. But broadly classification, I have seen beta blockers, statins, thiazides, antidepressant, antipsychotic drugs, calcium channel inhibitor and ACE inhibitors. This group of drugs when taken in a long duration by the patients over a period of few years, then a subset of 10 to 15% patients start getting the erectile issue. It is not a single tablet will lead to the ED issues in majority of the patients. They should discuss these issues with their treating healthcare providers, and along with the urologist. Doses can be titrated, add-on drugs can be given, and it is very much manageable by in that aspects. So it is a decision between the three doctors. One is a physician, healthcare provider, general practitioner of the patient, and a treating psychologist, therapist, and a urologist or whoever andrologist who is treating the patients. How do we differentiate in outpatient department after taking a detailed clinical history, which aspect of patient we are treating? Is it a psychogenic ED or the organic ED? We do get a rough idea once we see a patient in outpatient department, which type of, after taking a history, if a history is of a sudden onset is there, it is situational with the patient. He is giving a history, I'm getting a night erections are there with me, I'm able to perform a masturbations without any issues, and I'm having a problem only during the performing intercourse with my partner. Some event in the major events in the loss of job, some of the other major accidents, some loss in the families, anxiety, fear, depressions. This subset of patient, usually after the history, we come to know, okay, this gentleman is having a psychological part of the erectile dysfunction, and it should be given a proper counseling. And counselors are now very much important aspect of the treatment, more than the medicines, I personally feel. So in my clinical practice, I take a decision, myself giving a medicines, I involve my clinical psychologist, always in my picture, and we both together as a couple, we treat these patients. Organic part of the erectile dysfunction, histories are usually gradual, and patients are usually in the mid-40s, which we see in the patients. They don't get any erection. The history is quite classical in these patients. I don't get morning erections. I don't get even erections during the masturbations. And they do have certain histories, like some cardiac events, neurological history, stroke, some surgeries in the past, radiations, trauma to the organ, and chronic alcoholic and smokers. So from the history aspects, we do get an idea which type of erectile issues we are going to treat in the patients. So history taking is very important. Now, what are the risk factors involved? Per se erectile dysfunction, as per the EUA guideline 2020, I have just taken out all the headlines which is there mentioned. We are strongly connected with the erectile dysfunctions. Aging, yes, advancing age is one of the important factors. Coronary artery disease, strong risk factor in the patients. If you detect a patient with a erectile dysfunction at the age of 20s or 30s, this gentleman itself is a cardiac risk in the longer age. This has been documented in the long section population studies. If you have erectile issues at the age of 30s, this gentleman in the age of 50s or 60s or 70s late, he will be having some cardiac issues. He should be investigated in that way. Other aspects, long-standing diabetes, risk factor, yes. Peripheral vascular diseases, it affects the blood flow into the organ. Chronic alcohol smoker, direct connection is there. Direct correlation in many cross-sectional studies all over the globe has been done on that aspects. Nowadays, obesity, sedentary lifestyles, weight gaining, excessive works, stress, raised level of cholesterols, yes, they all are the important risk factors. These risk factors, when we discuss with the patients, they are all treatable. If you take them, if a patient take these aspects very carefully, most of them are very much treatable with the other aspects, and he will be better off with his symptoms of erectile dysfunctions. Now, once we have taken the detailed history, what to do? How do you assess the patients? Assessment requires a detailed history, and most important aspect is the history taking in all the erectile patients. Give the complete ample amount of time to this couple or a patient, because he has he has already done the research on the social media, on the Google, everywhere he has done the research. He has a half knowledge, either half right, half wrong, we don't know. But these patients should be taken a detailed history. History taking is very important aspect in a clinical practice. Give him good amount of time, whatever the queries are there, solve that part. And you try to elicit the history which is important. History from the medical aspect, from the surgical history, his psychiatric evaluations, and medications, alcohol, and recreation drug. These aspects should be, leading question should be taken from the history aspect, whatever the patient giving his own history, because that gives us idea about what are the risk factors involved in these patients, how do we are going to tackle these patients. Specifically focus history on the sexual aspects. We do ask the patient as a couple, has he able to perform with one partner or the another partner? Is the foreplay important aspect is there? Is he get erection during the masturbations? All this history, anything, all of us are taking this part as important aspects. I had kept one questionnaire. It is a standard practice. Considering outpatient is very, if you have too many patients in the outpatient department, you can give this questionnaire to the patient. It is an international index of erectile functions. Questionnaire is there. And patient take its own 10 to 15 minutes prior to meeting to you and start a scoring system. So by the time the patient reaches you in the, for the consultation, you have a rough idea which type of erectile issues which he is facing, one, and what is the severity of the problem. The scoring system says if it is anything score between 20 to 25, it's a no erections are there, and less than 10, he has a serious issues are there. Scoring system is something like this. This is a questionnaire which I had kept in my outpatient department. This scoring system actually takes 5 aspects and scoring by 1 to 5. First is the how to rate your confidence levels. 1, do you get the erections? 2, how often you are able to maintain? 3, and how difficult for you to sustain, and is it satisfied or not? So the idea of this questionnaire on the international aspect was to cover the parts of erectile functions, orgasmic function, the sexual desire part, intercourse satisfaction. This is what this questionnaire has told us. You will get a rough idea on the patient's history before he is talking to you, what I am going to, which part I am going to focus in this questionnaires. So it is one of the important aspects. I do recommend my colleagues to follow this. Once you have taken the detailed history from the patient, what next? Clinical basic examination. As a healthcare provider, all of us are doing a detailed examinations. I do take some focused areas which needs to be taken into consideration. Blood pressure, very important in this patient. Hypertensive, accelerated hypertension, one of the important risk factors. Peripheral pulses, just see the pulse of the patient. Sometimes you may miss the arrhythmias are there in the patients, and that is important coronary artery risk factors in the patients. Examination, we do patient with the EDs having a small flabby testis, hypogonadism. You can directly clinically diagnose the patients. See for the secondary sexual characters. Penis for the phimosis. Young patients coming in the outpatient department, because of the lack of education, they are not, few patients don't even know what is phimosis. They don't feel skin should be retracted back, and this sort of important teaching which is still missing in our school levels, which patients come to know in the outpatient department what is phimosis, and this is the main cause of erectile dysfunction, very much a treatable conditions. So examination aspect is very important. Clinical examination, we see the plaques, we see the melanoprostatitis. These are the conditions which are treatable in these patients. So examination, important aspects, should not be ignored. Investigations, all of us as a healthcare provider doing all the basic investigation which is required for the patients, but focus, apart from the complete workup, I do focus on the testosterone levels. I do get a prolactin levels done, and areas of sugar, yes, diabetes, we should be taken. Lipid profile. Recent studies have shown that raised level of lipid profiles or LDL levels, it is definitely connected with the erectile issues in the long term, and correction of this over a period of time, patient do better. It's a individual important risk factor and treatable factor in the EOA 2020 studies. Thyroid function, yes, hyper and hypothyroidism needs to be treated accordingly. So investigations, I keep this as a basic investigations. Apart from the routine profile, I do get my patients examined in this way. After doing these examinations, whether the patient need a further investigations, advanced testing includes nocturnal penile tumescence rigidity test 1, second is intracavernous injections 2, third is a Doppler study 4, and a very subset of patients may need, those who need a reconstruction surgeries, we recommend arteriography or the direct infusion cavernosometry. In a clinical practice, I have done only twice this study. I have never come across in my clinical practice the patients of this subset of patients. And neurophysiological testing, usually it's a, I have read about this, is a limited in the clinical utilities are there. Regi scan, it is done in the andrology clinics. This is to differentiate patients. Are we treating a patient with a psychological ED or it is an organic cause of the ED? It is a penile tumescence test in which 2 gauze are kept, one at the tip, at the coronal sulcus, and one at the base. And overnight we do the monitoring at an interval of 7 days. 2 readings should be taken into the consideration, and it detects the circumferential rigidity, and a patient should get at least 60% of the rigidity should be recorded at both the ends, and which should last for 10 minutes. That means a normal night erections. In a normal adult, 5 to 6 erections in a rapid eye movement sleep, that is REM sleep, is a normal for a physiological response, where you get a good rigidity and erections in the deep sleep also. That means when the patient is free from any external stress factors relating to any sort of stress in the deep sleeps, this differentiates between an organic cause and the psychological aspect of the erectile dysfunction. Intracaverous injections, yes, one of the diagnostic tools when you have a clinical dilemma, whether it is something is wrong with the blood flow of the organs. We give a pap test to the patients and see the erection should come in 10 minutes and it should last for minimum 30 minutes. This is the way to differentiate between the arterial or the venous cause of the erectile dysfunctions. Doppler is a very important. Nowadays, we are getting this test on a regular practice. In a clinical practice, Doppler is one of the important aspects. We do Doppler with and without the pap test. In a Doppler, if a blood flow is going more than 30 centimeters per second and the end diastolic velocity is less than 3 and RI index is 0.8, that suggests adult is normal. And this is now has become one of the more important medico-legal aspects also. That part we should be having some documented proof whether the patient is having a ED issues or not. Is it a psychological aspect or something is wrong? Doppler has now becoming a standard of practice more than the NPT test now. NPT was in the past 10 years back when I was doing my 15 years back. NPT was very frequently doing. Now in a clinical practice, Doppler has taken over as far as my practice goes off. Those who are doing a vascular reconstruction, yes, arteriography and intracavernous cavernosometry and high-end CT angios for the penile, high-end CTs can be done to isolate the isolated penile artery stenosis. 1 to 2% of patients come in this bracket, those who require a reconstruction, revascularization surgeries. Now, what does the guideline says? This is the last guidelines of the EUA comes in 2020. The guideline says you should take a detailed history. 1, you should identify the risk factors. 2, focus examination should be for the penis, prostate, hypogonadisms, CVS history and the neurological. This is a standard practice which should be taken into the consideration as per the algorithms. In the laboratory aspects, you should do the examination, focus on the sugar levels, lipid profile and the testosterone. This is a basic test which should be done as a part of investigations in patient with the erectile issues. Now, how to treat? The last part, this is only a broad view I am giving it. In a detail, it will be taken in the next 2 days. There are different aspects of all the parts are taken. I am just taking the overview of the discussions. What is the treatment modalities in the ED in a males? General therapies, psychosexual therapy, important aspect, drug therapies, vacuum and surgical aspects. There is one subset of patients all of us are getting in the outpatient department is a patient coming with erectile issues in mid-30s, 40s or 50s with a cardiac issues. Okay, doctor, I have a heart issues, I have a heart problems. Moment we get this thought in a mind, ki patient is having a heart issue, should we give the tablets or not? What medicines to be given? This is a very important aspect in a clinical practice. See, cardiac patient with erectile issues is an important aspect, and how it should be treated, that is to be taken into consideration. To start off with, broadly, this is a classification. I don't want to get in detail, but yes, we do stratify the patient. Is it a low risk for the cardiac, intermediate risk or the high risk patients? So from the history aspect, you can get it, what exactly is the patient. If patient is asymptomatic, number 1, he don't have a cardiac problem right now. If the risk factors are less than 3, the risk factors are usually hypertension, high cholesterol levels, increased weight, morbid obesity, alcoholics. This is the risk factors present in the patients, and obesity and diabetes. If the risk factors are not there, patient had a MI in the past and his CHF status is stable, hypertension is controlled, these are the low risk patients. You can safely give the drugs in this patient without even consulting a cardiologist. In a clinical practice, you just take the history. If patient is absolutely fine, you don't need to do anything. They are absolutely fine. If patients comes in, the risk factors are there. He is hypertensive, he is obese, he is having a high cholesterol levels, He had angina, which is stable on the drugs. He had MI in less than 2 months, between 2 to 6 months. Then he needs to be assessed. And high-risk patient should be sent to the cardiologist. How to assess, how to differentiate? The recent guidelines is once you see the patient with the cardiac issues, get the exercise ability done. What is exercise ability means? Sexual activity is equivalent to an adult walking 1 mile on a flat in 20 minutes or climbing at 2 flights of stairs in 10 seconds, and is absolutely fine. If you ask this patient a history and if he's giving yes, that means his tolerance is good. He can able to perform with the oral drugs. If a risk factor is low, you can easily give the medication without any issues in the patients. If it is an intermediate risk, get a stress test done. It is basically a treadmill protocol of 4 minutes walking on the treadmill. If the treadmill is showing no problems, then definitely after getting a treadmill test conducted, you should have a confidence patient will not get affected from the medications. And if it is positive, then it is a high risk case. Cardiology should be giving a clearance for the starting a medical therapy in the erectile patients. Coming back to the last part of the management, how to look upon. As a healthcare provider, we are giving all patients, yes, stop the smoking or reduce the smoking. I would say nobody stops in a clinical practice. Yes, they can reduce it. They should reduce the alcohol, weight check and daily exercises. They are the 4 important aspects in all the patients which we see that is very much treatables. Psychosexual therapies, very important aspects. I recommend all my colleagues involve a counselor always in your clinical practice to get a life easy, because patients do need a counseling in these aspects. I won't take details of this aspect because it will be covered in the next few slides later on by my colleagues. Drug aspect, yes, there are drugs in the market which works on the erectile dysfunction. Oral drugs, PD5 inhibitors, oral phentermine, yohimbine, intracaverous injection with the L-prostadil and papaverines, and the intraurethral L-prostadil is given. Psychosexual aspects, I think it will be covered in the later part. It is an important aspect. PD5 inhibitors, yes, they are the drugs. Sildenafil, tadalafil, and the vardenafil are the important group of drugs which we are giving in the day-to-day practice. Tadalafil is a weekend pills. Usually it works for 48 hours and is no drug interaction with the food. Other 2 required to avoid a fatty meal should not be taken. PD5 inhibitors, they inhibit the conversion. It maintains the cyclic GMP, increase the erections. Dosaging, it is fastest acting drug nowadays in the market is Evenafil. It is available in India now. It comes in a strength of 150 to 100 mg. It is shortest acting drug. It acts in less than an hour or so. Drug interaction, contraindications, nitrites, cardiac events. If you have fibrosis, sickle cell anemia, PD5 inhibitor should not be given. Hypogonadisms should be investigated. Testicle replacement therapies should be given along with the PD5 inhibitors in a patients if testosterone levels are less than 230 nanogram in a patients, or if it less than 240 in hypogonadism patients. Intracaverous injections in clinical practice, 10% of patients require this. L-prostadil is only drug. In India, it is given by Samarth Pharmaceutical is giving this in a vial, and success rate is 70 to 80%. Clinically, patient come back with the pain at the local site. Penile pain is the most important thing which we are seeing it, and priapism is the second aspect. Bimix and trimix therapies are there. Clinical practice difficult to get these drugs, but yes, they are available. Papaverine, phentermine, and they are given in combinations. Triple therapy, yes, it is 92% response. Again, multiple injections given over long periods, they do cause the fibrosis in the organ, and this is the area of issues. Intraurethral therapy, it is mentioned to given a prostadil. Pellets are given into the, inserted into the organ. This is a vacuum therapy. I won't go into the detail of that part. It is just one of the aspects in a clinical practice. It's difficult to maintain because patient do get a penile congestions and unable to ejaculate. He needs to take out the ring. Penile prosthesis, it will be covered in the next part of the discussion. 2-piece and 3-piece. I do basically a Shah's implant and 1 and 2 penile implants are done. Revascularization surgeries, very isolated patients in which inferior epigastric artery is anastomosed to the deep dorsal arteries. subset of patients should be young patient, non-diabetic, non-smokers. And latest in the guidelines or what the literature says, consider for the topical agents is in the clinical trial 1, shockwave therapy is 2, stem cell therapy 3, and the plasma-rich injection. They are the 4 new treatment modalities which is there. Many studies are going on these aspects, and it has shown results in the clinical trials, but not in the population studies. All 4 are heavily marketed nowadays, but still long-term results are yet to be given with all these 4 aspects. Thank you.
Thank you, Dr. Bhupat. The session is open for question and answer session. Anybody for any question?
Yes, sir.
Regarding the etiology, hello, audible? Regarding the etiology, you should address the orientation also. That means if the patient is homosexual, that means he will not be having erection when he is married. That means heterosexual relations. That you forgot to.
Point well taken, sir. I got your point. Yes.
And the spouse-induced erectile dysfunction is there.
That I had mentioned, that is a very important aspect. All in a clinical practice, it should be a couple therapy. I never take my patient after the first visit. I want a couple should be taken into consideration. A history should be taken from as a wife also, then as a couple and individuals, and also involve our counselors.
Yeah, once erectile dysfunction occurs, the first time, spouse blames him. Then,
yes.
Like Tolstoy is told, it happens always.
Yes, absolutely right, sir.
One more question. Yes, sir. Bhupat, any experience with plasma-rich stem cell therapy?
Sir, I have just read in the literature results. There are 2 clinical trials which are showing a promising results. As per the 2020 guidelines, it has. I have not done anything, but promising results as per the literature. I have not done in a clinical practice till now, sir.
Okay, thank you.
It's experimental, sir. Yeah, it's experimental. Stem cells, plasma cells, still experimental. 2 studies are there in the literature right now. Shockwave therapy, there are 3 clinical trials till now. 1 from India and 2 from the Europe and EUA. From the EUA is there, sir. 3 trials are there, showing a 35% clinical response in a patient, sir. But my personal experience is not very, till now it's not there, sir. Yes, sir.
The new study says that the statins are not contraindicated.
They are not contraindicated. It is a treatment decision between a patient and a treating physician, and it should be taken, if it is taken for what the study says as per literature, that long-term usage, heavy dose usage, and other risk factors involvement, then only, otherwise nothing, sir.
Okay.
Absolutely
Exercise will be better.
I give my patient a clinical advice, 25 to 35 minutes of exercises, weight control, stop habits, makes life easy.
I just wanted to ask whether sildenafil is your drug of choice or tadalafil or...
Sir, depends. Nowadays my choice is Evenafil, sir. Nowadays, a short-acting drug. If a young patient required at the weekend pill, definitely a Cialis, the tadalafil is a drug of choice. It works for 36 hours. Short-term actions, if you need, then definitely sildenafil is a drug of choice because action remains for 4 to 6 hours, sir. So it depends individually what is the requirement. If it was short-term, 1 session he wants, or he wants for a weekend. If it wants a long-term, then for 2 days, definitely not for the 2 days, at least for 24 hours, this tadalafil works, sir, in a clinical practice.
And another important point is they should never be given with nitrates. You might have mentioned it.
Yes, nitrate is a contraindication for this. Yes, sir.
Do you give tadalafil as well as sildenafil combined therapy?
In a clinical practice, I don't give in a combination, sir. I don't give a combination of these 2 drugs.
In my practice, results are better. That means tadalafil, 10 mg alternate days, and sildenafil or avenafil SOS.
I give 5 mg of a dose in a daily therapy. Along with that, I add one of the drugs. This is my practice, either 2.5 or a 5 mg. I give, the continuous therapy in a clinical practice. Along with that, I add on the situation on the day of intercourse like this. But I don't mix the two molecules in a one go, like 50 mg or 20 mg like that. That I don't do, sir. Low dose daily therapy and add-on therapy I give in a clinical practice, sir.
That is what I am doing.
That I am doing it, yeah.
Thank you very much, Dr. Bhupat Bhatti. I would now like to call upon Mr. Sudhir Ittam, General Manager for Operations, VishwaRaj Hospital. Sir, please come on the dais. Dr. Bhupat sir, please come here. Mr. Sudhir Ittam will now felicitate Dr. Bhupat Bhatti. Thank you, sir, once again. Sudhir Uttam, sir, please wait here. I would like to, now I would request Mr. Sudhir Uttam to felicitate our chairpersons. Dr. Gaikwad, please come on the dais. Mr. Sudhir Ittam sir to felicitate our next chairperson, Dr. Shamsi Iqbal. Sir, please. Thank you very much, sir. So, time for inauguration and the light lamping ceremony. Before that, I would like to introduce our guest of honor, Dr. Rajendra Bangal. He is a foreign medicine expert. He is currently the Registrar of MUHS Nashik, Maharashtra. He is member of the Admission Regulating Authority of Maharashtra. He is member Regulatory Authority. Then he is a medical legal consultant and forensic expert. He is member National Advisory Board of the Indian Academy of Forensic Medicine. Similarly, he is member of Board of Research of MUHS Nashik. He is also a member of Ethical Committee of MUHS Nashik. And he is also Editor Emeritus of the Journal of Forensic Medicine, Science and Law. The main thing that he is here is we have a very close relation with Dr. Bangal. In fact, as a forensic medicine expert, he is helping a lot in many of our problems. So I now request Ms. Veena from the nursing department to come on the stage and proceed with the further proceedings. Thank you.
ज्ञान का प्रकाश जो प्रज्वलित हो सबकी दुनिया बदल देता है। योग्यता का प्रकाश जो प्रज्वलित हो कौशल और चिंतन के साथ डिज़ाइन कर लेता है। Now it's time that we light a lamp of knowledge to overcome the darkness. So may I request our guest of honor, Dr. Rajendra Bangal sir, Mr. Sudhir Uttam sir, GM Operation VRH, Mr. Mahesh Chopre sir, Registrar MIT ADT, Dr. Sanjay Dhangar sir, Consultant Urologist, VishwaRaj Hospital and Chairperson of the conference, Dr. Shashikant Dr. Iravarkar, Medical Superintendent Gramin Rugnalay Yavad, Dr. D.N. Hambire, Director Medicine VRH, Dr. Ajayan Varghese, Director Institute of Sexual and Reproductive Medicine, Kozhikode, Dr. Sachin Katkade, Assistant Medical Superintendent VRH, Dr. Joshi sir, GM Cells VRH, Dr. Mahesh Rokade. I request all the dignitaries to join the stage for lamp lighting. I request all the audience to please stand for the World Peace Prayer. Thank you. Audience may please take a seat. May I request Mr. Mahesh Chopre sir to felicitate our guest of honor, Dr. Rajendra Bangal sir. Sir, please come on stage. Mr. Mahesh Chopre sir. Rajendra sir to please share a word with us.
A very good morning to all the dignitaries present in this hall and senior consultants from various places. I bring greetings from Maharashtra University of Health Sciences. It is most of the this university started in 1998. So all those who have graduated after 1998, they must be having the degrees of MUHS. However, very few individuals or few doctors, they do visit the university. They just get the degree, they maximum go to the colleges. The interaction with the university is very less. So I take this opportunity to invite you all to our campus, which is spread over, I will take 2 minutes to introduce my university, and then I will come to the topic. It is spread across around 52 acres with lush green campus and water bodies over the campus. In addition to that, recently another 30 acres we have got from the government for medical college and hospital. So it is in the city of Nashik. And at present, more than 550 medical health science colleges are affiliated to the university, including medical, dental, Ayurveda, Unani, homeopathy, physiotherapy, nursing, and all this. 550 plus colleges are there. It is one of the largest health science university in India. Recently, we have, and there are all 5 regional centers in Mumbai, Pune, Nagpur, Kolhapur, Latur, and Chhatrapati Sambhajinagar. So these regional centers are there. Plus, we have established chairs of excellence. So, like in Nagpur region, we have chair in tropical medicine. In Chhatrapati Sambhajinagar, we are establishing in community ophthalmology. In Pune regional center, the chair in genetics. In Nashik headquarters, chair in medical educational technology. And in Kolhapur, we have chair in preventive cardiology. So we are divided into, though it is a one health science university, our approach is an integrated approach. We consider modern medicine has to go hand in hand with other pathies of Indian system of medicine. So a research center has been set up on the university campus, which carries out integrated research in modern medicines and Ayurveda in various diseases. So in short, our approach, as with the vision of our Honorable Prime Minister, that Ayush also should be considered as one of the main stream of therapy. So that's the vision of university also. Now coming to today's topic. Now I was going through the list of lectures or topics. So most of those are clinical oriented, and of course it should be like that. But a topic on medical legal aspect of erectile dysfunction, that was missing. So I request the organizer, next time when you organize, you please add this particular system topic in this subject. The thing is, VishwaRaj Hospital is not new to me. I have been associated with VishwaRaj Hospital since almost a decade or so. So almost since its inception, and handling most of the medical legal aspects and issues and trainings of the consultants and doctors on the floor. I am coming to this campus for this hall for the first time, and I thank the organizers that they have invited me for this purpose. When we were students, this term erectile dysfunction was termed as impotency in males and frigidity in females. Now it is erectile dysfunction. And the medical legal aspect of this, mainly there are 4 issues. First is about the, if this erectile dysfunction is present before marriage or at the time of marriage, then that marriage is considered null and void ab initio, that is, marriage did not happen at all. But if it happens after the marriage, then it is a ground for divorce. That is one thing, and that's why many cases, when I had served in BJ Medical College for 5 years, then JJ for 7 years, so most of these cases, they used to come to us. And mainly these criminal aspects, that is, whenever there is a allegation of rape or the issue of disputed paternity, then they used to involve a team of experts. Third aspect is when we sustain injury during work or something leading to impotence or diminution of potency, then the issue of compensation is there. And lastly, the issue of which is more pertains to us, that is doctors treating, means urologist or this gynecologist. These issues is regarding medical negligence, allegations of medical negligence on by the patients or by the couple claiming compensation from the courts, consumer and or even in criminal negligence. So these mainly are the 4 aspects of medical legal aspects of this particular topic. Now, whenever we used to teach the students, we used to teach that you cannot label a patient while giving opinion in case of potency or impotency for that purpose. It has to be given in a negative form, double negative form. That is, what we write is the person, that there are no findings to suggest that the person is incapable of performing sexual intercourse. So nothing to suggest and incapable of performing. So that is the way we taught the students. The opinion should be given. Even if there is no abnormality or nothing, physical abnormality, or you find no cause, whatever the list of causes sir has just told, there is no cause, still you cannot say that he is potent. So you have to say that, I don't know what is your this thing, but this is, we taught the students that whenever offender of rape is brought to you and you examine him, the police, their only query is you label whether he is potent or not. You give your opinion. So in that case, you used to give that we find nothing to suggest that the person is incapable of performing sexual intercourse. I will just tell you a true anecdote and then I will stop. A similar case was brought to a medical college for examination. A senior professor in forensic medicine, he examined the accused of rape. And after the examination, he submitted the report to the police. The case went to the court. While deposing before the court, this professor, when he was asked, what is your opinion about whether he is potent or not? So he clearly stated that, in my opinion, this person is perfectly potent. So this was clearly against what we taught, that it should not be stated like that. So he said he is perfectly potent. The judge and the lawyers, they were not used to hear such type of replies. And then he asked, how do you substantiate that? How do you confirm? And how do you so firmly say that he is potent? So he said that when I was examining the patient, and during the course of examination, I did his per rectal examination to know the status of prostate. And while I was examining the prostate, he was enjoying it and he got the erection. And that's why I clearly say that he is potent. So everybody was quiet for some time. And then the lawyer, he turned to the courtroom. Everybody was sitting. he said, that means every time my client wants to have erection, this doctor has to come and put his finger in his rectum. So everybody started laughing. And but the doctor remained calm and quiet. So when the courtroom was quiet, he said, that is not perfect, that is not the complete truth. Even your finger, he told to the lawyer, even your finger can do equally well. So this was just, and this is a true story. Okay, thank you very much for inviting me here. Thank you.
Thank you, sir, for sharing your experiences. And now I would request Dr. Mahesh Rokade, sir, to carry on with the further sessions.
Getting back to academics now. Getting back to academics now. The next topic for today's discussion is premature ejaculation, and I would like to invite Dr. Shashikant Irwadkar sir to chair this session. He is an orthopedic and trauma surgeon. He has done his MBBS from VM Medical College, Solapur in 1995, and he is an MS orthopedic from Vijay Medical in 2006. He has also served as a medical superintendent at Yavat PHC until 2023. May I kindly request Dr. Shashikant Irwadkar sir to invite our speaker for this topic, Dr. Irfan Sheikh, and the topic is premature ejaculation.
Hello. Good morning. Good morning to everyone. I will invite Dr. Irfan Sheikh for further talk. Dr. Irfan Sheikh is consultant urologist, urosurgeon and andrologist. He is one of the top urologists in Pune. A good medalist in the Department of Urology, Dr. Irfan Sheikh specializes in female urology in India. He has completed his education at one of the top colleges. He has completed MBBS from Vijay Medical College and Sassoon General Hospital in Pune and MS General Surgery from PGI Chandigarh. Moreover, he has also done MCH in urology from Topiwala National Medical College and BYL Nair Charitable Hospital. With the experience of over 11 years in this field, he is well versed in treating all kinds of diseases related to the urologist. Worked as a senior clinical fellow at Leicester Hospital, Hertfordshire, UK. Just after this, I will call Dr. Irfan Sheikh to continue his speech. Thank you.
Thank you, sir, for kind introduction. I'll be discussing a very common topic which we all see very commonly, that is premature ejaculation. So, as I said, it is very common and we see such patients very commonly in our day-to-day practice. 20 to 30% of men in sexually active age group suffer from premature ejaculation, and it leads to psychological stress, affects their self-esteem and their relationship status, eventually affecting the quality of life for both patient as well as the partner. So premature ejaculation, in brief called PE, is a commonly used term, but more scientific term is early ejaculation or rapid ejaculation. So according to International Society of Sexual Medicine definition, P is defined as ejaculation which always or nearly always occurs prior to or within 1 minute of vaginal penetration. Here vaginal penetration is important. So for foreplay and other things don't count. So after penetration, if ejaculation is occurring within 1 minute, it is premature ejaculation. Along with that, there should be, this is the lifelong premature ejaculation. In patients who have acquired premature ejaculation, time limit till 3 minutes is also permitted. And in both most important thing is inability to delay the ejaculation beyond control. So patient don't have control over their ejaculation, and it causes negative consequences both to the partner as well as the patient. So it leads to distress, stress, anxiety, and bother. So we should understand how the ejaculation occurs. What is the physiology of ejaculation? So normal antegrade ejaculation consists of emission, expulsion, and orgasm. So these three things happen. This is the diagram where both cortical as well as brainstem is involved, spinal cord is involved, and eventually through pudendal nerve, the sensory input or ejaculation sensations, they travel and eventually lead to ejaculation. So what is emission? Emission is the process of ejection of spermatozoa, which starts from epididymis through vas deferens. Eventually it comes till the posterior urethra. So this is the emission. We should understand both sympathetic as well as parasympathetic nerves are supplying these areas, and mainly in ejaculation, parasympathetic play important role. It has a clinical implication where treatment modalities also depend on these. So very important point in this is closure of bladder neck. So competent closure of bladder neck is important in antegrade ejaculation. So patients after prostate surgery or patients having neurological issues, they suffer from something called as retrograde ejaculation. So patients get sensation of release of semen, but sperms, they travel back, and patient don't feel that sperms are coming out. So bladder neck closure is very important. Expulsion is that semen has already come till the posterior urethra. So from there to for semen to come out, the process is called as expulsion. It is a spinal cord reflex, and it is a phase where there is point of no return. So from treatment point of view also, this phase is called as point of no return, and here we cannot stop or delay the ejaculation. Competent bladder neck and urethra and pelvic floor muscles, they are important. And so this is the ejaculation involves areas from from cortex to spinal cord. So these are interconnected. Here the neurotransmitter role is very important. It has therapeutic implications. So serotonin is most important. Apart from dopamine, oxytocin, GABA, and adrenaline, they are also involved. But major role is of serotonin. All the receptor subtypes are involved in the process of ejaculation. And orgasm it involves both ejaculation of and the response it creates. Like it involves in the sexual response cycles also, like desire, arousal, orgasm, and resolution. And it gives that pleasure sensation of the sexual act. And it is quite short. The cerebral, it is a cerebral process, and we should understand that orgasm sometimes occur without competent lower urinary tract, like patients who has had radical prostatectomy, or they may feel orgasm even though they may not have sensation of ejaculation. They may have retrograde ejaculation, and still the orgasm can be felt by these people. So role of serotonin is that serotonin inhibits the ejaculation and delays ejaculation, prolongs the time, ejaculation time. So if there is low level of serotonin or serotonin is cleared very rapidly at the synaptic level, it leads to premature ejaculation. There is a genetic predisposition in serotonergic pathway, and it leads to mainly the primary PE. Pelvic floor dysfunction again is an important part where it leads to both premature ejaculation as well as erectile dysfunction. So this is most distressing. If there is pelvic floor dysfunction and associated ED, then it is like severe form, and patients are affected more and more in these psychologically. They are more affected in such cases. So this is the diagram showing synaptic level, where mainly the role of depoxitin at the level of serotonin reuptake, and eventually it leads to prolonged ejaculatory latency time. As I already said, serotonin is a major neurotransmitter, and low level of serotonin, it leads to premature ejaculation. So drugs, those lead to increased level of serotonin, they cause increased ejaculation time, and so it is used as a treatment modality for premature ejaculation. Causes, like we already seen, there are two types of premature ejaculation, primary P and secondary P. Primary is basically it is present since beginning, or it starts at the first intercourse level. Mainly psychological factors are important. Impulses like conditioning, where masturbation plays an important role. Upbringing or previous traumatic sexual experiences, they play an important part. Genetic predisposition again is an important factor in primary PE. Secondary premature ejaculation is mainly seen in patients who are diabetic, hypertensive, hyperthyroidism. Again, very rarely, like we suspect that thyroid could be a cause of premature ejaculation, but hyperthyroidism can be a cause of secondary PE. And use of recreational drug, even though common belief is that alcohol and recreational drug delay ejaculation, but they are found to be causes of secondary PE. Psychological issues like depression, anxiety, stress, or lack of interest in sexual performance, all these can trigger to PE. Hyperthyroidism is associated PE. We already seen substance abuse. Important factor with current lifestyle, lack of sound sleep is becoming normal, but lack of normal sleep can lead to low serotonin level, eventually leading to premature ejaculation. So we have seen primary and secondary or acquired PE. Two other varieties are there, natural variable PEs and subjective PEs. So natural variable PE is premature ejaculation, which is a normal variant of sexual function. And here important fact is intravaginal ejaculatory latency time is normal or sometimes short. It is inconsistent, like sometimes patients typically give history that sometimes my ejaculation time is normal, or like I'm satisfied, and sometimes it is quite abnormal. So it is natural variable PE. Here the important factor is ability to control ejaculation is not there. Like it doesn't depend on the will of patient. In all the definition, this is the most important factor. Some patients we get that though their ejaculation time is less than 1 minute, but they are not distressed or they are not bothered. So in that condition, we may not classify it as a PE. And another variety is subjective PE or premature like ejaculatory dysfunction. Basically here, again, ability to control ejaculation is lacking in this patient. It is the perception of inconsistent rapid ejaculation, which leads to subjective P, and most of the time their ejaculation time is normal. So this is the subjective P. Role of clinical history and clinical examination is important. Based on the history, we can differentiate between types of P which we are dealing with. Practice most of the time patients are not aware about the premature ejaculation. They label it as erectile dysfunction. So we have, as a clinician, we have to ask them what exactly is happening, whether erection is not appropriate or you're ejaculating too early. Physical examination is important, and other etiological risk factors like endocrinological, hormonal history and evaluation is important. Psychological history is important. Here, serum testosterone, prolactin are to be done in these patients. Thyroid levels, at least TSH, needs to be evaluated at primary level. This is penile biothaciometry is an important investigation, but it has not gained widespread use because it is like very subjective, varies from patients to patients, and like it doesn't have treatment implications. So some centers are doing it, but it is not very commonly done. It's basically the sensory threshold is checked at the level of penis, in maybe at the level of glans, at the level of shaft, and if it is delayed or it is hypersensitive, like based on that we can determine the level, but the treatment doesn't depend on the results of biothaciometry, so it did not gain much importance, even though like some centers are doing it. Coming to the treatment, it involves non-pharmacological, pharmacological and emerging or maybe surgical or newer modalities of treatment. It is like erection, ejaculation, and sexual act as such is a complex procedure. Many factors work. It is not like any other problems where we can pinpoint the cause. So treatments are multifocal treatment, multiple point of treatments are important, multiple options are there. So we need to educate our patients that this could be the cause. So they sometimes get depressed that I have been given a medicine for premature ejaculation and it did not work even 1%. So they get more stressed and it adds to their psychological stress, leading to further reduction in the performance. So non-pharmacological treatment, psychotherapy or behavioral therapy is very important, should be offered to all patients. But it requires strong compliance both from the partner as well as patient, and time consuming, and patients, though it is effective, but sometimes patients are not able to continue the treatment for long duration. So eventually the efficiency or result is less as compared to the medicines or tablets which we'll be seeing in pharmacological treatment. It is first line treatment and should be offered to all patients. And it is very important in managing the psychological stress or distress it is creating, both for the patient. Non-pharmacological treatment involves stop-start technique, squeeze technique, use of thick or multiple condoms, pelvic floor exercises, These are non-pharmacological treatment. Squeeze technique, here when patient feel the urge to ejaculate, patient or partner holds the penis with thumb and forefinger to for that it acts as at the level of bulbospongiosus reflex, leading to diminished ejaculatory urgency and loss of desire. So again, as I told, cooperation from patient as well as partner and sticking to this technique requires lot of efforts, and we find that practically it is difficult for patients as well as their partners to continue with this. Pelvic floor therapy significantly increases the intravaginal ejaculatory latency and should be offered along with these all techniques, even with the pharmacotherapy. Similar technique is stop-start technique. Partner stimulates the penis until the patient feels the urge to ejaculate, but patient should stop stimulation and wait for that sensation to pass. So again, they have to stimulate till there is patient feel that there is point of no return and stop it. So thereby eventually helping the patient to increase the ejaculatory latency. Now, newer modalities are coming where these at the level of patient and partner, it is very difficult to do and repeat because every time if you are going to do that, it will create stress for both the patient as well as partner, and the natural sexual act becomes an activity. So now, in past few years, few machines have come which will be mimicking the stop-start technique. I have seen one such machine in conference in China. So this is this stop-start technique was incorporated in machine along with there was stimulation by the machine, and we can self-start or self-stop that stimulation. So such machines will be coming to our part also within near future, and it will be very useful for patients to use them because compliance is an issue with anything which involves partner. It needs a lot of motivation from their end. Pharmacological treatment, we all know that topical treatment is there. Few medicines are there. Main backbone is depoxitin, which is the only FDA approved drug for premature ejaculation. But along with that, many other medications are very commonly used as off-label treatment for premature ejaculation, includes tramadol, tricyclic antidepressant, SSRIs. PDE5 inhibitors at low dose are also being used very commonly nowadays for treatment of premature ejaculation alone, and patients who are having ED along with premature ejaculation, they are very useful, probably the drug of choice. Alpha blockers have also been proposed to increase the act of ejaculation, but we don't find it practically works. So theoretical discussion is there. Tramadol, again, we all use it as an analgesic, but off-label use of tramadol is quite useful, and it is to be taken as on-demand medication, probably 1.5 to 2 hours prior to the act of intercourse. It acts at the level of reuptake of serotonin as well as noradrenaline, and it leads to prolonged ejaculation. Here, advantage is that it has very less side effects, and it improves the control, and the sexual performance is also better. So these are common side effects of depoxitin. Depoxitin, I'll tell the recommended dose is 30 milligram on demand to be taken 1.5 to 2 hours prior to intercourse. Some patients don't respond to 30 milligram. We can use up to 60, but at that point the side effects are more. PDE5 inhibitors we have discussed. Alpha blockers, again, tamsulosin as well as silodosin both have been used. We can use in few patients, they do respond, but not commonly and not to be offered as a first-line treatment for PE. So these are emerging modalities and newer treatment where surgical treatment is there. Still, there is no first-line evidence that surgical treatment increases the ejaculatory latency time. First important modality is selective dorsal neurectomy. Few centers are doing it very commonly. We at our centers have done few cases. It responds nicely in like I would say 50 to 60% of patients, but beforehand it is very difficult to determine which patients will respond to dorsal neurectomy and which won't. So that is, we need to understand more about this procedure. It involves basically cutting off few branches of dorsal nerve of penis where it is a daycare procedure and without much morbidity. It can be offered mainly patients who don't respond to the pharmacotherapy and who are suffering from lifelong PE. So it is like in coming days, it may become more and more common. Few centers from Korea, they do this other procedure called as glans penis augmentation using hyaluronic acid. Again, basic premises is that you reduce the sensitivity of the nerve. Advantage is that it is a daycare thing, like you would not require an admission, maybe within an hour or so you can go home, not required anesthesia also. It is an injectable treatment, but long-term treatment has to be seen, like long-term result. And other modalities like Botox also are coming, where we locally inject Botox in bulbospongious muscle, where theoretically it would inhibit the ejaculation, but practically, in my experience of few cases, it has not shown much response. So these are the newer treatments. In conclusion, premature ejaculation is a common problem and which leads to distress to both patient as well as partner. Pathophysiological mechanism is complex and diagnosis is mainly clinical, not much role of investigation in this. Behavioral therapy and psychotherapy is mainstay and first line treatment of PE. Topical treatment and pharmacotherapy should be offered in all patients, and Depoxitin is the mainstay of treatment currently. Thank you. If someone wants to ask few doubts. Okay, sir.
Experience of Ayurvedic drugs.
Sir, like I don't use like Ayurvedic drugs, so practically, sir, I don't have any like personal experience with Ayurvedic medications.
Yeah, I will answer for this question.
Yes,
Cannabis is the best drug of choice for this thing, premature ejaculation. My patients use it. That's why, but I don't encourage it.
Yes,
because it
yes,
will be
sir.
addicted. But cannabis is the drug of choice for ganja for premature ejaculation.
Yes,
One thing I want to ask,
yes,
whether the biothismiometry you are practicing, you are doing, or someone else is doing.
So I have at my center, I have the facilities, so, but like we have observed that it doesn't change the treatment modality. So
The exact problem is that frequency is 0 to 50.
yes, sir.
That means for doing penile biothesmiometry, it should be at least 200. I have developed such a machine and I am practicing it. I get better results. That means I have increased the range. That means normally, if you are going in
Stimulation,
internet
yeah.
also, the range is from 0 to 50
Yes,
only,
sir.
50 hertz. That means in our electricity also it comes out like that, 230 voltage and 50 hertz. I have changed the frequency to
200.
500 with the variable frequency drive, then I am getting the good results. And penile sensitivity ratio is also well calculated.
Okay.
Tomorrow I am taking the class about penile
Yes, sir.
biothesmiometry.
Yeah.
Thank you.
Thank you.
It is not only the cannabis or ganja, but any intoxicating drugs or substances do delay ejaculation in some cases, not all. Even alcohol is also very well known.
So like, so but alcohol, it is not like opioids or cannabis, but like in
Alcohol is something like that, he boasts something, but the performance will be good.
yes.
That means he will be boasting like anything, but performance will not
Will
be there.
not be, yes.
But there is no other drug which compares with LSD where there is time distortion. You feel seconds as minutes, minutes as hours, hours as days, and days as years. So as eons. So somebody having sex for 5 minutes, he'll feel that he has done sex for 500 days.
And you didn't consider the partner issue. That means suppose the female partner is not having orgasm within 10 minutes, then we cannot say it is as premature ejaculation.
Yes,
It is
yes,
the
yes.
fault, whether it is the fault of log or carpenter, it is the fault of the log itself.
Yes,
That-
yes,
Okay.
yes.
Okay. Any question?
Thank
No
you.
questions? Thank you, sir.
Thank you.
Now, may I invite Dr. Sachin Katkade to felicitate the chairperson for this session, Dr. Irwadkar, sir. Dr. Sachin will also felicitate the speaker of this session, Dr. Irfan Sheikh. Thank you, Dr. Sachin, Dr. Irfan Sheikh, and Dr. Irwadkar. Now I hand over the mic to Dr. Sanjay Dhangar.
So continuing with the CME, I would like to invite chairperson for the next session, Dr. Kalpana Khade, Dr. Manik Vijay. Ma'am, please. Madam को slide लगा दो. Dr. Kalpana Khade is senior obstetrician and gynecologist. She is president of the Indapur IME Association. She is from Indapur. नहीं, अमित मुक्ता सर, हाँ. Dr. Manik Vijay. I would now request our chairperson, Dr. Kalpana Khade, to introduce our next speaker, Dr. Amit Muta. Amit Muta, sir, please come on the dais.
Hello. Sir is Associate Professor of Grant Medical College and JJ Group of Hospitals, Mumbai, pursuing PhD Sexual Problems and Their Management in Geriatric Population, Grant Medical College, Mumbai. He is a Joint Secretary Executive Committee, CSEPI 2325, India. He is a Vice Chairman, Sapphire Institutional Ethics Committee, Thane, since 2014. He is a member of St. Elizabeth Hospital and Research Center's Institutional Ethics Committee, Walkeshwar, Mumbai, since 2017. He is a member scientist of SL Raheja Hospital and Research Center's Institutional Review Board, Mahim, Mumbai, since 2017. He is an associate editor of Asian Journal of Integrated Nephrology and Andrology since November 2015. Column editor in Journal of Psychosexual Health since November 2018. He has been awarded Fellowship Council of Sex Education and Parenthood International in September 2015. Original research article in indexed national and international journals. Published oral papers in national and international conferences. He was a guest speaker in scientific and non-scientific forums. His core interest in andrology, sexual medicine, and reproductive endocrinology and sexology. I request you, sir, to deliver your speech.
Thank you for that elaborate introduction and kind words. Thank you, the organizers, Dr. Sanjay Dhangar, my good friend, for inviting me to this forum and share my experiences in the field of sexual medicine. I started practicing in 2011, so most of the presentation would be based on my own experiences, practical experiences, which I follow while practicing sexual medicine. So, in a nutshell, I would request somebody to have couple of chairs on the stage, and anybody who is willing to volunteer to be a patient of sexual disorder, not particularly erectile dysfunction or premature ejaculation or desire disorder. It's stuck. There is erectile dysfunction in the slides. It's frozen, frigid. Can we do something about it? Yeah. So, how do we approach a case of sexual dysfunction? When I say sexual dysfunction, it doesn't mean that it is only erectile dysfunction. whatever I am going to share or talk, it will cover the 90% practice of sexual medicine. And more of, I would like to present it as an interactive session. Now, patient details are the first thing which we need to do. Name, age, sex, address, contact details, date, reference, the referring doctor or the past patient or internet or social media. Now, this is important for somebody who is looking to practice dedicatedly in the field of sexual medicine. Every each aspect is important. Now, apart from the name and of course age, sex, address, age is very important because in my opinion, the sexual disorders are bimodal in nature. One is predominantly less than 40, where the nature of sexual disorders is predominantly psychological, and above 40, where the reason for sexual disorder is predominantly organic in nature. Now, chief complaints. Chief complaints can be erectile dysfunction, then you have disorders of desire, arousal disorder, penetration difficulty, premature ejaculation, ejaculatory dysfunction, orgasmic dysfunction, male, female or both. More commonly, the presentation is from the male side because of his inadequate performance. There is the orgasmic dysfunction is predominantly female would be the complaining party. Pardon? Hello, am I audible? Hello? Okay. Am I audible? Yes. Okay. So, orgasmic dysfunction, which is male, female or both, and predominantly the party which complains about orgasmic dysfunction is female. Men will generally confuse between the orgasmic experience of their own. They are basically unhappy because their partner is not able to achieve orgasm. So, if you probe properly, the men will be experiencing that satisfaction after ejaculation. So, in this list, the most common entity is a combination of erectile dysfunction and premature ejaculation. Second most common entity is erectile dysfunction as a patient presents in our practice. And the third most common entity is premature ejaculation. Then you have loss of libido, desire disorder, arousal disorder. This might be a very less percentage, 2%, 3%, 4%. But the most common is combination of erectile dysfunction and premature ejaculation. Now, the next part of history taking is very, very important. Whether the patient is married, unmarried, engaged and sexually active with the same person with whom he is engaged and sexually not active with the same person but active with some other girlfriend or some other person. Then you have dating, which is quite common in not even in urban but rural areas. Then you have girlfriend or boyfriend because presently we are in an environment where gender fluidity is being pushed. Then you have casual sex, one night stands, friends with benefits, a common terminology in urban college settings. Then you have commercial sex workers like prostitution or call girls and people with homosexual tendencies. Now here I would like to take the help of this gentleman as a volunteer of a sexual dysfunction patient, if you don't mind. Yes, what's your good name?
My name is Dr. Vivek Narayane.
Okay. In which language you are comfortable?
Anything, sir. English can be.
English, Hindi?
English.
English. Can you take that chair and sit in front of me? So you have to pretend to be a patient of sexual dysfunction.
Yes, sir.
If you don't mind.
Yes.
Okay. So when I start this particular history, each and every, with this 8-point part, most of your diagnosis will be confirmed as far as patient of a sexual dysfunction is concerned. I will ask you some direct questions, and you have to be honest. You have to pretend to be a patient. So you have to give your answers as a patient, not as a clinician. So which language you are comfortable in?
I'm comfortable in English, sir.
English or Hindi?
Hindi also, Marathi also.
Marathi also. So you are from Pune?
Yes.
So which language speakers are the most of the patients?
Marathi.
Marathi. So Marathi will be better? Okay. So some questions I will be asking you in Marathi, which I know the meaning of. Some which may not be, then I will ask you in English. Okay? So संभोग करायची इच्छा होते?
Yes. हो सर.
होते. Natural है ना, नैसर्गिक है.
हो.
So इच्छा होते तर जेव्हा इच्छा होते तर लिंगामध्ये काही बदल होतात?
हो होतात.
होतात. ताठरता येते?
हो सर.
ताठरता येते. ताठरता किती असते? 100% असते का? हे जर 100% आहे ताठरता, तर याच्या कंपॅरिझनमध्ये तुमच्या लिंगात जी ताठरता येते ती 25% येते, 50% येते, 75% येते की 100% येते?
100% येते सर.
You are patient.
I'm a patient. So 60%.
60%. Okay. So assuming that आपण तुम्ही जे म्हणताय ते आपण सत्य पकडू, तर 60% तुमची ताठरता आहे लिंगामध्ये, तर ते योनीमध्ये शिरकाव होतं का? त्याच्या आतमध्ये जातं का लिंग?
हो जातं. पूर्ण जात नाही पण जातं.
पूर्ण जात नाही पण जातं. ओके. तर किती जातं? इतकं जातं की इतकं जातं?
30 ते 40%.
30 ते 40%. म्हणजे तुम्हाला ते सफिशियंट वाटतं का?
नाही वाटत.
नाही वाटत. तुमच्या पार्टनरला जाणवतं का तुमचं लिंग आतमध्ये गेलंय?
हो जाणवतं.
जाणवतं. व्यवस्थित जाणवतं की कंप्लेंट करते?
नाही कंप्लेंट करणार.
कंप्लेंट करते. काय म्हणते?
पूर्ण जाणवत नाही म्हणून. पूर्ण सॅटिस्फॅक्शन होत नाही, पूर्ण जाणवत नाही.
सॅटिस्फॅक्शन नाही.
हा पूर्ण जाणवत.
गेल्यासारखं वाटत नाही.
गेल्यासारखं वाटत नाही. हो.
दॅट इज बेटर.
मराठी.
असून नसल्यासारखं आहे.
हो बरोबर.
ओके. ठीक आहे. सो पेनिट्रेशन इज कवर्ड. देन समजा तुम्ही गेले, 30-40% गेले, देन यू स्टार्ट स्ट्रोकिंग, म्हणजे तुम्ही धक्के मारायला सुरुवात करता. तर हे जे तुम्ही धक्के मारतात ते किती वेळेस ते धक्के होतात रफली सांगायचं आहे तुम्हाला? 5 वेळा, 10 वेळा, 50 वेळा, 100 वेळा, 500 वेळा?
20 ते 25 वेळा.
20 ते 25. Now here, if you see the number of strokes in a minute, the patient is saying 20 to 25 in a minute. So for an average person, any person stroking 20 to 25 minutes, not minutes, 25 times is less than 30 seconds. In a minute, roughly a normal healthy male would stroke for at least 50 to 70 times. So there you can figure out that there is a premature ejaculation as far as the definition of premature ejaculation is concerned by who? Who defines premature ejaculation? As a doctor, I am asking you.
Doctor.
As per the International Society for Sexual Medicine and VRH criteria, less than 1 minute it's defined as premature ejaculation. Then you have ejaculation. Ultimately, if there was no ejaculation, people would not stop screwing each other. So ejaculation is the defining moment. So you have to ask, virya nikto ka? So if the answer is yes, then the ejaculation is a sign of experience of satisfaction for most of the men. But there are men who are worried that even if they are satisfied, but they are worried that their partner is not achieving the orgasm, and that makes them uncomfortable. And then third, last part is orgasm. Orgasm is a male which is defined by ejaculation, and female is an experience. Some women might squirt, they might, the fluids might come from the Bartholin gland, and that might be the end point. Some they just experience. So it's very varied in female. So this covers, thank you, you've done the good job of a patient. So this covers most of the sexual medicine, the patients presenting in a sexual medicine clinic. Then very important as far as the, apart from the psychological aspects which I have already spoken, there can be anything, rejection from the partner, just a comment from the partner, foul smelling, bad breath, foul smelling smell from vagina, or lack of confidence. All this can cause sexual dysfunction, psychological part of the sexual dysfunction. Coming to medical, it's very important, and we tend to miss out. And classically the patients, they are not comfortable in sharing their sexual difficulties to their regular physicians, because they don't want to reveal their sexual difficulty to their regular doctor. They might change a doctor, go to somebody else who doesn't know them personally. So this is what I come across, because the referring physician is usually not a family doctor of that particular patient. So one aspect, some are comfortable, their family physician will be referring them. So most important in our day-to-day practice in today's era is diabetes mellitus, then you have hypertension, then you have coronary artery disease, stroke, or urinary complaints, respiratory complaints, particularly COPD. They have a less respiratory capacity, so they may not be able to maintain the sexual tempo for a longer duration of time, and they might lose erection also because of their psychological preoccupation that they might not perform, they might collapse, have difficulty in breathing and everything. Then you have surgical history like major, minor. Major surgery, some people after some major surgery, they feel that they have lost that mojo inside them. And even minor in genital region surgeries, they are worried that something has happened, so they lose erection. Strong psychological component post-surgical might be also evident. Now coming to addiction history, very, very important. Tobacco, chewing as well as smoking. A single butt of smoke is proven to cause spasm of dorsal artery of the penis for at least 4 hours. So, and people, when you ask, then sir, इतने सब पीते हैं सिगरेट, तो हमको ही क्यों ऐसा हो रहा है? तो दूसरों को हो रहा है कि नहीं, ये आपको कोई बताएगा नहीं. Nobody shares or tells that I am having sexual difficulty because of my smoking. It doesn't happen. One. Second is that you need to tell that with the duration of smoking, the magnitude of effect on the erectile tissue is more. So if somebody has smoken for 5 years or 10 years or 20 years, of course the 20-year guy will have more severe symptoms of erectile difficulties. Then coming to alcohol, again somebody has pointed out rightly, the desire increases but the performance downs. Again the same pattern. A beginner alcoholic may not experience so many problems, but somebody, which I come across very commonly, somebody who has taken alcohol, consumed like anything, like it, what do you call, काय म्हणतात ते, trailer or tanker, like a tanker for years together, over 20-year period of time definitely is bound to show some signs and symptoms of sexual dysfunction, apart from the hormonal imbalances which are evident in a long-term alcoholic. Then you have ganja. Ganja again, quite commonly I get these people, long-term ganja consumers, they experience erectile dysfunction. But the beginners, which make them take the ganja again and again, they experience delayed ejaculation. So that is the reason, because that gives enhanced performance long-lasting erection also is there, because unless there is ejaculation, the erection won't go. So ejaculation is the end point for erection. Some people may lose the erection before also, particularly diabetics, because of the weakened cavernosal tissue and nervous supply. Then you have opium, again quite common in practice. We get these opium consumers, the delayed ejaculation make them intake a lot of opium, and eventually that leads to major erectile problems. Then you have cocaine. I have at least seen 3-4 cases where the patient not only experienced erectile dysfunction on long-term consumption, but they turned out to be sterile. They had 1 kid, now they are planning for 2nd kid, but because of cocaine, their FSH has shot up and they are sterile. And you have heroin, LSD and others. Now LSD is a very interesting drug which was discovered by a German chemist. I don't remember his name, but there is no other drug developed for sexual enhancement. At least the consumers of LSD have experienced some out of this world experiences with LSD. So, and it's the most powerful aphrodisiac ever created. Now coming to these various group of sexual enhancers or disruptors in the form of recreational drugs, if a man decides to consume or experiment with a single drug every day, there are more than 365 drugs available for all 365 drugs. So such is the desperation or as far as sex is concerned, it has captivated people's imagination. Then you have very important as a physician's drug history, antihypertensives like beta blockers, in that highest incidence of erectile dysfunction is seen with propranolol, and it is the most commonly and widely used beta blocker. Apart from its effect as an antihypertensive, it is as an anti-migraine, anti-anxiety and so many other indications. Then you have another group but not significant, alpha blockers like prazosin, the phentolamine, broad acting alpha blockers, not the selective ones like tamsulosin. They have less incidence of sexual difficulties. Then you have hydrochlorothiazide and chlorthalidone. Chlorthalidone, of course, high dose hydrochlorothiazide causes, it increases blood sugar levels, disruption in blood sugar levels. There is low androgens because of its anti-androgen effect, and raised triglycerides because of its effects on the lipid metabolism. But chlorthalidone, it's being marketed along with other drugs as a combination therapy, and that that is one of the major reasons which I have come across. And if you ask the patient or change the drug to a option which is less having less impact on the sexual functioning, then the patient improves. Chlorthalidone definitely, and it is a mismarketed product, plus, and very by and large it is true about all the drugs in India. There is a lot of underreporting as far as chlorthalidone is concerned. Then coming to antidepressants, most of the antidepressants have some or the other sexual dysfunction. The chance finding of SSRIs as a delayed ejaculation, one of the side effects of SSRIs is delayed ejaculation, and that led to use of or recommendation of SSRIs as one of the drug for premature ejaculation. Various drugs available in this group are depoxetine, paroxetine and Clonil. The brand name is Clonil. Content I am not remembering. So these are used as drugs for premature ejaculation. But In low dose, I would prefer. High dose definitely will cause some erectile difficulty. So SSRIs, even if you are advising to the patient, whatever the MR might be claiming, low dose to be preferred. And you can prefer as per your liking. Individual's liking is also there. I prefer paroxetine as a drug for premature ejaculation. Then you have antipsychotics, all of them, and most commonly with amisulpride, chlorpromazine, clozapine, and all these drugs, all the D2 blockers. I would like to emphasize risperidone and aripiprazole, everybody. But I would like to emphasize on amisulpride. Amisulpride is a very strong antipsychotic. It causes, it's commonly used by psychiatrists for severe psychosis. But the problem with amisulpride, it will control the psychosis, but it causes orgasmic dysfunction. The patient is not able to experience ejaculation. A couple of patients I had, one had not ejaculated for 8 years, and another patient had not ejaculated for 3 or 4 years. Then another group of drugs which is missing in the group is benzodiazepines like diazepam, alprazolam, clonazepam, clobazam, all these are benzodiazepines. Now I would like to emphasize on only one drug which I have come across. All of them cause in long term, but one drug, clonazepam, the recommendation as per the inventors of the drug is to be used for only 6 months to 1 year. Now what happens in India, they don't need prescription. Once the rapport is built with the medical guy, he will keep on giving the same drug. This particular patient, he was on clonazepam for 18 long years, and after 3-4 years of using clonazepam, he lost his erection, and he was not, and somehow one fine day the wife felt that sex has to happen. She brought the patient to me, and when I saw this, so clonazepam he was taking for years together. So this is how the drug history is so important. Then another area where anti-epileptics, particularly my experience with valproate long term, 5-year, 10-year, they present with erectile dysfunction. And the next group of drug is the anti-Parkinsonian drugs. Now this is very important and very interesting. One case I would like to share. A lady, 65-year-old, widow, she has a complete family, her kids are married, she is completely fine and everything, मतलब जो बोल सकते हैं जो चाहिए जिंदगी में वो सब है. But she said, sir, there is an irresistible desire to do sex and I just don't know what to do. Even after self-stimulation, I am not able to achieve the orgasm and the desire doesn't die. Then when I dwelled into the details of her medical history, she was taking anti-Parkinsonian drug, levodopa with carbidopa, for a long period of time. Now dopamine levels were increasing, and that the side effect of one of the side effects of these drugs is hypersexuality, increased desire for sex. Then you have antiretrovirals. Again, few cases I have come across where lamivudine, some antiretrovirals, they reduce B12 levels, so neuropathic EDs can be seen. Some increase triglyceride, so vascular ED can be seen. So hypolipidemic agents like statins, simvastatin and one more statin has been proven and reported to cause erectile dysfunction. And the information is available on the net. There are papers published. And atorvastatin and the companies, they claim that they don't cause, in fact they are beneficial in erectile dysfunction. I don't deny that they might be. But logic speaks this way: long-term ingestion of any hypolipidemic agent will reduce the cholesterol levels, and cholesterol is an important substrate in the production of hormones. Okay, there is no hormone without cholesterol. So naturally the androgen levels will go down and desire will be a problem in the long term, and that is what I have come across in my practice also. So proven long-term ingestion of statins, proven low testosterone levels that connects with the low desire levels. Then you have proton pump inhibitors. Short-term, any drugs, their long-term impact is, there are something called as post-marketing studies, which happen over 5 years, 10 years, 20 years. So post-marketing studies found out that esomeprazole and pantoprazole both cause erectile dysfunction. They are proven, and now they are in textbook also. So you have to be careful about drugs. And what I prefer is sometimes which drugs which need to be given over a long period of time, like antipsychotics or anti-epileptics. I advise them some 15 days, 1 month drug-free intervals, so that, but then again it is risky. You have to see, you have to assess the various aspects, or just write down to the treating neurologist, sir, kindly reduce the dose or change the drug with a favorable sexual side effect, like lamotrigine should be given in place of valproate. Then you have anti-androgens and gym supplements. Anti-androgens like the drugs for hair fall. Can anybody tell me which is the drug for hair fall? Finasteride. Very common, very underreported side effect. But in some cases, the effects of finasteride are irreversible. If the person experiences sexual difficulties, even if you stop finasteride, the difficulty is persist. Continue. Then coming to gym supplements. Gym supplements, again, big market, big industry. All these things cannot be spoken on social media. Very commonly used gym supplement, you are all aware probably, or might have heard, whey protein. Whey protein, the source of whey protein, most commonly the source of whey protein is soya bean. Now soya bean is known to increase estrogen E2 levels. It is known to cause sterility. Soya bean as a source of protein should be avoided by men. Even in women, if you see the physiology, there will be increased E2 levels. And that is one of the reasons, if you see all the milk supplements, for infant feeds, most of them are containing soya bean. Soya bean as a source of that protein. And we are giving to young kids. I have told my wife to stop advising these soya containing products to the kids. So that is why so much of hormonal imbalances you see in young kids, and I have no proofs to talk about it. I can just by logical correlation. If estrogen E2 levels have to rise, it has to act on the breast tissue, on the feminine fat deposition, and all those stuff. Then coming to family history, again, very important. So you have to assess diabetes, hypertension, cardiovascular, psychosis, neurosis, anxiety, personality disorder, infertility. Next, coming to clinical examination, apart from the routine TPR, BP, you can refine your practice with experience. Most of the times I don't do any of this temperature, pulse, respiratory rate. I definitely look for blood pressure if there is an history of blood pressure or a family history of blood pressure. So, and the related medications, because both medications as well as blood pressure cause erectile dysfunction. Then coming to systematic examination, you do abdomen, chest, gait, carrying angle, height, weight, depending on the presenting characteristics. If somebody is obese, I will ask for the weight. If somebody, comes for the parent bring the young baby, the kid, 10, 12-year-old, I look for carrying angle because there is no pubertal spurt of growth or pubertal spurt of hair growth. Then you have to see the gait, whether there is the gait is a normal, or there is a convergence, valgus, varus, and all that. Of course, breast is important, and I see the breast examination not in women but men, who give a history of gym supplement consumption and hormonal anabolic steroid injections. Now, I am in the last phase, so don't worry. General examination, you do the penile examination, which is very, very clear, and you do the penile examination, palpation, stretch length, girth, curvature, plaque, urethral opening, whether it is at the right, whether it is operated for hypospadiasis or epispadiasis, and circumcision. Coming to scrotum, you examine the scrotum, feel the testes, epididyma and vas deferens to rule out any epididymoarchitis or architis. Then coming to investigations, routine investigations, I don't advise any blanket packages, this package, that package, waste of time, of course the packages are not very expensive these days, but there is definitely a wastage of time because you have to go through all the reports. I don't advise them, but I advise very relevant and as per the need of the case. So these are the investigation which I use time to time. Routinely I advise blood sugar, whether I am looking for fasting, random or postprandial, then hemogram, particularly hemoglobin, and rule out microcytic or megaloblastic anemia, then lipid profile. Both have different management and implications, and lipid profile, particularly I am worried about high triglycerides and low HDL levels. Okay. Then urine routine microscopy, RFT, LFT, serum uric acid, special investigations, semen analysis, penile Doppler, nocturnal penile tumescence. Specific investigations, if I suspect strongly diabetes, I will go for HbA1c, and glucose tolerance test is the definitive test for ruling out pre-diabetes. Even pre-diabetes can cause erectile dysfunction, and it is the autonomic neuropathy is the earliest marker of diabetes. ECG, USG, CDD, CT, stress test, hormones. Coming to hormones, most commonly I will be advising testosterone, but in a case of infertility, FSH, in a case of sterility and hypogonadism, global hypogonadism, all others, DHEAs, estrogen E2, again those who are into gym supplements, I advise E2, prolactin and FSH-LH. Now management, psychosexual counseling is the cornerstone of any sexual dysfunction. Not only any sexual dysfunction, but in my opinion, any patient needs counseling, psychological counseling. Herbal preparations like L-arginine, ashwagandha, horny goat weed, fenugreek, ginseng, shilajit, safed musli and others. So many of them. Now somebody has spoken already in details. I'll just throw, these are the 5 PDE5 inhibitors which were launched at various times in the Indian market. First is sildenafil, the blockbuster drug known as Viagra. Then you have tadalafil. The advantage of tadalafil is that it has the longest half-life. So you can give as a chronic dosing, low dose. Then you have sildenafil, which has been taken out from the market, but it was the second most expensive drug after Viagra. Then you have vardenafil, which is very similar to sildenafil, except the headache side effect. Incidence of headache is less as per the claims of the launching company. Then you have avanafil, which has been recently launched, and my experience with avanafil is quite limited, so I will not be commenting on that. Now coming to intracavernous injections, which is one of the routinely practiced thing in my practice. Papaverine, chlorpromazine, phentolamine, prostaglandin E1, phoscorlin and others are the drugs available. But commonly I use the first 4, papaverine, chlorpromazine, phentolamine and prostaglandin E1 in various combinations known as bimix, trimix, concentrated trimix or cord mix. Then combination therapy, you can give a low dose long-acting long-acting phosphodiesterase inhibitor like tadalafil, and on demand you can give a short-acting like sildenafil. Then you have intracavernous injection, and it can be combined with, to reduce the dose required in intracavernous therapy, I give an on-demand sildenafil, which sort of primes up the penile erection and then inject, and a very low dose also produces significantly good erection, and it is helpful in diabetics who will need this treatment over a long period of time, because there is something called as tachyphylaxis, same drug, same dosage, eventually there will be no response. So the lowest possible dose you start with, the better, and long-term usage for the patient. Then you have vacuum erection device, penile implant surgery, penile transplant, and dorsal neurectomy, which is been advised for premature ejaculation. And there are various other surgical options for premature ejaculation, they are claimed, but definitive outcomes, very limited knowledge is there. Thank you. Yeah.
And more than amisulfuride, in practice, what we see is it is the levosulfuride which is most commonly used and abused as well. I will add to that. You might have heard tablet L, pan L, it contains levosulfuride. And levosulfuride is just the
levo isomer of the active drug.
Has hormonal as well as sexual impacts on the patients. Now it's dice is open for the patients.
Regarding, you didn't mention about domperidone and metoclopramide.
There are, I will tell you, if I put the entire list, we will stop practicing. More than 50, so many common drugs are causing sexual problems. Yes. Antiemetics, and particularly domperidone and metoclopramide. I have not mentioned that. Yeah. Yes. Because of its effect on prolactin and hyperprolactinemia, and that results in sexual difficulties. 100%. Yeah, sure. Warfarin is commonly, if I am correct, it is commonly advised in post-CABG patients, not in all patients. And post-CABG patients, in my 12 years of practice, I have maybe not more than 15 or 20 patients. And they are so worried about living that they forget having sex. But they want to have sex. But because of their heart, ejection fraction, so many other parameters, I am worried why I should give sildenafil and land up myself in trouble. I will lose my erection. Yeah, drug interaction, one thing. Nitroglycerin it should be avoided, which was mentioned, but alpha blockers along with PDE5 inhibitors also should be avoided. That leads to lower, falling of blood pressure and might lead to collapse also. See, they might work in psychological cases. They might, I don't say that they don't work. Ashwagandha, I myself has conducted a double-blind clinical, randomized double-blind controlled trial. I am just awaiting its publication. So they definitely help, they definitely act, but they cannot work like sildenafil or tadalafil. Okay. Means quality of sperm or quality of oocyte. There was one study, good question. There was one study where these drugs for premature ejaculation, they had an effect on the sperm motility, So when you are dealing with sexual dysfunction patient with primary infertility and compromised seminal parameters, you avoid these SSRIs for premature ejaculation. They cause some effect on motility. They reduce the motility. And then only I feel you will be able to do justice to your patient. Penile color Doppler, some people say we have to do it. The renowned people say. Some people prefer it being done by a very experienced person who understands the end diastolic flow and the relevance in the erection. And my personal opinion, I don't advise penile Doppler. I feel it's a waste of time. I use a vascular Doppler and see if there is a blood flow or not in the penis.
We can go for the pudendal artery stenting also, that or ballooning. That
Again, it's a very experimental, and the problem with pudendal artery stenting, the stenting is developed for a coronary artery, which is 6 to 8 millimeter. Pudendal artery is hardly 2 millimeter.
we can do the balloon. If we do that ballooning, the atherosclerotic plaque will rupture and it will increase the flow across it.
Yeah, not there in the pudendal artery, but dorsal artery of penis, the flow might increase. But again, this is a lot of controversial. The cardiologist want this to be done, but there is no definitive outcomes. Patient benefits should be paramount. What positive, you charge whatever you want, but what positive outcome you are giving to the patient, you have to be honest with that.
Thank you very much, Dr. Amit Mutha. I would now like to invite Dr. Ashish Kumar Doshi, GM Sales and Marketing Head, VishwaRaj Hospital, to felicitate Dr. Amit Mutha. I request Dr. Doshi to felicitate our chairpersons, Dr. Kalpana Khade. I now request Dr. Doshi to felicitate next chairperson, Dr. Manik Vijay. our speaker and chairpersons. I now hand over the mic to Dr. Mahesh to continue the session.
Sorry. All well, sir. Yes.
After an engrossing lecture by Dr. Amit Mutha, we move on to the next lecture, which is erectile dysfunction PDE5 inhibitors to penile implants. I request Dr. Anand Railkar sir to chair this session. Sir is a senior general surgeon and an obs, also practices obs and gynecology, and has done thousands of deliveries with a very less LSCS rate. I request sir to introduce our speaker for today, Dr. Ashish Pardeshi.
Good morning, everybody. It's an honor to introduce Dr. Pardeshi. He is a DNB urology in December 2008 from Jaslok. Post DNB, he has played various roles in renowned institutes like KM Hospital, Ruby Hall, Jahangir. He is currently founder director of Kidney and Urology Super Specialty Institute, Pune. He is registered as renal transplant surgeon as VishwaRaj, Jahangir and Apollo Hospitals. He is holding membership of Urological Society of India, European Association of Urology, American Urology Association, National Academy of Medical Sciences. He has presented more than 15 papers and publications in national, international journals also. He has special interest in academic, has attended more than 25 national and international workshops. He is having special interest in renal transplant surgery and reconstructive urology. And I personally know how patients admire him when they come back to me from his clinic.
Good afternoon, ladies and gentlemen, my senior colleagues. It's a great honor to be introduced by Dr. Railkar. We all know him. Thank you very much, sir, for this honor. Today, we are going to talk on erectile dysfunction, PDE5 inhibitors to penile implants. It's a very big spectrum actually to cover in one lecture. But erectile dysfunction as an entity is misunderstood by many. Why? Because this is the only problem where the person comes with a diagnosis in his mouth today, in today's world. Patient will never come, I have typhoid, I have COVID, I have cancer. But patient will come and first tell you, sir, what is your problem? Sir, I am suffering from ED. That's what the today's era is. Without knowing what actually he has, and he is making a self-diagnosis of erectile dysfunction. So erectile dysfunction is not a disease, it's actually a situation which bothers most of men today. And we are going to just clear our concepts. I'm not going to give you any specific guideline or algorithm or make this lecture boring. But I want we all doctors to understand how to approach and guide a patient of so-called erectile dysfunction. So as Tolstoy has said, man survives earthquakes, experiences the horrors of illness and all the tortures of the soul. But the most tormenting tragedy of all times, and it will be the tragedy of the bedroom, because that is where the man's confidence is actually put to test, and where he fails very terribly. This is what is called as a paradox. This is a small cartoon which tells us how a man's brain is. It's very ironical that a man's typical brain, they say, thinks about sex every 7 minutes. But most of the men, why do they suffer from erectile dysfunction? When they think about it so much, but still they're not good at it or they fail, that is a paradox. What is the reality? The reality is these two peaks of times which have to match during this activity which is called as sexual intercourse. And there is always a mismatch between the peak of a man, which is earlier, and a peak of a female, which probably is never understood. So do I have to live with ED all my life? The answer is no. Every man can be treated successfully today for ED. It is very frustrating and devastating, as we already know. We all know the normal sexual response cycle in men. It's arousal. There is a plateau after that arousal. There's an orgasm. There's resolution. And there is a refractory period before we start another activity. So what is the definition? Inability to maintain an erection firm enough for intercourse. So if you can have erectile dysfunction, if you can sometimes get, not always, can get but doesn't last enough, or do not get it at all. So all these three entities actually are named as ED. Therefore, I don't call it a disease, it's actually a situation. But we need to understand that it is a couple disorder. It is not a disorder only of one man. It's an activity of two people, okay? And it is a disorder affecting two people. This is the most important part we need to understand, so that when we counsel people, we need to have the other side also to understand and to treat the patient better. So when we say it's a couple, there is a problem in this couple. The couple has a different psychological view about this activity. Okay, this is a small thing which tells us women need a reason, men need a place, which is probably very true, because men have a different perspective of intercourse. Sometimes women might have different, and this might also cause a problem, which is also labeled as erectile dysfunction, which is not. Okay. Is there a measure? A lot of people will come to you today as a sexual specialist, and many will agree, sir, the court wants to know, my father-in-law wants to know, my family wants to know whether I'm potent or not potent. The wife is accusing my husband of telling that he is not sexually competent. So is there a measure? We don't know about if there is a measure or no. The main causes of erectile dysfunction are vasculogenic causes. There are other causes also, like pharmacologic, people taking beta blockers, post-operative endocrinologic, neurologics like stroke or trauma. But most of the people will come to us with what's called as misconception in today's informative era. They do not know what they are doing. They have nobody to talk to. They don't know what they are supposed to do. And most important, they do not know whom to approach if they have a problem. So in today's era, the 21st century young man does not know more about it, or is completely misled with the information which is being thrown upon by the media and the internet. So we all know about the routine treatment, basic treatment actually. Therefore, we define ED as a situation. Most of them, it is not pathologic. So most of the times, these things will usually give a relief, like sexual counseling, patient education, raising the confidence of patients. These are the basic things where common people with so-called erectile dysfunction, who don't actually have dysfunction, can be treated. You have to drive the partner into the treatment. That's the most important part here. We forget the partner, we keep on treating the man, and sometimes it might not give us the desired result. So you have to involve the opposite partner, tell her to raise the confidence of the man, which is usually the problem. Oral medications and combination of all these. We all know about medical therapy. There are a lot of drugs which are available. The latest one being an avanafil, which has to be given 15 minutes. And there are proper preconditions to these medications. You have to take before food, you have to take at this time, you have to remember to take it, you have to carry it along with you. So these medications, apart from the pharmacologic side effect they have a lot of apprehensive problems, because what is called as a performance anxiety. Okay, so these medications probably will work with very few people. Most of them will have problems with them. Other issues like vitamin B12 correction and associated disorders needs to be looked upon. There are various other medical treatments in the market, but we don't know how, where, and when to give these medications. The routine problems with oral medications is, as I said, on-demand apprehension. People are not very comfortable taking medications before. There is a lot of interference with food, a lot of side effects. Most of my patients stop these medications because of extreme side effects like body ache, backache, blurring of vision. The cost treatment was initially a part. Now the cost treatment has become, cost factor has become better. There is a factor of addiction that people think that I won't be able to, I am paralyzed, I won't be able to have intercourse without these medications, and that drives them more down. There's always a fear of being occasionally fatal. There were incidences of fatalities, we all know, and some complications like priapism, which can render you completely erectile defunct for your life. So when all these factors of lifestyle change and medication fails, we term this entity as refractory erectile dysfunction. That is what we call as true erectile dysfunction, where there is an organic cause for the problem. So when we say refractory, it means not responding to routine advice and medications. What are the causes? Atherosclerosis is the commonest, long-standing diabetes, major pelvic surgery, radiation, spinal, neuro and pelvic trauma, and recurrent penile surgery. In my practice, most of the ED patients are because of there are recurrent failed penile surgeries. So what are the options? Shockwave therapy, which is going to be talked upon later, intracorporeal injection of vasoactive agents, vacuum erection device, and penile implants. So the shockwave treatment is going to be talked by Dr. Shimpi, I suppose, later. We need to just consider ICIVAD, that is before intercourse, we inject medicines into the corpora cavernosa, either by the partner or by the patient himself, to achieve an erection. Now these medications have a combination, number one, to create an erection, and second, to avoid complication of that drug, to prolong it. So there are various mixes, and we need to understand that when you give this injection by a small syringe, which is usually an insulin syringe, we have to have a pressure at the point after the injection because it can cause an hematoma, and we have to look for prolonged erection or priapism. This is how the partner or the person gives the injection intracorporally about 15 minutes before the sexual activity, and you get a good erection. The injection has to be properly into the corpora. The patient has to be educated about the urethra and the corpora and the site where it has to be given. Okay. So there are various preparations like papaverine or other like phentolamine and chlorpromazine, which is called as a biomix, and papaverine, pentolamine with prostaglandin E2. All these are available in the market and they are very good. But the problems with the advantages of this are that it gives a man a hope. The moment you inject papaverine in his penis, the man sees his erection and he gains that confidence. Okay, it is very simple to administer, and it is safe if it is done as instructed. It solves the issue of premature ejaculation also, because this injection works for a longer time. It will take that action even after ejaculation to continue sexual activity, and it restores sexual function naturally. Okay. The various complications with these injections like priapism, which is the worst complication, local hematoma formation, corporal fibrosis because of recurrent injections into the corpora, and sometimes urethral injury. Other devices are there which are called vacuum erection device, which is going to be spoken later. And there are a lot of problems with the VED also, which will be dealt. When all this fails, we actually have only few options for this problem. Okay. So what is the best option now is what is called as a penile implant. Okay. The penile implant are usually cylinders which are placed inside the corpora cavernosa for achieving an erection into a man who desires to have sex but cannot have an erection because of organic problems. So this was a study which was done in 2003, which showed that the penile implant had a 93% satisfaction rate as compared to other modalities of treatment. So this is how an implant works. So there are malleable implants which are rigid, and there are semi-malleable implants which are activated with a pump. Okay, so there are three types. So the malleable is a non-inflatable rod which stays inside the penis and gives an erection which is sustained. Okay. Second, with a two-piece inflatable implant, where there is a reservoir and there is a cylinder which fills on demand. So we have tumescence and non-tumescence at choice. Then there's a three-piece implant, usually for longer penises and to achieve a larger girth. So this is called as a three-piece implant. So differences, as I told you, are these two. The malleable implant has now come up with a hinge at the pubic angle so that it can be concealed inside the undercloth so that it is not seen. So this is how it looks like. This is an Argentinian implant which has a silicone covering with a metallic rod inside. It can be bent into the shape we want it and whenever we want it, and it is very easy to implant. So the inflatable penile prosthesis achieve a natural erection and detumescence. It's a very good implant, and the deflation which causes complete detumescence, okay? And it gives a near natural fear of sexual activity. This is the actual implant by the AMS company from America which makes this implant. It's a very good implant. It costs about 8 to 9 lakh rupees, and the surgical cost total comes about to 12 to 13 lakh rupees. But this has a reservoir which when pumped inflates the implant and gives a natural erection. So there's another company called as Coloplast which makes a 3-piece implant for achieving larger girth of the penis. So 1-piece non-inflatable penile implant, the problem is that it stays firm even though you don't want it to be. So it has a 24-hour firmness, and sometimes it becomes a problem, and it may show through the clothing, okay? But the advantage is that it is less expensive and it can be affordable by everybody. The problem in India today is penile implant is still considered as a cosmetic surgery and still not paid by insurance companies. We are trying to get through them, but it is very difficult to convince them to make this available through insurance companies. And that's the biggest hindrance in our practice to tell patient that to apply an implant for himself. The 2-piece inflatable is the best implant. It gives a natural erection, natural facility, and it can be concealed very well. But the problem with these manual implants is that it has a button which is kept in the scrotum which has to be pumped, and it requires a good person. For example, I have patients who are paralyzed. They cannot actually inflate this implant by themselves. They need an assistant to do that. The advantages of a 3-piece implant are same, but as I told you, it achieves better girth. The problem is that it is too mechanical, and it can have mechanical issues later, like the reservoir getting blocked or getting leaked. So this is how an inflatable implant looks after what is called as deactivation activation. So in a deactivation mode, the penis is flaccid, and as you press the pump, and you can have a choice of how much rigid to make it, and it becomes more firmer on further pumping. So this is how it actually looks like. There is a detumescence and a tumescent state after an inflatable. So what do we do for Indian patients? Indian patient cannot afford, looking at the price of 15 lakh rupees, they will say, no, it's okay that we do not have sex, or whatever erection they have, they might lose that also after listening to 15 lakh rupees. So we have Professor and my mentor, Dr. Rupin Shah from Lilavati Hospital. He introduced this implant in India, which cost about 20,000 rupees. It's a malleable implant, and it is very easy to fix. I've been doing this day in and day out with patients, and patients are very happy with this implant. So this is how it is fitted. There is a penoscrotal incision, and on the penoscrotal incision, we opened the corpora and fit this implant. Recently, this implant has come with an innovation of a hinge, which can be concealed very well, which I'll show in this video. So this is a video which will show you. ये क्या हो गया? Okay. Okay, fine. So this is how the implant is. If you see, the implant is fitted, it has a hinge which conceals it in the underclothes, and whenever the sexual activity has to happen, it will become rigid. So this is one of the best implants, very affordable. The total cost of surgery is about a couple of lakhs, and patients are very happy. This is a patient who had rectal cancer, was operated for anal surgery, and there was a denervation, and he had complete erectile dysfunction. After surgery, he is now having a natural intercourse. But there are a few complications of these rigid implants. There are infection. Infection is the worst complication. We have to take out the implant on the same day of implantation if there is infection, or immediately when the infection happens. There is no treatment for it, then you have to wait and put a new implant. Putting a new implant in an infected state is very challenging because there is immense corporal fibrosis, and drilling into the corpora becomes very difficult. There are chances of extrusion. If you see, this implant has been extruded through this is an artificial penis which was made in a sex change surgery where these implants are maximally used actually. And this is an extrusion because of a wrong placement of the implant. The implant can just perforate through the glands. It can get migrated. There can be mechanical problems. And there can be what is called as a crossover, where the implant will run over each other inside the corpora. One more important disease which causes organic erectile dysfunction is Peyronie disease, where there is a plaque in the penis, and this plaque will cause an acute bend in the penis. Okay, so in these cases we have to, there are various stages of this Peyronie disease where we have to understand where we might treat it. In the last stage, when there is a plaque which develops, we have to take out the plaque and do what is called as a corporoplasty, and this surgery is associated with a lot of erectile dysfunction, and they need to be treated sometimes with an implant also. One important aspect is penile fracture, which causes permanent erectile dysfunction if not treated in time, especially both the corpora are involved. The treatment needs to be done very effectively and in less amount of time, preferably within 6 hours of the fracture, so that patients are not rendered completely erectile defunct for life. Okay, it's a very challenging situation. Most of these people will require an implant. Priapism. Now, why I have mentioned priapism here? Because priapism is a disorder which is very complex to treat, and if not treated well by the concerned urologist, it might cause permanent corporal fibrosis in the man and having no chance of sexual activity in the future, because the corpora becomes completely wood-like, and even putting an implant into these patients can be a challenge. So this is what is priapism. It was described by Priapus, which is supposed to be the god of fertility. Okay, it's a very dreadful situation. Sometimes it can cause what is called as penile necrosis also, and we have to amputate the penis in very severe cases. Basically, there is an imbalance between the inflow and the outflow during erection, during priapism, and it is divided into two types, low flow and high flow types. High flow is usually where the arterial blood flow is too immense, and low flow is where there is venous obstruction. So we have to first diagnose which type it is, and accordingly we treat it by creating artificial shunts to let out the blood from the corpora into the spongiosa or into the saphenous vein. So this is how we treat a patient of priapism. We inject a bigger needle size which will drain out all the deoxygenated blood from the penis. Now this has to be done within 3 to 4 hours of priapism. If not, then it becomes a big problem. Okay, long-term effects, as I told you, penile fibrosis, penile gangrene, and sometimes they can have recurrent priapism, okay? And it very complicates the penile implant very badly. So this is the only situation where, as I told, treatment is very, very difficult. So what is the role of doctors? We need to understand this. When a person comes to you with erectile dysfunction, number one, we are supposed to guide him so well that he does not lose his confidence further, number one. Do not just randomly prescribe medications or do investigations. We need to talk to them. We need to promote sex education in people. We need to refer a patient to the right person, actually. We need to emphasize the importance of diet and exercise, and we have to give right treatment. So sex is deeper than a few inches of penetration. It is a mental thing, a soul dance. Make the mind lose it and the body to follow. So this is an important advice what I give to my patient, that sex is not planned. It has to follow a bond which is soulful. Okay? So a man can enjoy sexual life till he is alive. Thank you very much.
This was an excellent presentation from simplest thing to the most advanced surgical treatment. I really congratulate you. It was wonderful.
Thank you, sir. Thank you. Any questions are there? Can you ask? Any question?
Actually, for lung fibrosis, we are using anti-fibrotic agents. So whether they could be of
Yes, sir.
lung fibrosis, we are using anti-fibrotic agents.
Like?
Like Vijay, etc.
Which one? Excuse me? Okay, no, we are not using it here. No, this fibrosis is actually the spongy fibrosis actually. Once it happens, nobody can do anything for it because the spongy tissue is lost. It's like a sponge which is dried into the sun and nothing can be done for it actually.
It is also like a spot.
Yeah, yeah.
So can I know your question? What is it?
His question, I'll tell you, his question was that, as I told, the penile fibrosis, corporal fibrosis is a difficult situation to treat. Sir was asking ki whether, like, they use some medications for pulmonary fibrosis actually. Indapamine, no? Indapamine you said? Indetanib. What is that but? Antifibrotic, like a steroid?
Not a steroid.
Well, I am hearing this for the first time.
Yeah, because I am a pharmacology associate professor.
There you go. So त्यांना सांगा काय ड्रग कुठला आहे ते. We can do some research on that, sir, surely.
And sir, I would like to ask you a couple of. So, what is the typical number of canal implants you do in a year?
About in my practice, about 8 to 10 implants in a year.
And what is the number of SHA implant and 2-piece and 3-piece?
3-piece we don't do it in India because most of the people are not interested in girth. 2-piece implant, the ratio is about 2 implants to 10 implants. 10 implants are SHA implants to 2 implants of AMS Ambicor.
Okay, and that the criteria for going the implant is?
Patient's choice. Monitoring and patient's choice basically.
Patients are choosing SHA.
See, in India, the basic factor which drives implants is cost. Nothing else. Nothing else.
And sir, what is the typical number of priapism you come across in your practice?
Priapism, I have at least 2 patients in a year actually. If I take an average of my 10-year practice, 2 patients. I recently got a child actually. He was 11 years old. He was shifted from Nagar. No, we did all the investigations. Nothing. Surprisingly, what was the problem? He had severe phimosis, okay, and he had a lot of sphygma collection inside. At night, probably tried to scratch very badly, and there he had an erection, and he recurrently did that, and he came actually 24 hours after the priapism happened. But unfortunately, we had to actually inject pseudoephedrine to get tumescence because the tumescence was not happening with normal letting out of blood. Yeah.
20 times diluted phenylephrine.
Phenylephrine or pseudoephedrine also is. I prefer pseudoephedrine actually to phenylephrine. Yeah, it is available. Pseudoephedrine is now available actually. Earlier it was not available.
And the incidence
Namaste, sir.
of priapism, I mean, what you said is 2 in a year.
Yes.
Any ICIVAD induced priapism you encounter?
Yes, there are ICIVAD, specifically in only papaverine injections.
Yeah, and I think this ICIVAD is being done by pro people thinking that it is some magic.
No, it is not
They are actually not understanding the gravity of the situation and what the patient might end up and be experiencing with priapism.
Absolutely.
So when ICVD is being advised, I feel we should advise the people who are practicing this to use it with a due caution.
Cut a long story short, we have to select that patient who is right for ICVA.
You said the smegma collection in 11-year-old boy. Does this pre-puberty boy have that significant smegma secretions?
Yeah, the problem was, I have a video also if I want to show it to you. He had severe phimosis, no? Severe phimosis.
Got it.
Smegma doesn't only contain semen. Smegma contains dead cells, okay, epithelial cells, sweat, and urine products. Okay, that all can cause the electrolytes in urine. They can cause significant amount of smegma. He has lot of. So when I did his circumcision later, I was very surprised to see that smegma collection around.
Yes. Those are, kind of a cheesy substance, and you can call them as smegma plith also. They are like hard, stony also they become. But pre-puberty boy is a relatively rare occurrence, I think.
The smegma?
Yeah.
Okay. But in this patient, there was nothing else to suggest. We dug into his family history. His father has a minor thalassemia, minor trait, but apart from that, nothing else.
Did you find that drug, antifibrotic, sir? There is a basic difference between the lung alveolus tissue and the cavernosal tissue of the penis. So that anatomical difference makes the whole difference that the drugs may not be useful for the cavernosal fibrosis.
Sir wants to say something, and this sir wants to say something.
One, there are blood clots.
Yes, yes. Yendra sir wants to say something.
Very informative talk.
Thank you, sir.
I want to comment and a question. The comment is that ever since we started using phentolamine along with papaverine, the dose of papaverine which we have to use is so small.
Absolutely right.
That the chance of paraplegia is almost nil.
I agree. I agree.
But we are a very tiny dose, 7 or 8 milligrams.
This is a very important information which sir is giving actually, the biomix where...
Before that time, I think papaverine used to be given 20 milligrams, 45, 20 milligrams. And that, with that,
I agree.
I think the chance of
Yes, sir.
paraplegia was very, very high. Number one, you mentioned in one of your slides that ischemic ED is the vascular aneurism combination. What we see today in our practice, young men, 25 to 40, severe ED symptoms associated with performance anxiety. And I think these are the people which are getting more common in practice today than the elderly people who are organic
Yes.
because of vascular.
I agree, sir. I agree. Very well. Good point, sir.
And I think this is a good point about prosthesis. Would you consider prosthesis in the severe case of psychogenic impotence?
Psychogenic importance, no, sir. We won't be able to counsel the patient for this purpose. I have a couple of people with severe psychogenic importance, and to my surprise, it is the partner who did not allow me for the implant or any surgical intervention in him. Because this patient was, when I say we need to first label, now this patient who was an army colonel, okay, who was so psychogenic that he used to drive his wife back to his home in the middle of a cinema and say he wants to have sex now. So she was actually very troubled with him. So he was very psychologically unstable as far as sex is concerned. And he wanted an implant. He was wanted to get treated for his erectile dysfunction, because when he used to go back to the bedroom, he used to find that he couldn't get an erection. So then the partner herself told that we do not want any such treatment for him. So I would not allow any implantation for a psychosexually.
Sir, very good. I mean, the approach you have, because of late in last 8 to 9 months, I have at least 3 to 4 cases of young men, age group 22 to 28. They have some element of psychological ED. They're perfectly normal, but they somehow, for some reason, they were not responding. And 2 of them were gym supplement.
I understand, yes.
And they were advised straight away penile implant by somebody in Bangalore, somebody in Pune, somebody in Mumbai.
I agree.
But when I figured out and took the proper entire history and changed the gym thing and all these things, and his hormonal disruption was taken care of, the patient responded to intracavernous injections. He started having good erections, good sex. Then slowly I put him on oral medication, to which he was not responding. They started responding to those medicines, tadalafil and sildenafil. And now, over a period of 3 to 4, 5 months, now they are having sex without any medicines with full confidence. So anybody advising penile implant, and particularly in the psychological cases, I don't think that's the right way. That should be the last option, because the identity of any male is experiencing the early morning erection. With penile implant, that entire experience is going out for this young man who is going to live for another 30, 40, 50 years.
I agree.
So penile implant should be with due caution for young psychological cases, and I would say not advised only unless it is a proven vascular leak case.
Absolutely. And of course the advice of a treating psychiatrist also.
Yeah.
Thank you very much. Thank you, Railkar sir.
Thank you, Dr. Ashish, for such an excellent lecture. I now invite our GM Operations, Mr. Sudhir Uttam sir, to come on the stage and felicitate Dr. Ashish Pardeshi.
I'm sorry, I just had a ligament injury actually. Thank you. Thank you guys. Thank you. No problem. Thank you so much. Thank you. It's okay. Thank you. Thank you. Thank you, Mahesh.
I request Mr. Sudhiruttam sir to felicitate our chairperson for the session, Dr. Anand Railkar sir.
Thank you.
Dr. Dhangar sir to come and carry on the further proceedings.
Let's continue with the next session. I would like to invite chairpersons for the next session. Dr. Pratibha Vanve, kindly come on the dais. Dr. Pratibha Vanve. She is a senior consultant obstetric and gynecologist at the Krishna Accidental Maternity Hospital, Indapur. I would like to call upon next chairperson for the session, Dr. Vikram Patil. He is gastrologist at VishwaRaj Hospital. I request chairpersons to introduce our next speaker, Dr. Shirish Yande.
Good afternoon, everyone. It's my privilege to invite Dr. Shirish Yande sir, who is a consultant urologist and director of academics in Ruby Hall Clinic, Pune. So we all know about him, but just to introduce in short, he has performed over 1,500 renal transplant and has experience in both live and cadaveric donor transplants. He runs an exclusive urodynamic laboratory in Pune, where he performs and reports an average of 1,000 cases every year. He has special interest in functional urology. Urinary incontinence is a field of his special interest and has developed expertise in evaluation and management of his condition with a unique zeal. He is a keen teacher at all levels of medical fraternity and is recognized professor of National Board of Examinations, Delhi, for the faculty of genitourinary surgery. He has managed about 25 postgraduate teaching department in Ruby Hall Clinic in the capacity of Director of Academics. He has been Secretary and President of Urological Society of India West Zone and has organized a number of urological meetings and workshops for his colleagues and doctor in training of national, zonal and city levels. He is an avid student of technology. His recent venture in learning robotic surgery has also stems from his interest in technology. He has an immense love for music. He continues to be a serious student of world music, which he thinks has changed his life in many ways. Sir, you can start.
This is good enough. Thank you very much. I'm very much obliged. It's an honor to be invited by VishwaRaj Institution. It's my first time here. It's quite impressive setup. Am I heard well? Yeah, okay. And when I was talking to Sanjay Dhangar, my colleague, I wasn't sure what kind of a crowd I'm going to get. And knowing that so much of interest in sexual medicine, I think I have. Hey, where is my pointer? Yeah, but I have the pointer, but change of slide. Can you show me the change of slide? मैं इकडे करू शकतो ना? Okay. बरं ठीक आहे करेक्ट. कुठे Okay. Okay, yeah, fine. So coming back to ejaculatory disorders, I was going to say that this is okay. कुठे खाली आहे का? मध्ये ओके. नाही पॉइंटर नको मला चेंज ऑफ स्लाइड पाहिजे. ओके ओके या. I think we need to understand the process of ejaculation. It involves closure of the bladder neck first. Then there is a process called seminal emission, and then there is a ejection of the semen. So these are three different processes which are involved. And if you actually look at the etiology and organization of ejaculation, you will find that this is quite good, this is quite complex phenomenon, because closure of bladder neck is entirely through the sympathetic pathway, lower thoracic and upper lumbar vertebrae, and that controls by its own outflow to the bladder neck fibers, whereas seminal emission is another sympathetic pathway induced, but it works through the seminal vesicles and ejaculatory duct contraction as well as prostatic muscle contraction, and that produces the emission, whereas ejection of semen is then organized by the relaxation of the external sphincter and the twitching contraction and the contraction of the bulbous spongious muscles, which expel the thing out, expel the semen out. So it's a very complex process, very well organized by three different neurological systems and pathways, and it is curiously combined with orgasm, which is an entirely different process, but which actually means they are pleasurable but twitching contraction of pelvic floor, which are actually controlled by the somatic nervous system and not by the autonomic, but it is wonderfully coordinated with the autonomic system. So this is how ejaculation, orgasm are located and organized in the body. And therefore, when you talk about any disorder of ejaculation, we do talk about different pathways and different injuries and different lesions of different levels that can produce ejaculatory disorders. But when you look at the ejaculation, you find the first thing to take over is actually secretion of bulbourethral glands, which is only about 2%. Then epididymal and the vas deferens, which mainly have the sperms in it, but it only amounts to about 3% of the ejaculatory volume. And then you have prostatic fluid and seminal vesical fluid, which are ejected through the ejaculatory ducts, which push the semen forward and which push the sperms forward, and that forms about 90% or 95% of the ejaculatory volume, and that is how it is organized. You form that the first, if you want to, when you do a withdrawal technique for contraception, then what we need to do is the first few drops of semen are the most important drops, because they are the ones which are rich in sperms. So this is something which you have to understand everything. Now, what are the ejaculatory disorders that we have come across? Anejaculation is no ejaculation at all. So these are again divided into two aspects. A psychogenic anejaculation, where there is a complete dyssynergia between orgasm and ejaculation, and the patient cannot ejaculate simply because of autonomic nervous system breakdown. Whereas spinal cord injury is a similar one, but that is non-psychogenic. But spinal cord injury is particularly the conus lesion and supraconus lesions, where the entire organization of the sympathetic outflow is deranged and therefore ejaculation, contraction of the seminal vesicles and ejaculatory ducts does not take place and can produce an ejaculation. Whereas retrograde ejaculation is different system altogether. Ejaculation does take place as normal, but some part of it is retrogradely injected back into the bladder, particularly after a transserous resection of prostate, where the bladder neck mechanism is completely deranged. You remember that the first thing to in the retrograde in the ejaculation is closure of bladder neck. If that cannot be affected effectively, then the entire semen can go back into the bladder. Diabetes, because of neuropathic reasons, multiple sclerosis are the similar reasons, and when they have the bladder neck dyskinesia or the bladder neck does not close appropriately, retrograde ejaculation can take place, and that can be diagnosed easily by following the post-coital or the post-ejaculatory, post-masturbatory semen which contains sperms. Premature ejaculation is a different system altogether. That's an ejaculatory disorder. The premature ejaculation can be divided into two: early orgasmic response, as Dr. Prakash Kothari has named it, where the patient is far too stimulated. Stimulation is so huge that the patient ejaculates very fast, and that usually is associated with orgasm. Whereas there is non-orgasmic ejaculation, so there is something wrong with the somatic nervous system where orgasm cannot be achieved, but ejaculation takes place, because there are two different pathways of execution, and therefore ejaculation can occur without orgasm in those cases, and that can also manifest as premature ejaculation. Then comes to a last group, which cause scanty or absent ejaculation. Alpha blocking drugs can produce. We always thought the alpha blockers like tamsulosin or silodosin always produce retrograde ejaculation, but that doesn't seem to be the case. They seem to paralyze the seminal vesicles and the prostatic smooth muscle in such a way that no emission takes place into the prostatic urethra, and that can lead to either scanty or no ejaculation at all. Bladder neck incisions, for obvious reasons which I mentioned earlier. If the bladder neck is wide open, then ejaculation can go inside, and patient may manifest as absent ejaculation. And obviously the other surgical causes, ejaculatory duct obstruction, which we will talk about a little later, but ejaculation due to obstruction, and simply because 95% of seminal volume is pushed through ejaculatory ducts. If ejaculatory ducts are obstructed completely, then there is no ejaculation or very, very scanty ejaculation. Now, this is an important understanding, because ejaculatory ducts actually enter the prostatic urethra somewhere there, and they open on either side of verumontanum, and there is a substantial amount of prostatic volume in front and above the ejaculatory duct, and the peripheral zone of prostate which comes below. And therefore this is important, because when we do ejaculation sparing surgery, or when you want to do an ejaculatory duct obstruction surgery, then this anatomy has to be taken into account very, very carefully, because you can actually, we're very close to bladder neck mechanism and also to the external sphincter, striated sphincter mechanism when operating in this area. Let us see how we go about. So this is the area we talk about. The seminal vesicles and ejaculatory ducts form one single tube, which are called ejaculatory ducts, and these are the ducts which run through the posterior aspect of the prostatic urethra and open on either side of the verumontanum, which are, so all our urologist colleagues are very aware of this ejaculatory ducts openings, which we see every time you do a cystoscopy. Now etiologies are very many, but I will not go into this, because we are not in this crowd, we are not interested in knowing the etiology of various kinds. Presentation of ejaculatory obstruction is very, very important. Patient may not have any symptoms whatsoever, but patient may come with entirely with infertility. And if you can say patient infertility, patient with ED obstruction have normal examination findings of genitalia and normal secondary sexual characters. Seminal vesicles might be palpable digital examination, but prostate epididymal tenderness might be elicited. But there will be marked dilatation of epididymal heads, but that is not a very, very common feature. What's important in the diagnosis of ejaculatory duct obstruction is at least one vas is palpable. There is a low semen volume, usually less than 0.1 ml, and this should be consistently so. patient, the seminal pH is acidic, normally it is alkaline above 7.5, and this is less than 6. Low fructose in semen. Semen is quantitatively estimated by majority of enterological pathologists today, and therefore you can know the low fructose in semen is also pathognomonic of ejaculatory obstruction. And of course, TRUS is the key. TRUS means transrectal ultrasound. If you do, as you say, a complete obstruction associated with low ejaculatory volume, absent sperm count, because no sperms coming through this epididymis reaching the prostate, sperm motility obviously not questioned, and ejaculatory fructose is absent, and that can be qualitatively measured to be absent. Okay. Now this is a transrectal ultrasound, very, very important investigation. You can see this is the probe here, and you can easily spot a dilated seminal vesicle or a dilated ejaculatory duct above the prostate, and you can see this can actually be probed using a Chiba needle. Chiba needle is a very atraumatic needle which we use for various purposes in urology today under under ultrasound guidance, and you can actually puncture a dilated seminal vesicle or a dilated ejaculatory duct, cyst, and aspirate sperms, and can be sent for microscopic examination. If it contains sperms, then you may know that the obstruction exists only at the level of ejaculatory duct joining the prostatic urethra, in which case surgical treatment of opening of ejaculatory duct is going to be completely successful. But if you find no sperms, or very few sperms, then obstruction probably exists proximal to ejaculatory ducts, and therefore you may have to go for a IVF or a ICSI in that case, and no counter surgery is going to be useful except for epididymovasostomy, which also has a fairly low success rate. So anyway, you can do a vasography, not very commonly done today in urological practice, but we have done it a large number of times. You just cannulate the vas, put in a tiny catheter into that, and inject the contrast, and you can see dilated seminal vesicle and ejaculatory duct before the contrast enters the bladder. And that's a very, very useful diagnostic test to diagnose ejaculatory obstruction, which is surgically correctable. If you see such a huge, massive dilatation of ejaculatory ducts and the seminal vesicles, then surgical correction is indicated, and it has a much higher success rate. Yeah. You can, of course, inject methylene blue, and then you can do a cystoscopy and find out this blue occurs into the cystic areas transparently seen through the cyst wall, and once you open this cyst, you see the seminal volume, seminal fluid coming out of that, and you can deroof the cyst properly. You can get a fairly good issue of the semen as well as sperms, and patient can turn fertile if ejaculatory obstruction occurs there. Okay, so when you do a transurethral resection of ejaculatory ducts, some things have to be followed. Number one, must understand where the ejaculatory ducts are located. They're located up here from the bladder neck to the verumontanum. Mind the verumontanum is situated with the middle of the prostate in most young men, whereas we urologists are used to see large prostate patients where verumontanum is pushed down somewhere here, but verumontanum is usually here, and therefore your resection has to be above the verumontanum in order to deroof the ejaculatory duct. So the area that you want to see is somewhere here. So if this is the principle of ejaculatory ducts, this is the area that needs to be resected here in order to open. If the time permits, I'll show you a small video which shows how it is being done. But obviously, this is the area to it. Let's just see if I can see the video there. I don't know whether the video will be running. If it runs well, it's good. If it doesn't run, we'll call it a day. Anyway, I'll just finish my initial talk for the time being. Can I go back? I'll go back a little bit. Yeah. So this is the area that you have to observe. Now, there is some part. If you can manage to open up this area well, you can open up the ejaculatory ducts, but you have to deroof them adequately. You have to deroof them adequately in order to make sure that all the fluid comes out, and this fluid can ultimately contain sperms and make a patient fertile. If you cannot do it, then obviously obstruction exists proximal to ejaculatory duct, and therefore the treatment would be to do a microscopic aspiration of the fluid, epididymal fluid, and then you can do a testicular sperm extraction or a microscopic aspiration of epididymal fluid and use it for cryopreservation for subsequent use of in vitro fertilization or intracytoplasmic sperm injection or ICSI. That is the best way to go about. Yeah. When you come to this, just one small point before I finish. There is a lot of number of patients today coming with bladder neck dyssynergia or bladder neck obstruction. They're young individuals. They are not even married. And if they're married, they haven't proven their fertility. And these are the patients on whom we need to do a bladder neck incision. If we do an incision, we're likely to give them either retrograde ejaculation or you're likely to damage ejaculatory ducts and you'll give you a complete infertility. So in order to avoid that, we have in our technique, which is called ejaculation sparing bladder neck incision. And as I said, if you just restrict yourself to this area of a bladder neck to the mid portion of posterior urethra, or bladder neck to the verumontanum, and then you can do the incision here and make sure you don't go deep enough and you do not produce, you don't do these are ducts. You do either more lateral or stay strictly in midline. Midline may not be safe. It is better to stick to lateral aspect. Go to about 1.5 centimeter, but don't go close to verumontanum. Don't go beyond verumontanum by any cause, otherwise you're likely to damage the ejaculatory ducts. So this is the principle of doing ejaculation sparing resection. We urologists are nowadays practicing this technique very commonly, counseling the patient that if this operation fails, he might still have a retrograde ejaculation, in which case we have to go for some kind of a assisted reproductive technology. But obviously, so far, we follow technique very carefully and meticulously. We can manage to do ejaculation sparing surgery in those cases. So, my dear friends, ejaculatory disorders are many. We need to know what kind of ejaculatory disorder we are dealing with. So understand the process. We have to do systematic evaluation to find the precise diagnosis, and we can offer them a targeted therapy to give them a complete satisfaction. Thank you very much.
Thank you, sir.
There was a topic discussed about laser surgery. What I could not show you the video for some reason, but what we do is we do ejaculatory duct incisions. I mean, obstructed is present in the cyst, and if you do an incision into that, after either injecting a dye like methylene blue, or you need not do that. If you can see the cyst carefully under ultrasound guidance, you can go ahead and make an incision and open it up and de-roof properly. This can be done by laser. Laser is nothing but a knife. So what you can do electrically, you can do using laser. It may be slightly more controlled, and there may be a better control of hemorrhage. But really speaking, hemorrhage has never been a problem, and we urologists are so used to doing these operations. So electrical incidence has no difference whatsoever in technique-wise in laser and this. So laser has no. Robotic, well, robot, what is robot? Robot is laparoscopy. Robot only controls laparoscopic arms more precisely, plus it gives you a better magnification. Apart from that, robot is not. So all laparoscopic surgery can be replaced with robot. In this ejaculatory duct obstruction, there is no role for laparoscopy, and therefore there is no role for robot. Yeah.
With this EDO resection, bladder neck is usually saved, or by and large it gets dissected so that the retrograde ejaculation can be a consequence.
The principle is you try and save the bladder neck. Right. Yeah, we try because we don't want him to have a retrograde ejaculation either. So we try and save the bladder neck. So I think the proximal point of your safety is bladder neck, and distal point is the sphincter. So you do a resection entirely between these 2 points and try and de-roof this cyst as much as possible.
And in the common surgery like TURP, you know, which is done day and night by the urologist, do they take proper care to save the bladder neck?
You can, but generally we don't.
They don't.
Why? Majority of patients belong to the age group of 65 and above, so fertility is not an issue. We counsel this patient that you will lose ejaculation, but if you want to do an effective surgery for bladder outlet, then you have to do a good resection of the bladder neck. We don't have. In some of the cases, we can preserve ejaculation in those cases by trying not to resect the ejaculatory duct. So we can do that, but in a very, very selected number of few cases we do that. Yeah.
Because many of them, even if they are less sexually active, but with dry orgasm, once they get the retrograde ejaculation, it is known as dry orgasm.
That's right.
Many times they are not so happy about their sex life.
Yeah. And larger of patients now getting more aware of this, and they may not be sexually active really that much, but they don't want to lose their ejaculation and they don't want to lose their erection either. Of course, erection will not be affected by this. Ashish will tell you that. But yes, they are very, very aware, very much conscious about the losing their ejaculation and orgasm. So we do have to tell them that, look, you may lose that, but if you really want to save it, then we have to do slightly modified surgery in your case, which we do.
For this prostate, the commonest question asked is whether to go for robotic surgery or usual method.
That's a very important point, Dr. Umerji. Yeah. See, we have been doing robotic surgery for prostate, but it can only replace open surgery for prostate. When we do open surgery, huge glands, for example, 100 grams and above, for then we are better off doing a open surgery, because we can enucleate the gland completely from the capsule and take it out in one go, rather than resecting and making bits of it. Okay, more hemorrhage and more time. So enucleation is a better way of doing it. If you do enucleation, you can do a robotic enucleation, which is a much less invasive and a more controlled surgical procedure. We do this very routinely but it only replaces open surgery, not transurethral.
Use of the truss technique, as you said, is it more beneficial for the surgeon to avoid the trauma to the neck, bladder neck, and...
Sorry, what's the question?
The use of truss technique, you said, transurethral, urethral...
Extremely.
So it's very important for the surgeon to do that in preserving what you said just now.
All of us, we urologists, are trained to do truss. Okay, but what has happened recently is ultrasonologists are so good and they are so enthusiastic about it. And for example, doing prostatic biopsy, we used to do our biopsies under a truss guidance. But now that ultrasonologists are so good and they have time, and there are so many of them, they're very keen to do that. So in my practice, we have given away all my biopsies to them. And I'm sure a lot of my colleagues, Ashish and may agree, they've given away all our practice of use of truss to ultrasonologists now. And they are good at it, no doubt.
Sir, I have a small question, sir.
Yeah.
Sir, actually, being a gastroenterologist, sir, here on the dais.
Oh, sorry.
Hi, sir.
I didn't see that. Sure.
Sir, as a gastroenterologist, we encounter chronic liver disease cases who have sexual dysfunction. Like we see almost 25 to 75% patients of chronic liver disease because of the endocrine dysfunction, sarcopenia, or because of drug like alpha beta blockers. They have this type of issues. So do you encounter this type of patients of chronic liver disease, and what is your approach? I know this is not related to this talk, but just a short.
Liver cell failure. No, what did you say? What was the question?
In cases of chronic liver disease, sexual dysfunction. So
chronic liver disease with?
Sexual dysfunctions, like erectile dysfunction.
Sexual dysfunction?
Yes. Do you encounter this type of cases?
Yes, we have. So
how do we approach? Like we start with medical?
Somehow we have patients who have got liver transplants and we're dealing with them sexual dysfunction in these patients. It's very common, yeah. But chronic liver disease causing hormonal changes and affecting sexual function is much more common than organic sexual dysfunctions. That is much more common, yeah. But yes, I think patients who have got transplanted patients who are on steroid for a long time, who also encounter sexual dysfunction, and we do have to treat with them, yeah.
Sure. Thank you, sir, for that lucid and informative talk.
Thank you.
So, any more questions?
What is that? Well, that depends on the cause. If it is a bladder neck incompetence, then we have some drugs which can augment the bladder neck. But they are highly, highly ineffective. And if your problem really is infertility, then we can easily do that. But what we do is we do a postcoital sample of urine, wash it, and use it for IUI, intrauterine insemination. That is the way we go. Well, post-EUR, that is iatrogenic. So we should not have a problem. I mean, patient must be aware of it. But he can't come back and tell me, doctor, I did not know, and you have given me rectal ejaculation. No, in that case, we don't have any answer to that. It should not happen, actually. We need to counsel the patient properly. Yeah.
Thank you.
Thank you.
Thank you very much, sir. I would now like to invite Dr. Vittal Shenge, Head of the Department of Anesthesia, VishwaRaj Hospital, to felicitate Dr. Shri Shinde. To felicitate our speakers, Dr. Vikram Patil. Sorry, our chairperson, Dr. Vikram Patil. Felicitate our next chairperson, Dr. Pratibha Banve.
The next lecture for today is ejaculatory disorders, behavioral therapy versus pharmacotherapy for early ejaculation. I request Dr. Kunal Oswal and Dr. Milind Sakni to come to the dais to chair this session. Dr. Kunal Oswal. Dr. Milind Zakne is a general surgeon who has done MBBS from Pune University and DNB General Surgery and has got a vast experience as a laparoscopic and general surgeon. Our second chairperson, Dr. Kunal Oswal, is also a general and a laparoscopic surgeon with over 20 years of experience in Pune. I request the chairpersons to introduce the speaker for today, Dr. Shirish Malde.
Dr. Shirish Malde. Dr. Shirish Malde will talk on recent advances in sexual medicine. I'll give a short introduction about Dr. Shirish. He is a diplomat of American Board of Sexology, consultant in sexual medicine and male infertility, having practiced in Mumbai since last 23 years and visiting consultant at Goa and Belgaum. He is an ex-national vice president of Family Planning Association of India, one of the largest NGO working in the field of sexual and reproductive health. He has a wide experience of running a telephonic helpline addressing sexual and reproductive issues of the common people. He has answered more than 65,000 calls. He is actively involved in sexual education among the children and young adults from all walks of life. He has presented many scientific papers on various platforms and he is a columnist in prominent Marathi and Gujarati newspapers. I hand it over to Dr. Shirish Malde.
Okay. And this is pointer. So good afternoon, everyone. Am I audible? So, first of all, thanks to Dr. Dhangar and his team at VishwaRaj Hospital to organize such a informative CME. Since almost 2.5 decades, we have been striving to make sexual medicine as one of the popular stream of medicine which was neglected. Even in medical education, we don't have a single chapter in sexual medicine, most of you would agree. And now with such kind of CMEs, I am happy to see that we are able to spread the more and more scientific knowledge and more recent advances into the therapeutics of sexual medicine is spreading across the medical fraternity. So today's our topic is behavioral therapy versus pharmacotherapy in the management of premature ejaculation. And in the morning we had a nice talk by Dr. Irfan Sheikh. So in the morning, okay, audible to all? I thought with this I will have some mobility. This was off. Yes. So in the morning we had a nice talk by Dr. Irfan Sheikh on premature ejaculation. So we'll just briefly we will go through it. Our respected chairpersons have given me a good introduction of mine. So sexual functions in man, you can say it starts from desire, then the physical component, that is erection, comes, then penetration, and finally ejaculation or orgasm. Though practically we say orgasm and ejaculation are same, but theoretically they both are different entities. Dr. Prakash Kothari has done PhD on this subject. And in women, you can see there is no ejaculation, but yes, orgasm does exist. Definitions, since many decades, the academicians have been struggling to come to a consensus for the definition of premature ejaculation. You can see, and since the age of Masters and Johnsons, there has been a lot of changes and metamorphosis in the direction, in the definition of premature ejaculation. Finally, ISSM has came up with the 4 important points, and they have also given 1 minute time duration. To many academicians and clinicians do not agree. Even in DSM-5 also there have been some points, but finally for all practical purposes in our clinical practice, 3 important components should be there to diagnose a case of premature ejaculation. First is the persistent short ejaculatory latency time. Ejaculatory latency times means the time from vaginal penetration till the ejaculation. Second important component is inability to control ejaculation. The person feels that he is helpless. He does not want to ejaculate, but he cannot control and he ejaculates. And third, most important component is the psychological frustration or distress to person and the partner and its impact on the quality of life. That's the main reason they visit your clinic. Now, classification can be several types. It can be lifelong versus acquired. You will come across patients who will say, sir, जब से हमारी सेक्स लाइफ शुरू हुई है हमेशा ही मेरा कंट्रोल अच्छा नहीं रहा, बहुत जल्दी डिस्चार्ज हो जाता है. And then there are some patient who said कि I am married since 20 years, but only since last 2 years I have been ejaculating too early. That is acquired. Then generalized and situational. There are some individuals who will say that in any situation we do ejaculate very quickly. And there are some individuals who will say वैसे तो ठीक रहता है but only कभी कभी discharge जल्दी हो जाता है. That is based on some specific situation. Either they are too much sexually excited or there is a not good privacy. Even in that condition also the sympathetic nervous system overrides and person ejaculates quickly. According to the severity, you can classify them as a mild, moderate and severe. Mild means after vaginal penetration, they are able to have few strokes and then they ejaculate much before their expectation. Moderate, you can say just on the verge of penetration or immediately after penetration they ejaculate. And severe are the cases who ejaculate sometimes during foreplay and sometimes before ejaculation. Genuine and misconception. Someone in the morning pointed out very rightly. Some patients do have misconception about the timing for sexual intercourse. Thanks to the pornography, they think that it should last for 30 minutes, 40 minutes, marathon sessions. And then they say, doctors, हमारा सिर्फ 17 मिनट में खत्म हो जाता है, 15 मिनट, ज़्यादा से ज़्यादा 18 मिनट हुआ मेरा. And then there are some individuals who consider that Cowper's gland secretions which they get during foreplay is also premature ejaculation. They will say कि हम अभी तो मोहब्बत करना शुरू हुआ कि हमारा तुरंत 1-2 कतरा पानी आ जाता है और हम खारिज हो जाते हैं. So that's not premature ejaculation. So always go deep into the history. Don't just buy definitions or their diagnosis from patient directly. Many patients will say, क्या problem है? PME है. They themselves will diagnose and then will say. But once you get into the details, you will know that mostly they don't have problem. Sometimes the partner is not able to reach orgasm and then they consider themselves as being incompetent. And finally, primary versus secondary. Primary are cases like generalized who have right from beginning of their sexual life, they have been ejaculating too early. And secondary are those who have developed this after certain events in life. And causative factors is difficult to say, though we say diabetes and blah, 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 a whole list of the etiological factors, but none of them are definitive. Classification wise, if you see, there are people who have low threshold for ejaculation. Like I always give them the example of a dam. A dam has a particular threshold for water retention, 80 feet or 100 feet. If water rises above that, they have overflow. So that is a threshold for that dam. Similarly, each and every individual have a threshold for ejaculation. If they have little more excitement, they ejaculate quickly. So that their threshold for ejaculation is very low. This will help you a lot to explain them about their condition. Examination usually is academically not needed, but for all practical purpose, you must do the examination of premature ejaculation, abdominal genital examination, neurological examination, and sometimes the examination of lower limb if you suspect some major neuropathic changes. A rectal examination can be done only if it is associated with painful ejaculation. But however, you have to do this examination to reassure patient that he is having normal genitals and his response is a normal sexual response. So this is the intravaginal ejaculatory latency time. This is largely used in a prognostic purpose and also to know the efficacy. This IELT has been devised. It's the time interval between vaginal penetration and intravaginal ejaculation, and it's usually measured using a stopwatch. Now coming to the therapeutics. Sexual response cycle is a psychoneuroendocrine axis phenomenon, and hence behavioral therapy is applicable to this disorder. Based on the learning theory, we say that the human behavior is learned, the maladaptive behavior can be unlearned, and more positive behavior can be substituted. You will have so many patients saying, बचपन में हमने hand practice बहुत किया है, हमने हाथ गाड़ी बहुत चलाया है, हमने अपने हाथों से जवानी नष्ट कर दी है और अब हमारा ejaculation बहुत fast होता है. They are partly right. We may just write off कि ये तो वो झोला छाप डॉक्टरों के सेंटेंस बोल रहा है, but they are right because they have trained themselves and they have conditioned themselves to ejaculate too rapidly. In places like Mumbai and even Pune, major cities where privacy is a big concern for adolescents, they usually masturbate in public toilets. They don't have much time to fantasy, they don't have much surrounding to fantasy, so their masturbation is usually a mechanical masturbation, stroking very wildly, and within 20-30 seconds they ejaculate because they have to come out of the public toilet soon. So it's a learning theory which is sometimes responsible to condition themselves to be premature ejaculator. And therapeutically, if you use this behavioral therapy, the essential component includes that you have to create an awareness about point of no return. During masturbation or sexual intercourse, there is a time before which if the patient stops the stroking, he is able to avoid the ejaculation. But if he crosses that point, no matter whatever he does, he is not able to withhold or control the ejaculation. So that is known as point of no return. So you have to explain this nicely in patient's own word that how we can identify this point of no return. Because all the behavioral therapy he has to do, a large depends on that he has to do it before point of no return, because after crossing point of no return, no amount of therapy will be useful. And second component is strengthening pelvic floor muscles to develop good tone. How various behavioral therapy models are there. We always talk about and we always read in some columns also, in internet also is full of these techniques, but no one knows exactly what to do and how to do. So it is extremely difficult for a doctor to explain patient what he should be doing to control his ejaculation. The common techniques used are stop and start technique. It's like the person is moving towards orgasm, in between you give a break, so he buys some time, ejaculation is delayed, again you stroke, again just before point of verge of no return, you stop it. So this is how he is going to gain more and more time. I am not going into detail because our talk will not permit this, but this is something stop and start technique. Second is a squeeze technique, which was promoted by Masters and Johnsons, largely for single persons, but it can be used with the help of partner also. And third, Dr. Prakash Kothari always advocates is yoga mudras like Ashwini Mudra and Vajroli Mudra. You sit in a pose which is similar to Vajrasan, and along with your inhalation and exhalation of your breath, you will be contracting the pelvic floor muscles and relaxing them. So this is the main crux or the main principle of behavioral therapy, that the pelvic floor muscle strengthening, and second is to know the point of no return. Second aspect of the therapeutics is that the premature ejaculation is a neuromuscular reflex phenomenon, and some agents that block or enhance neurotransmitters can affect IELT. And that's the reason even the medical therapy is also applicable to premature ejaculation. The various drugs that are used are the number one topical anesthetic agents in the form of spray or gel. The commonly used medicines are prilocaine and lidocaine. Second line of treatment is oral drugs. The first are tricyclic antidepressants like clomipramine, or selective serotonin reuptake inhibitors like fluoxetine, paroxetine, dapaxetine, and sertraline. Details we have already listened in the morning sessions. Sometimes PDE5 inhibitors are also used alone or in combination with SSRIs. You all know that tadalafil and dapaxetine combination is the most commonly available and hence most commonly used drug combination. Of late, sildenafil and tadalafil combination is also available. How this combination works, the PDE5 component gives them a rigid erection which sustains for good amount of time, and SSRIs increases IELT. So both the ways patient is happy, the rigidity has also enhanced and time duration has also increased. And finally, nutraceuticals and some empirical medicines, and which includes some type of herbal preparations like cannabis. In the morning someone said, but the most common herbal preparation used is hypericum, perfoliatum. That is supposed to be the nerve remedy, and it should be delaying the ejaculation. So timings and the mode of administration is also very essential, because most of SSRIs will have peak half-life time at 3 to 4 hours of time. So patient should take it at least 4 hours before bedtime and not 1 or 2 hours before bedtime or expected sexual activity time. Because if it is of short duration, the medicine will not act. Each medicine have got its own peculiar preferences. Some patients do respond well to fluoxetine or sertraline or clomipramine, and invariably all drugs have some or the other less some kind of unpleasant adverse effects. This includes nausea, vomiting, and giddiness, and tricyclic antidepressants have sedative actions. What patients does on their own, many of them they will say कि हम लोग ये यूज़ करते हैं, हम लोग ये तरीका यूज़ करते हैं, तो ये क्या-क्या तरीके हैं? Application of anesthetic cream, thanks to internet, many of them are doing self therapy with this. Some of them, they divert their attention during coitus. Because of hyper-excited state, they tend to reach climax very soon. So they divert their mind. Some of them, they do self-pinching or self-tongue biting to give some pain, to inflict some pain. So, just 5 minutes. So with this they try to, and some of them try to recollect some unpleasant activities or some unpleasant past events in their life, so that their excitement can be given a break. Use of alcohol in small quantity. Some young people do masturbate before intercourse, so that their second round of intercourse will have sufficient time. Use of condom, many people do this. Now, indications for behavioral therapy. In which cases you will go for behavioral therapy? Mild to moderate case, where at least penetration is possible. Generalized and primary cases, because they are the one who have been troubled since long. Since the beginning of their sexual life, they have been troubled. Those who are into a stable relationship with partner and their partner are cooperative. If you teach them stop and start method, and if a person is doing stop and start method during intercourse, many times partner gets irritated. What is this? Why you are stopping in between? Do it continuously. Then there should be regular attempts at coitus. Many people have very infrequent attempt at intercourse. Maybe they are too busy, or their privacy is less. Many of them have intercourse only during weekends. There also it may not be suitable. Now, client showing better compliance. Now, practicing behavioral therapy requires patience. Explaining them requires patience in doctor, and practicing requires patience in the clients. Not all can practice this. And those who are disappointed with oral or local therapy, or those who have found some significant adverse effect with local therapy. Now, what are the indications for pharmacotherapy? Severely early ejaculation. Before you teach them stop and start, they are already ejaculating out. So medicine is the only way to delay ejaculation for initial time. Pre-marriage encounters or on dating. Once again, infrequent intercourse. We meet once a month, and normally we tend to have sexual intercourse. So their stop and start technique will not be much useful to them. Those who have got strained relationship, like for example, non-consummation of marriage. The couple has not had sexual intercourse for 8 months, 1 year, 2 years. Because of severe premature ejaculation, you cannot start behavioral therapy with them. You have to give something so that there is something known as chamatkar tithe namaskar. Frequency of coitus is not too high, or people returning home after long duration, army men, people who are migratory workers, people who are working in Gulf, or UP, Bihar people coming to Maharashtra for work, they also have this problem. Partner not cooperative, or those who want to conceal that they are taking treatment, because in stop and start technique they have to disclose it to the partner, where many people, many men do not want to know that their partner should know that they are under therapy. People who find it difficult to follow behavioral therapy, and then people who are exhausted from other empirical treatment. हमने ये दवा लिया, वो दवा लिया, फलाना ढिकना सब दवा लेकर के अभी थके हुए, हारे हुए हैं, तो you cannot start them on behavioral therapy. Their medicine therapy would be first line of treatment. Advantages, and if you see vis-a-vis pharmacotherapy, you can have a better predictable outcome, because taking medicine will give them the result well within first week itself. More client compliance, especially in severe cases. Therapy can start at primary healthcare level. For behavioral therapy, you have to refer them to a therapist who deals with it. Whereas in primary healthcare center, prescribing medicine is very easy even for a general practitioner, or even at a much lower level also. It prevents exploitation of clients by other unethical practitioners. This is my favorite line. Why people go to advertising quacks? Railway station pe ST स्टैंड पे निराश ना हो, तुरंत मिलिए, वो जो झोला छाप डॉक्टरों के एडवर्टाइजमेंट होते हैं, why people go there? Because we fail to give them the adequate results. That's why those people are flourishing. If a busy physician, busy cardiologist is not able to attend to what his patient is saying, if a busy diabetologist is not able to attend to a sexual dysfunction of his client, he says, no, I know only about gliptins, I know only about OHA, I don't know about sexual dysfunctions, then this fellow is bound to get into the trap of the such jola chhap. It is our incompetence that is pushing them to these jola chaps. More suitable in high turnover OPDs, like many people have बड़ा OPD है, 50 पेशेंट दिन में है, और विश्वराज हॉस्पिटल का OPD, तो वहाँ पर सबको इंडिविजुअली स्टॉप एंड स्टार्ट स्क्वीज मेथड नहीं सिखा सकते, so you teach them or you put them on medicine first. Behavioral therapy advantages, you can impart basic sexuality education. There are so many misconceptions in a human's mind about their sexual dysfunctions. So you have a good golden opportunity to correct those things. Emotional issues and attitude changes can be expected, like in case of a strained relationship between husband and wife. It's just giving them a pill will not solve their intimate relationship issues. You got a chance to address them during behavioral therapy. You have an opportunity to explore and explain the essence of relationship, mutual responsibility, communication. You have to say that you have to say the female partner that unless you cooperatively help this guy, he is not going to improve. Quality of life, that is emotional, interpersonal and psychosocial factors can be considered. And finally, there are individuals who say, as long as we use medicines, we are perfectly okay. But the moment we give up medicines, immediately after 4 days, we are back to square one. So we want to get rid of medicines. Welcome to behavioral therapy. Disadvantages, pharmacotherapy means there is too much medicalization of a sexual dysfunction. Spontaneity in sex gets killed. You have to take proper medicines at right time. So you have to plan your sexual activity. On 11th hour, if partner wishes, ki chalo, let's have intimacy today, he is nervous. नहीं, आज तो medicine नहीं लिया है. Often relationship, romance is completely ignored because it is prescription that is driving the treatment. Reinforces war between sexes, various adverse effects. I already told you that most of these SSRIs and tricyclic antidepressants do have adverse effects. Increased sexual confidence can draw complications. Many people are not going for extramarital sex because of their some sort of weaknesses during sexual act. If you treat them, if they become macho man, that at a pill they can have very good erection, at the pill they can delay their ejaculation very well, then extramarital sex chances increases manifold. Women feel that they are losing worth. The partner says कि अरे इसको टैबलेट लेना पड़ता है अराउजल के लिए, अरे इसको कंट्रोल करने के लिए टैबलेट लेना पड़ता है, am I not good enough? Clings to medication more than required. Behavioral therapy, you need high motivation and perseverance from doctor as well as patients. Outcome is highly uncertain. It's often too lengthy and time consuming. It has a limited applications, like in too high anxiety case not useful, where partner is not available or not willing to be involved, this therapy may not be so good, or too profound socio-cultural influences. Your very good efforts to clear myths and misconceptions may go wasted if patients have a very deep impressions that masturbation is harmful. Even a 65-year-old man will say, मैं 18 साल का था तब मैंने masturbation किया था, मेरे दोस्तों ने मुझे गंदी आदत सिखाई थी. For 40 years he was absolutely healthy. He won't consider this. But 65 years में ED हुआ, so he considers कि 18 साल में जो masturbation किया है वो responsible है. Competent psychotherapist is a rare commodity. no explanation further. And psychiatric illnesses may go undiagnosed often because the psychotherapy or behavioral therapy is too much focuses on such changes, and sometimes you misdiagnose them. These two people are not compatible. But pharmacotherapy and behavioral therapy are supplement to each other. So this is the main message I want to carry. Not only one line of therapy may be 100% suitable or applicable or useful, you combine and blend them nicely. You give them medicines to delay the ejaculation, so there is a good compliance, patients cooperates well, and with little enhanced confidence of improving sexual life, patients can practice stop and start squeeze method very effectively. So it's a perfect combination of science and arts. And finally, if Dr. Dhangar permits, I would like to invite you all for our Council for Sex Education and Parenthood International, which is the national body which is very active and held, and with this body holds the National Conference of Sexology every year. So in current year, we have organized it in Srinagar, Kashmir, in the month of April. It's labeled as Tulip Conference because that's a season where the tulips blossom there for about 1 month. So I invite, being a organizing secretary, you would be wondering कि Mumbai man Srinagar में कैसे organizing secretary हो गया, but Kashmir is my second home, and this fellow Dr. Masroor Wani, he is from Srinagar, dermatologist and sexologist, who is the organizing chairman there. So 13th and 14th April, Srinagar, you can visit, you can attend the conference and then can have a summer vacation in Kashmir. Thank you very much.
Excellent talk, sir. We will take few questions.
Sure.
एक सेकंड सर.
When we visited, there is a often practice ki they are selling ashwagandha and shilajit for this purpose. So what is your personal view or your experience regarding ashwagandha, shilajit? Because all Ayurveda people are saying that we should take it like a bikasul.
Not only in Kashmir, Srinagar, but even if you visit Haridwar or Jammu, I mean, even in any place in Himachal Pradesh, any Himalayan state you visit, these people will bring Shilajit. Shilajit, the name suggests, it is produced as a some kind of a bark from Shila. Shila means rocks. Rock में से जो गोंद का जो अर्क निकलता है वो शिलाजित होता है. It is almost extinct. हिमालय में भी वो मिलना मुश्किल हो गया है. So Ayurveda is a very good system of medicine, I would say, but only with the good practitioner who can ensure you good quality drugs. Ayurveda in sexology particularly, on this open platform, I can say after 24 years of practice, is failing miserably. No doubt 99% of the products which are advertised in the news channels, internet, local newspapers, magazines are all Ayurvedic products. There is no quality control. Whatever they are giving, even
what
the
about
noted,
Patanjali and all that?
even the noted,
Accountable?
I am coming to that, even the noted pharmacies like Dabur, Vaidyanath, I have a big question and big query myself that how tons of this Shilajit they are getting to produce daily millions of tablets. So quality control is a big question. So we haven't seen a good result in ED as well as premature ejaculation with any of these. Ashwagandha, yes. Safed Musli, yes, because they are available in abundance. But once again, you see ashwagandha, you go to any Gora Gandhi Ayurvedic shop, you see at least 4 to 5 qualities. 200 रुपए किलो से लेकर के 2000 रुपए तक किलो का होता है. So which quality is good is difficult to judge. More the cost means more better quality ये कहना मुश्किल है. I won't vouch for it.
So, forgetting about quality, what will be the take-home message?
Take-home message would be a combination of behavioral therapy and psychotherapy. Psychotherapy, we haven't gone into detail because our talk was limited as a vis-a-vis, that we have to judge the advantage and disadvantage of both the methods. So any medicines, whether it is a nutraceutical, herbal, or any of these medicines which were mentioned here, you see that it is effective. Proper timing should be given. If a patient is consuming depoxetin in morning and if his regular sexual activity is in the evening, depoxetin will be of zero value. So you ask patient, when is your sexual activity time, and you will be surprised that we take it for granted that night time, bedtime would be their sex time. But many patients say night time में बच्चे सोए रहते हैं रूम में, अपॉर्चुनिटी नहीं होता है. मॉर्निंग 7 बजे बच्चे स्कूल को जाते हैं, फिर 9 बजे तक हमें अपॉर्चुनिटी रहती है. So your timing for medicine intake should coincide with the sexual activity. This is the most important essential component for ED as well as more importantly for premature ejaculation. Because taking medicines at wrong hours will make it totally ineffective. Same, sir. Ginseng is also, I would say, overhyped. Just because the Korean root resembles male genital, people think that it is good for male genital. Anything can be additions. Anything. There are so many nutraceuticals now available. Hypericum is now the most commonly drug. Along with this, Gokuru. See, these are proven medicines. If you read the Rasayan Shastra and Vajikaran, there are certain things that will make you scratch your head. For example, Suvarna Bhasma, Makar Dhwaj. Is Suvarna Bhasma, you think that is available and can be taken? People have reported serious kidney damages with such kind of heavy metals medicines.
That is gold. Gold salts are nephrotoxic.
It is. So proven medicines, when produced by a scrupulous producer, will become ineffective.
So, I mean to say all the manufacturers in India are not up to the standard?
Well,
I'm just asking.
We cannot make such statement.
We cannot make a general statement, but general observation is yes, because there is a lack of quality control. So any Tom, Dick and Harry can, produce and can establish a small factory in 10 by 10 feet ka room and can produce.
Well-established Ayurvedic company like Registrar, Pune, or maybe some few of
Yes.
on the fingers.
Sir,
very few of them, yes. Sharangdar is one of them. Sharangdar is one of them. Dut Papeshwar is one of them. There are many.
Sir, one.
This circumcision is supposed to cause prolonged ejaculation.
No, that's a big myth.
That's a big myth.
That's a big myth. Otherwise, all Jews and Muslims will never visit your clinic. But they do visit. That means circumcision is not helping them.
Responsible for premature ejaculation.
I would.
That's a big myth once again.
Sir, I would like to add on circumcision. Very simple thing. If the prepuce was not needed, the evolution would have got rid of the skin only. That lubrication, that the glands in the peripupial skin, the glands are having some lubrication role in the act of sex when otherwise if there is and plus that skin provides the natural curvatures, natural friction. Okay, otherwise the smooth prepuce will not give the extra hitting pleasure which the women needs to get aroused. So there is definitely a role of that prepucial skin, whether we want to accept it or not. If we bring religion into everything, then difficult for science to survive. Hello?
Yes, Dr. Ajay.
Suppose
Anything? Any more?
Personal tolerance level or something you said.
Threshold.
Threshold, right.
Threshold.
Personal threshold. In
Threshold.
behavioral consolation therapy, counseling therapy.
Yes.
How do you judge of a person coming to you for a
No, for example, when someone says ki,
tolerance? Yeah.
when someone says ki, why I'm ejaculating so early? So explanation is that his threshold level is less, and threshold level can be enhanced with behavioral therapy.
Right.
The way you do stop and start, you are delaying your ejaculation. And once patient is practicing this regularly, initially his first urge of ejaculation comes at a regular time. He goes on pushing it further and further. After 3-4 months, his first urge of ejaculation will also get delayed. This is the success of behavioral therapy.
Personal emotional control or psychotherapy is useful in such cases.
Sorry, I didn't get you.
Psychological, psychic therapy, I mean asking you. Psychotherapy.
Psychotherapy, like here in premature ejaculation, we term it as a behavioral
We are
therapy.
using depressants, no? So psychiatric drugs, I mean, we are using.
We are using in very low doses.
Low doses.
Clomipramine for depression is used in 25, 50 and 100 milligram.
So psychotherapy
we are beginning with 10 milligram only.
Right.
Even fluoxetine, which is used 60 milligram normally, we are using only 20 milligram. So it's a very low dose.
Yeah. So psychotherapy is more important. If it is not working, then you are using this antipsychotic drugs.
See, these antidepressant medicines are not treating depression in PE. We are using their adverse effect for our benefit. Most of these antidepressants, they delay the ejaculation, and in some cases, they make the ejaculation absent. Like someone told that a person is taking antidepressants for 2 years, 4 years, and he is not ejaculating at all. He is not ejaculating at all because of this adverse effect of antidepressants. So we are using in a lesser quantity. थोड़ा ejaculation को delay करना है, not infinitely.
Use of Xylocaine for local application to delay ejaculation?
Is there? There are people who are using this, and local sprays, lidocaine, xylocaine are used, and one of the side effects is that it creates such a numbness that even their orgasmic pleasure also reduces to a great extent.
Sir, I will tell you one thing. What is the purpose of sex? Pleasure. If you are giving local anesthetic, what pleasure you will get? It is the most useless product they are. Why they are approving? I don't understand this for sexual purpose. They are coming with whatever it is, but local anesthetics are not for this purpose. And while advising, we as a doctor should think the environment sell this product. What is the meaning of it? You know that it is local anesthetic. What is the use of it in sexual relationship?
Dr. Mutta, then we cannot use condom also.
Just throw them out of the clinic. This local anesthetic.
No. Dr. Mutta, then we cannot use condom also.
They cannot use anything.
Natural sex.
This is frozen, no?
Condoms are
Useless. Okay. The purpose is something else. Condoms are used for family planning. This lignocaine jelly.
For pleasure, condoms are used. If you want pleasure out of sex, don't use condoms. Simple.
Okay.
Thank you.
Thank you, Dr. Shirish, for your excellent lecture. Now I invite Dr. Darshan Gaud to come on stage to felicitate Dr. Shirish. Dr. Darshan Gaud is a consultant neurosurgeon at VishwaRaj Hospital. I request Dr. Darshan to felicitate Dr. Shirish. I request Dr. Darshan to also felicitate our chairperson, Dr. Kunal Oswal and Dr. Milind Sakne, sir. Dr. Milind Sakne, sir. We will now break for lunch. Lunch break will be for 30 minutes and we'll reassemble at 2:30 p.m.
डाउनलोड करके रख सकते हैं ना, कल भी यही कंप्यूटर रहेगा ना। चलिए मेंबरशिप डाउनलोड करके रखो।
The lecture will be on ejaculatory disorders, couple therapy by Dr. Raju Sare, sir. For this session, I would like to invite Dr. P.N. Shinde, sir, and Dr. Abhijit Danais, sir, to chair the session. Please, sir. Dr. P.N. Shinde, sir, he is an obstetrician and gynecologist. He has completed his education from Vijay Medical College, Pune. He is practicing in OBS-GYN since 1995. He is heading our Department of Gynecology in Vishwa Hospital since 2016. And Dr. Abhijit Danais, sir, he is a physician. He had completed his MD Medicine from Vijay Medical College. He is the director of Prakash Hospital from 1-4 at Hadapsar. Over to you, sir.
Hello. Thank you, sir, for the introduction. After the lunch, we are starting the post-lunch session in the recent advances sexual medicine. The post-lunch, we are having ejaculatory dysfunctions, and Dr. Rajendra Sathe will guide us for this. He is a physician by profession, counselor, and research. And more than that, he is a sexologist. He has written a book on Tantra and Prem Tantra in 1996, and he is involved in sexual medicines and sex therapy since then for a long time. He has worked in the field of sex, and he has proposed some definitions like orgasm and in the Asian conferences. So I request Dr. Sathe, sir, to be on the dais.
Hello. Hello. Can you hear me? Okay. किससे आगे? इससे आगे, इससे पीछे. आगे आपके साथ. ठीक है? Yes. Okay. Good afternoon, everyone. At the onset, I would like to thank VishwaRaj Hospital and their staff for giving me this opportunity to be with you and present a topic which is quite dear to me on counseling. So basically, I do believe that counseling plays a major role in treating sexual dysfunction, and that in anybody who wants to become a sexologist would definitely have to excel in this particular field of sexual art. So amongst the sexual stages, when a person is sexually aroused or he is sexually in desire, these are the areas where we have to first focus on whether his desire is good, whether his arousal mechanisms are okay, then whether he's in the plateau phase and he's able to maintain his erection and is not ejaculating during that phase. Then next comes the orgasmic phase and the ejaculatory phase on men, and then after that is the resolution phase. So whenever we ask questions in the field of sexual medicine, these are the first 4-5 areas where we are first interested in. And orgasmic or ejaculatory disorders in men and women are very, very common areas of a problem. So if anybody comes with a issue on ejaculation, it usually most of the times is premature ejaculation, which I think you have heard in the earlier lecture. But there are other types of problems also, and this is a matter of great concern to all men and couples together. So the woman also is a little frustrated, the man also is extremely depressed if he has these problems. Now, as a counselor, what we have to do is we have to untangle the mess, and for that we have to first sit and talk. So that mess which is there inside their lives, we have to start thinking in terms of untangling them. And not only do we have to untangle the mess, the important thing is that we have to also see that they develop a bond of love and affection for each other. So this is an important area which we have to focus on, and if we are successful in doing that, only then I would say that our counseling is successful. So as I said earlier, in couple counseling what we have to do is listen all the time, and that is where you have to be good at. So what I have seen many of the times, doctors don't have time to give to their patients, and if they don't have time, then obviously they are not able to listen, because the moment the patient starts talking something, he will interrupt and he will start giving his own opinions. So here we have to listen both as a couple to both of them, then individually to each one of them, and then again together if and when things are required. So while this listening process is going on, we identify the positives and the negatives in their relationship, and then the focused advice is on specific issues which they bring up. So now the patterns of life that we see usually also apply to sexual dysfunction. So here you can see that some people are reckless, others are careful, some are negative oriented, some are positive oriented, some are always sickly, some are healthy, some are happy and sad. So similarly, premature ejaculation, delayed ejaculation and ejaculation are the common areas where you can see that these are the reported problems which are happening in a pattern of life. So usually a person who is having premature ejaculation keeps on slipping into that problem again and again. The delayed ejaculation guy also is over there, and the ejaculation is a really difficult issue for a man to handle, and usually such people also land up in lack of desire. If you just ask yourself a question, that if the ejaculatory orgasmic phase is removed from from your sexual act, how many of you really would like to indulge in it? Because that is the only reason why people indulge in the sexual act again and again. And if an ejaculation is there, then we have to find out the reasons and then treat them accordingly. So there are a lot of couple therapies that are mentioned, and all these ones in the first 5 or 6 ones which are given are mainly based on relationship issues and trying to find solutions over there. But what I find very useful is the cognitive and behavioral therapy and the sensate focus therapy, which was proposed by Masters and Johnson way back in the 1960s. So what does the cognitive behavioral therapy deal with? So it deals with imparting education and information so as to gain cognition about the disorder. So many people remain ignorant as to why this problem is coming to them. So it could be guilt about masturbation in the past, it could be some kind of a child abuse, sexual abuse or something which has happened to them. So we try to find out by talking to them as to what could be the reason why they have been in those problems. So if there are say negative views about masturbation, then we have to correct their views about these issues on sex and sexuality and give them a correct scientific knowledge on all these matters. So what are the common techniques used in behavioral and cognitive therapy is that we use role-playing techniques and specific techniques, and especially we give them homework assignments to do the assignment and then keep a record of all that. So the efficacy that cognitive and behavioral therapy is working is now growing strong, and people who really sincerely give that therapy as well as couples who take that therapy are greatly benefited without the use of medicines. So they report that there is a good improvement in sexual satisfaction, perception, sexual arousal and pleasure and self-esteem. Now, the first person who really put modern sexology on the map was Alfred Kinsey, and in the 1950s he did a lot of work and got a lot of statistical data, and he published 2 books, the sexual behavior in the human male and the sexual behavior in the human female. So this was absolutely mind-blowing study to do in the 1950s, 40s and 50s actually. Though he was not a doctor, he was not a sexologist, he was actually a person who studied insects, and he studied their sexual behavior, and then he got interested in human sexual behavior, and then that is how he was able to write these huge books. Then the next 2 people who came in the 1960s were William Masters and Virginia Johnson. So they were the pioneers who actually observed people having sex. So you can imagine what must have been their lab. They used to invite couples, and they were volunteers who used to have sex in the lab, and both of them used to measure blood pressure and all the other vital characteristics. They used to see the skin color, they used to see the way in which they indulge in the sexual activity. And then they wrote 2 books again. So these books, Human Sexual Response and Human Sexual Inadequacy, were the 2 books that came up in the 1960s, and they too were bestsellers because these books actually focused on observations done by these 2 men and these 2 people, and then they started the real research in sexuality. Now we come back to the topic of ejaculatory dysfunction. So now premature ejaculation, as I mentioned earlier, is one of the commonest problem which we see in our practice, where men are extremely unhappy because they ejaculate early, and by definition if the ejaculatory process happens in under 1 minute of initiating the penetrative sexual act, then we call it as premature ejaculation, and then we offer treatment for the same. Then the second part is delayed ejaculation, where the man and the woman are having sex and the ejaculation just doesn't happen for a long duration of time, or it happens after a very long time, more than 20 minutes or so, and by the time both of them are having pain and discomfort and both of them are losing interest. So this also is a slightly rarely reported problem, but this also is a issue. Then vaginal anejaculation is something which we nowadays see more, especially when the man has been told by the couple has been told by their gynecologist to have a child, that they must have sex on that particular day. And then when that day comes, the man either fails to get a proper erection or the ejaculation just doesn't happen. And this is why these problems have to be treated with care and caution, and we have to sit and talk and discuss, find out what could be the reason. Sometimes the man or the woman is not cooperating enough is what is seen. Sometimes the man is not interested in having a child, and then that could be a reason. So there are many reasons, but we have to sit and discuss with them. Complete anejaculation is also a rare finding, but it usually is resolved more by treatment through a urologist, because they use vibratory techniques and they find out what could be the reason, because usually there is some kind of a physiological abnormality in that particular person. Painful ejaculation is again an issue when the man starts, if he develops pain in the testes or in the urethra or in the penis during ejaculation or after ejaculation. We have to find out what could be the reasons. But we find out whether there are any relationship issues also over here. Retrograde ejaculation is reported by men after having undergone prostatic surgery, where a TUR has been done, TURP, and then the ejaculation happens. The husband reports that there is ejaculation happening, but all the semen goes back into the bladder. And then the woman sometimes gets unhappy. She says that ejaculation hota nahi hai, and then they come over to the doctor. And here again, as I said, that proper information, once it's provided to the couple, things are resolved. I think I have just spoken about this. And as I said, that education, guidance, then focus on specific issues, as I mentioned earlier, and problem-oriented solutions have to be discussed with them to create an awareness and responsibility. And the most important factor which we have to discuss in these couple therapies is what are the expectations and what are the realities. Now, sometimes couples in their late 30s and 40s come to me and say that they are not able to get erections, they are not able to get ejaculation. But then when I inquire more into detail, what they reveal is it's for the second or the third act that they are not able to get the erection or the ejaculation. So what happens is that that particular man, he usually in his early, say 20s, is able to have sex and get the first act going on. But then he gets a premature ejaculation, and after the ejaculation is done, then he waits for some time and then goes in for the second act, where the natural increase of the sexual act happens. So say for the first time he does it, the ejaculation happens in about say a minute or two. Maybe then the second time he does it, it takes about 4 to 5 minutes, and the third time he does it, it takes about say 8 to 10 minutes. So after doing 3 ejaculatory acts, he is happy. But this is possible in the young age. Now as he becomes older, he goes to beyond 35, 40, this doesn't happen, and then this causes a lot of issue. And then we have to, so as we take a proper history, we are able to, yeah. So now I'll be showing a small video and I'll be talking along with that. I need some help over here. Control Alt delete. माझा काढू का लॅपटॉप? भागा होतं का नाही तुम्ही जा
झाला का लॅपटॉप?
त्याला की पेनड्राईव्ह लावायची जरूर नाही.
बरोबर आहे.
तेच वरचं पुढे 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 हां मी पुढे गेलो मागे 2 च्या 1 पाहिजे. हां इथे होते का प्ले बघा करा ना. हां हां त्यांनी केलं तर चालू होतं. कहाँ जोड़ा नहीं ती तिसरी व्हिडिओ मगाशी चालू झाली होती. एक मिनिट जरा एस्केप करा. सीज हँग झालंय ते. एक मिनिट ते करा मी करतो ते. E आणि F दोन दिसत आहेत. तेच तसं अक्कच हे करून घ्या ना. एक मिनिट एक मिनिट. नाही मी ती फक्त व्हिडिओ प्ले करतो ना. शो होऊ दे मला कळेल ते. पॉवर पॉईंट नको. नाही पॉवर पॉईंट नको. एक मिनिट तुम्ही ते मगाशी हे केलं होतात ना. नाही होणार. होतं का मग एस्केप करा आणि मला ते हे द्या. ठीक आहे मग I'll do it. Okay. I think this is okay. Yeah, so you can see now that the sensate therapy method, which was given by Dr. Masters and Johnson, has been focused on making the couple understand what is to be done. So you have to tell the couple that you have to spare time for each other and see that you are not disturbed. So you have to have a setting which is proper, where you have a comfortable sitting. The light has to be good. And you have to tell them again and again that you do not have to have any disturbances. There has to be no music, no phone, and the light also should be, sort of dim to the perfect amount, because sometimes the woman may not feel very comfortable if the lights are very bright. Then, because we are going to tell them that we need an 1 hour time, so they need to have a watch which is easily, easily seen. And then this, we have to keep telling them that if either of you feel uncomfortable, then we need a few extra sessions to get to know each other. And then once that starts happening, and once finally both develop confidence in each other, they have to have a understanding as to who will be the receiving partner and who will be the giving partner. So once you go over there, then you have to understand that there is no intercourse permitted over here. Now, once you tell them why the intercourse is not required, is that removes the performance anxiety from the man and the woman's mind. And here we have to, tell them to focus, that the person who is receiving has to focus on her or his emotional and physical sensations, so that you can concentrate and try to experience the pleasure that whatever you are able to get by receiving the sensual touch. Now, sometimes if there is distraction in the mind of a person, he has to get his mind back again and again onto where and how they are placed in that particular room. So the receiver and the giver have some certain rules, and some of the rules are that in the first part, in stage 1, there is no genital touching or the breast touching. So these areas which are the most sensitive areas have to be, sort of left out by specific, suggestions and telling them what is to be done. Now, the feeling of touch has to be definitely, sort of experienced by the giver and the receiver, so that the strokes which are given are very light and very just by the tips of the fingers. And then once that starts happening and once the partner starts feeling comfortable, then the giver can give a massage of the body. Now here too, the genital areas are not to be touched, and the breast also should be avoided. So once these things are done for 2 weeks over, say, 60 minutes as mentioned earlier, and this creates a sort of a confidence between the two of them, only then can we tell them that, look, you are now ready to move on to the next stage, and you must again tell them again and again that the sensual touch is allowed, but touching breasts, touching various areas of the body which are sort of sexually aroused are permitted only by consent of the receiving partner. And you can use massage or powder or something to oils to give them the massage, and then this is how the couple proceeds into the next stage. So now once their bond is established and there is some kind of an affection which is sort of given by the receiver and the giver, then again the roles are reversed and the receiver becomes the giver and the giver becomes the receiver. So this is what we have to emphasize on them, that this is the time to practice and practice and practice, and without getting the stress of showing any kind of performance. So there is no sex allowed in this stage 1 of the Sensate Focus Act, and this usually goes for these are usually recommended say 6 sessions over 3 weeks. So this sort of works and helps the couple to understand the features of good sex, that there is no pressure of intercourse on either partner, and they explore each other's bodies. So here the counselor helps not only for ejaculatory issues, but there also could be issues concerning erectile dysfunction, and these issues can also be sort of looked upon and taken care of over here. So here, although these exercises look boring and sort of something which is sort of not to be done, but we have to keep emphasizing on them that this is finally going to help the man to get his proper erections and his ejaculatory control. So once this has happened, then we go in for stage 2. So for stage 2, what we have to do is अजून एक व्हिडिओ, अजून 2 व्हिडिओ आहेत. इथे दिवा पण पाहिजे मला खरं. एक मिनिट. हां तो होतं का? एक मिनिट. USB ड्राईव्ह डिस्कनेक्ट होते मला असं वाटतं. तशी नाही होणार. Yeah. So for stage 2, you can see that once the stage 1 is done, then we have to tell them that you have to find time again and again. We have to mention that this has to be, sort of emphasized upon, that you have to find a lot of time for the whole thing. There has to be place, cushions. You have to be very comfortable and, sort of create that mahal, as we say, that act should be created. You have to have give them a special effort, and then experience the exercise, and then feel the experiences of the exercise. So the time factor, all those things have to be again and again emphasized upon them. So even in stage 2 of the sexual of the sensate focus, intercourse is to be avoided, and only thing that can be allowed here now is genital touching. So now that genital touching is allowed, we can see that the couple can give each other massage along with touching each other's genitals, and also see that lubrication and all those things are sort of advised properly. Now this again lasts for 6 sessions of 30 minutes, and then the man and the woman have to proceed to the next sexual act. I'll just cut short over here because some of it is sort of getting repetitive. Now let me just check. Yeah. So now this is the third video, final one, and now you can see that in the final stages, the couple is again given the same advice that you have to find time, you have to see that you're mentally calm and sort of able to give 100% attention to each other. The mobile phone, which is a very common distraction method, is sort of avoided here, and the man and the woman are now finally told that they can sleep in the nude and they can think in terms of having a mutual masturbation. Now mutual masturbation is also sort of, you have to keep telling them that the act should be such that you have to experience your own pleasure. Don't think in terms of what I am doing is there, but the person who is experiencing the masturbatory act given from the partner has to sort of start feeling and enjoying that pleasure, because many a times in our country enjoying sexual pleasure itself is considered as something which is a sin or which should not be enjoyed, or women sometimes feel that this is something which is not to be enjoyed, it is only meant for reproduction. So all these things you have to find out and ask them all these questions. So now the mutual masturbation and ejaculation and orgasm is something which we tell them to go ahead and see how things are happening over there. Okay, so now I don't have any videos, so I'll just again go directly to the last point. So basically, advantages and disadvantages is what I want to discuss now. I'll just finish off. I'm sorry for the time issues over here. But in couple therapy, what we always as counselors want to do is improve the counseling, improve the communication skills of the particular couple by helping them to communicate in a manner in which they do not insult each other. Very often when the couple come to you, they start insulting you and then insulting the partner and in front of you, and then that creates more rift. So those conflicts which have to be sort of taken care of, then it increases the opportunity for shared support and restores normal and physical intimacy. Increasing emotional detachment or avoidance is something which has to be focused on and found out that what is the issue why your partner is avoiding the sexual act. The trust issues and all these things are also to be looked upon. What I want to focus on here is there are too many disadvantages of couple therapy because there can be some mental issues. Now I have seen sometimes people are having personality issues. Either it's a cluster A, cluster B personality, cluster C, or some kind of a personality disorder in the one particular partner can create a havoc in the marriage. So these have to be sort of properly studied before we think in terms of giving couple therapy. Along with that, physical disease also has to be omitted. Now, physical diseases like vaginismus and many a times there are other issues which a man could have. So those issues can have to be, sort of first identified and treated. Resistance and unwillingness to take proper treatment is also a very common issue which I've seen. And one particular person sometimes is not interested in maintaining the marriage. And then when that starts happening, then whatever things you do, the couple therapy just doesn't work. Financial and time commitment are issues which are also to be considered, because each time when you sit with a couple for an hour and a half, if you do expect them to pay fees, but it doesn't happen all the time in our country. This is a good for an American situation where people do believe in all these things. But now with the advent of medication for erectile dysfunction, premature ejaculation and all these things, people are not very much happy over here. This was a good therapy prior to the advent of Viagra or sildenafil and other drugs like PDE5 inhibitors. But now I think that people avoid taking this. And sometimes the man, he's just not interested. So, or the woman, she's not interested in sex. So that old saying that you can take a horse to drink water, but you can't make him drink is very much applicable here. And the most important thing over here is that not all relationships can be saved. So I have had couples, where I have told them to separate because it will be in their better interest that if they stay together, they are going to have a very miserable life together for their whole lives. I have called their parents. I have called maybe the girl's parents and told her that I think it's better that she separates from over here and takes a mutual consent divorce and then finds a new partner. And I have had many couples who separated and then who got remarried again, and then things are much happier with them in their case. So these are the references which I would like you to know. And I think this was also a video of OP Nayyar. I don't know whether it will play. If it plays, it's well and good, but it's not playing. So if you see, so she is singing this song, and the man is really not even able to understand what she's trying to imply, And this is one of my favorite songs, so I would like you to also listen to this, where the woman is trying to tell that धसमुसळेपणा करू नकोस. पण काय कित्येक वेळेला पुरुषांना कळत नाही. And then this is what we have to keep telling and enforcing. So I think I'll end my talk over here. I had to, so the videos were not playing properly, but I'm thankful for again inviting me over here, and I'm glad that you listen with patience. Yeah. Are there any questions just now or later on?
Yes. If anyone has any questions. I would like to request Dr. Anirudh Karud sir to felicitate Dr. Raju Sati, sir. Yeah, please. Dr. Anirudh Garud is a head of the Department of Pathology in VishwaRaj Hospital. I request Dr. Anirudh Garud sir to felicitate Dr. P.N. Shinde sir. I request Dr. Anirudh Garud sir to felicitate Dr. Abhijit Danai sir. Thank you, Shinde sir. Thank you, Danai sir. Thank you, Dr. Garud. We'll move on to the next lecture by Dr. Manik Bisi sir, drug-induced sexual dysfunction. For this session, I would like to invite Dr. Sushma Bhairokar ma'am to chair this session. Ma'am, please. Dr. Sushma Bhairokar ma'am, she's a senior obstetrician and gynecologist. She had did her MBBS from Vijay Medical College in 1980 and she is practicing in gynec since 1980. Over to you, ma'am.
I would like to introduce Dr. Manik Bisi. He is MD psychiatrist, consultant psychiatrist, expert sexual medicine in Aurangabad. He is consultant psychiatrist, dedicated specialist, expert sexual medicine in a hospital, Jalna Road, Seven Hills. Professor and head of psychiatry in MJ Medical College, Aurangabad. And his areas of interest are medical neuroscience, medical education, and de-addiction. 11 years of clinical experience he is having at post-MD, and 22 publications in indexed journals and 6 chapters in book. So please continue, sir.
Thank you, ma'am. Good evening, one and all present here. At the outset, I would like to thank VishwaRaj Hospital team and my dear friend Dr. Sanjay, who has provided an excellent hospitality, and thank you for inviting me here. In the next few minutes, I am going to talk about drug-induced sexual dysfunction. I was sitting in the back and listening, and the most of the topic had been discussed by prior speakers in a different context. So what I am thinking is just to present a summarized version of drug-induced sexual dysfunctions. At the end of the session, we will be discussing and understand these 4 main learning objectives. What are the neurovascular and endocrine mechanisms behind the sexual act in both males and female? Drugs causing sexual dysfunction at various stages. A brief about clinical assessment and management we will be discussing at that particular junction itself. Like the previous speaker stated, talking about sex is a taboo in India. Just 4 days back, I was taking a clinic for the phase 2, that is second MBBS students, and they presented the history, and in psychiatry what we have is a detailed sex and marital history section that is to be elicited from the patient and the relative. The rest of the thing was presented very well, and they skipped this portion altogether, even the heading also. I said, what happened? Sir, uske baare mein kaise baat kare? Then I asked them very clearly, do you think it is important? Yes, it is important. Now direct question to you. Do you think you are not going to have sex in your life? Again, they said, no sir, that's not like that. Then why you are so shy to talk about that? Talk about the act which everyone, every human being, every animal is going to do and does. And then how to elicit that was told, and that was beautifully demonstrated here on the stage by a prior speaker also. What I would like to insist with this sharing was that we should be very open with both males, females in assessing their sexuality, their sexual behaviors, and so that after getting the details only we will be able to provide help to them. So this is a brief of human sexual behavior. In lower animals, if you see, say there are stray dogs. As soon as the monsoon arrives, their sexual activity starts. Is it like that? Is there any heat period in humans? So no. So humans don't procreate just for, don't do sex just for procreation. They do also for recreation, and that is an added advantage which creates a bonding between the two individuals. Now this sexuality in human beings has different aspects to it. What is most important is how is the relation between the two, the couple per se. Then, as stated by prior speakers, there are biological factors, psychological factors, social factors, environmental factors, setting, everything is important in human beings. And my suggestion is, please don't blame drugs without ruling out these factors. As we will be seeing, there are multiple ways in which either of these factors along with the drugs will be causing some impairment. It is not necessary कि there are few cases जो आप देखोगे कि जिसमें say for morning में amisulpiride का example आ रहा था, that there are 2-3 patients who presented after 5 years of amisulpiride with erectile dysfunction, but the remaining didn't present. So that is also the other aspect we have to think of before blaming to the drugs per se. With this, now what I am going to do is, I am just going to create a bit base of how these drugs may be causing dysfunction, the first thing, and then we will be seeing the different drugs. Our brain plays a very, very important role in sexual activity. It is true that even if brain is
disconnected from the spinal cord, erection is possible, ejaculation is possible, that activity is possible, but in human beings and also in lower animals also, the brain plays a very crucial role. So, and we probably psychiatrists deal here in the brain. Sexual interest and libido is completely CNS mediated. So brain is involved and the various areas are shown here. I'm not going to go into details of that because coming slides I will be talking a bit more. Arousal has CNS plus parasympathetic system involvement. Then there is a plateau phase, and orgasm and ejaculation is again mediated by CNS along with sympathetic system, and then there is a resolution phase. What we have to understand is that there is neuro, endocrine and vascular involvement. So you will be finding that sexual disorders are treated by surgeons, by physicians, by endocrinologists and so, because there is involvement of different systems that lead to the impairments or at the actual act per se. These are the findings from the research article, the reference is below. These are the areas that are implicated in interest or desire. Primarily you can see that anterior cingulate cortex and this superior parietal lobe, along with this OFC and this amygdala and hippocampus to some extent, they are implicated in causing the desire per se. Then having sex or liking to have sex is governed by primarily this insula, the hidden part of the brain, and then this ventromedial prefrontal cortex and some areas of brainstem are involved. And again, from the downside, ventromedial prefrontal cortex and amygdala. Inhibition of this sexual activity, these are the DLPFC, VMPFC and VMPFC again with their networks. They don't act isolated with their networks. In sum, DLPFC plays inhibitory role not only in sexual activity, in many other areas or behaviors also. Say for example, for motivation, inhibition primarily by the DLPFC. Addiction, inhibition primarily by the DLPFC. So these are the areas involved, and on other half of the slide you can see that the chemicals that are excitatory for sexual activity and inhibitory are listed down. The purpose is that any abnormality or any drugs that will be acting on either this side or this side will either cause inhibition in sexual activity or increase the sexual activity above the normal, okay, and are likely to, these drugs are likely to present with some sort of sexual dysfunction. So coming to first group of drugs. Now there are many. One of the speaker said if actually we want to know what are the different drugs that cause dysfunction, then we have to stop the practice per se, because many drugs are there. I am just listing the common ones. The killers of libido, benzodiazepines, yes, they act on GABA receptor and lead to decreased desire of sexual activity per se. Antidepressants, primarily by serotonergic action, but it is not that all antidepressants cause that. In fact, trazodone, nefazodone, mirtazapine, vortioxetine and vilazodone, they are known to increase the drive also. So if at all we have to give the antidepressant, then we can prefer to this group. Antipsychotics, again by both prolactin elevation and modulation of adrenergic system in the brain. These are the main culprits which increase the prolactin in the morning, as I have stated. Don't just go for the antipsychotics per se, they are combined with the many times PPIs and other drugs, so we should be watchful about that part also. which do not cause is this. Ziprasidone, olanzapine, quetiapine and blonanserin are the drugs which are good and do not interfere with sexual activity. Then there are serious drugs. Digoxin hai, hydrochlorothiazide, morning the speaker was already talking about this. So methyl dopa again, and spironolactone. We can go for, if there is impairment, we can go for angiotensin II receptor antagonists and vasodilators if there is sexual dysfunction due to these CVS drugs. Similarly, there are others like cimetidine, lithium, finasteride, and so on. List is quite long. Coming to, again, the drugs which enhance the libido. Levodopa, obviously dopaminergic activity will be increased and they will enhance the libido. The same reason what we say कि mania में hypersexuality क्यों होता है? Because there is an increased dopaminergic drive. Parkinsonism, again the same factor, levodopa दिया and sexual drive will increase. Methylphenidate, atomoxetine stimulants है brain के लिए, they enhance the pleasure and also lead to increased drive. Bupropion. Then there are drugs of abuse. LSD is one which was discussed in the morning. Then others also. Ecstasy, crystal amphetamine, alcohol in the low dose in early phase of alcoholism. Later on it kills the sex per se. So it causes impotence by multiple ways. And then for females, this is a FDA approved drug for increasing libido. That is filvanserin. Then there are arousal blockers, or the drugs which inhibit either erection in males or genital response in females. Again, the almost similar list is there: antihypertensives, antidepressants, then there are some other drugs. And if this scenario is there, how to deal with that? First and foremost, like with any other medications or therapy, whatever is administered, we have to think of reducing the dose of causative agent, because many a times we may be seeing the patient from the sexual disorder perspective, but actually he is also having another either psychiatric issue, CVS issue, or some other system issue, which also we cannot neglect. So as far as possible, get in liaison with the treating physician, surgeon, or whoever is the prescriber, and communicate whether we can reduce the dose of the drug per se because the patient is well settled on the same drug. If that is possible, try for some time. If that is not possible, can do a drug switching. So from one drug to another drug. Then you have to discuss with the other consultant, can we give some drug holidays for this patient? Because there are some drugs which cause temporary blockade in the sexual activity. If stopped for 2-3 days, say weekend drugs or weekends, then they may enjoy the sexual activity during that time. If nothing of that is possible, then you can, if there are no interactions and there is safety is assessed, then we can go for the drugs which improve the sexual function, sildenafil, like sildenafil, that PD5 inhibitors. So there are 5 that we are already aware. I'm not going to go into details of these. Then there are villains of orgasm. Again, same, almost similar list is there. One drug which is now a pet of, I will say, neurologists, also psychiatrists, physicians also, is naproxen. Headaches, SOS basis drug that is prescribed, but that causes difficulties in orgasm, both in males and female. So we have to be watchful about that. how they cause is by, in males, they delay the ejaculation, may cause retrograde ejaculation, priapism, dry runs sometimes, or the loss of erection without ejaculation also. So the prior to the act per se, they lose the erection. In females, there will be delayed orgasm and anorgasmia. And accordingly, whatever the issue is there, we have to assess and treat it. In the end, briefly, we are going to see this case that actually that has presented. We have association with renal transplant center. More than 150 transplants have been already performed in Aurangabad. This was a 45-year-old male, known case of CKD, underwent renal transplant 5 years ago. He was on tablet telmisartan 40 milligram and prednisolone 10 milligram along with some vitamins prescribed by the nephrologist. After 5 years, he came to us with complaint of loss of libido and intermittent erectile dysfunction. All other causes like, okay, is there any associated psychological issue, any physical deficit, anything that was on examination on his blood test reports was assessed, nothing was found. What is your opinion? Why he is going through the erectile dysfunction? Yes, sir. Prednisolone. Exactly. Telmisartan, safe. It usually doesn't cause any sexual impairments. Prednisolone on chronic administration leads to gonadal suppression and later on will present with the erectile dysfunction or other sexual symptoms. In that scenario, we have minimized dose in liaison with the nephrologist as much as possible, and bupropion that is was added, and he responded gradually to that. So thank you for your patient listening. I am done, ma'am.
Thank you, Manik sir. Anyone having any questions, queries? Now I would like to request Dr. Shripad Kore sir to felicitate Dr. Manik sir. Dr. Shripad Kore is a physician. He is attached to VishwaRaj Hospital. I request Dr. Shripad Kore sir to felicitate Dr. Sushma Bhairokar ma'am. Thank you, Manik sir. Thank you, ma'am. Now we'll move on to the next lecture by Dr. Pramod Surve sir. The topic will be sexual life and sexual function after spine injury. For this session, I would like to invite Dr. Anand Katkar sir on dais to chair this session. कल के लिए बुलाए I would like to invite Dr. Sandeep Kadlak, sir, to chair the session. Please, sir. Dr. Anand Katkar, sir, he is a neurosurgeon. He had done his MBBS from Bharati Vidyapit, Pune. He had done his MS General Surgery from Bharati Vidyapit in 2008. He had completed his DNB Neurosurgery from NB New Delhi. He is right now attached to VishwaRaj Hospital as a full-time neurosurgeon. Dr. Sandeep Kadlak, sir, he is a physiotherapist. He has experience in physiotherapist since last 8 years, providing the patient care and rehabilitation. He is a physiotherapist for Dr. Vijay Orthopedic Hospital, Sangamner for 1 year. He is a founder and consultant physiotherapist in Arogyam Physiotherapy and Wellness Center, Sangamner. Over to you, sir.
Yeah, good evening, everybody. Just to introduce Dr. Pramod Surve, everything is on the slides. I come from that part of the brain where structural damage is more important. And later on, when we face these kind of issues, it's really difficult for us to pacify the relatives as well as the patients. And I'm sorry I came late, but it was really an interesting talk given by the previous speaker. So over to you, Dr. Pramod.
Yes, thank you. Thank you for the brief introduction. And warm welcome you all on behalf of VishwaRaj Hospital, and thanks for giving this such opportunity organizing committee. And this is the rare and less explored topic of our spine surgery, and Dr. Anand Katkar is also well known that he is a spine surgeon, but we are less educated or equal to illiterate regarding the spine surgeries and related to sex topics. And usually if patient comes to us regarding the spine surgery, spinal injuries, spinal disorders, we hardly ask, even less than 1% of the times, 10% of the, less than 1 to 2% of the times we will bother about the sex and sexual disorder. And going through the such a vast literature regarding the spine and sex topics, I came to know that the sex is very important in the spinal disorder, and it has given so much of education to me, and I'll give some inputs regarding the spine related sex topic and sex related to spine. And coming to the sexual disorder, the sexuality is not only an important physiological promote to sustain the human species, and at the same time it is important to increase the self-esteem of the couple and whatever the human being. As a result of the spinal disorder and sexual disorders, the partners, failures, and whatever the married problems, so many things may come. And coming to the spine surgery part and the spinal disorder, and most of the patients also, they are bothered about the post-operative pain and coming to the functionality, normality, weakness, and instability, all these issues. But very less frequently they are bothered about the sexual activity, and the sex education is very important, and we have to indulge, and we have to educate first before any counsel before to the patient. And literature is very less and available regarding the spine surgery and sex. And most of the common and the patients, if some this Jean and Gilly paper, it has shown that the female and male, whoever they come with low back pain, they usually, the male partner, they are come with difficulty in the finding position during sex. It's the most common complaint from them, and this is the same complaint from the female also. But in the female, if we go through that, the second most common complaint is the difficulty in pelvic movement, and the fear of pain during sex, and the lack of interest in the sexual activity could be due to the pain, and the pain on penetration, and the fear of disappointing the partner. These are the sex-related issues for the back pain. And for the male partner, the difficulty in pelvic movement, it would be the second, and fear of disappointing the partner is the third here. The lack of interest in the sexual activity and the difficulty in achieving maintaining the erection is also a fifth priority for the male partner. And the sexual dysfunction, here the sexual dysfunction in the spinal disorders are mainly because of the pain and the loss of weakness due to the spinal cord injuries and other chronic drug usage, like Vijay sir told, drug usage which causes sexual dysfunctionality and psychological issues. These are the important aspects for the sexual dysfunctions. And coming to the normal sexual function, which the spine and brain, as sir told, the neurohormonal, vascular, the all synchronize to give the erection, ejaculation, arousal for the female and male. Coming to the brain, the spine, the thoracolumbar flow, which is the sympathetic flow, which is important for the orgasm, and parasympathetic flow, which is the craniosacral flow, which is important for the arousal, and at the same time motor function, and so many sacral plexus, S2 to S4 sacral plexus, which supply the genitalia, which is also important for the erection, arousal, and these are the all synchrony which leads to normality of the sex of human being. Coming to the spinal disorder, I am going to deal with main two disorders here. The traumatic is the spinal cord injury, and the degenerative disorders, whatever the disc and facetal disorders and spinal canal stenosis. These are I would like to cover the spinal cord injury first. The spinal cord injury is sex is also very important aspect, but very, very less explored topic in the spinal cord injury patient. And till date, I haven't explored any sexual aspect of the spinal cord injury, even young patients. But I would like to encourage, and I would like to have some questions regarding the spinal cord injury and sex related topics from now onwards. And everybody, if such patients come across, please kindly do concentrate on their sexual aspect also. A systematic approach is needed. They should be encouraged completely, and the communication should be non-judgmental, and we should not judgment if patient would like to have sex. If with spinal cord injury, there should not be judgmental, and we have to encourage with colloquial manner, and physical examination is also important. And coming to the sex topic, and it is not at all pleasurable activity for the important spinal cord injury, and at the same time promoting the maintenance of positive health sexual beyond the reproductive aim is also important for the spinal cord injury. And coming to the sex part, in the male partners, erection is one of the important topic which is difficult for the spinal cord injury patient. But complete upper motor neuron injury lesions means above L2 level injury also, patient they can have erection in 93% of the patient. Incomplete upper motor neuron injury patients, they have 99% of the patient they can have good erection. And complete lower motor neuron only thing between the injury means S2, S3, S4. If sacral plexus is damaged, there the erection would be difficult, but it is not impossible, where we can see the 26% possibility. We have to encourage positively. And incomplete lower motor neuron patients, they can have 90% patient, they can have erections. And coming to the spinal cord injury, male to female ratio in the men are less satisfied for the patient as they are very much psychologically and deprived, and at the same time cervical injury level was associated with higher level of satisfaction compared to the thoracic and lumbar. And the neuropathic pain and the fecal incontinence and urinary incontinence, such the abnormalities, they are the main concerns for the male partners for the sexual dysfunction. And so many formats of the assessments are present. And this is the most common spinal cord injury assessment. We have to communicate properly and ask about sexual and medical issues, and consider the partner and cultural taboos, and perform the physical and neurological examination. According to the examination and the result, we have to encourage the patient, and we have to educate the patient, suggest the practice, and review on encouragement we have to review, and at the same time follow up again, and on the basis of the patient and follow-up. We have to do the further medication and other invasive methods are the possible. And clinician must be comfortable communicating with the patient, and less than 8% of the times that this communication will happen. And these spinal cord injury patients, they are more comfortable discussing these things with peer spinal cord injury patient, then followed by the doctors, nurses, psychologists, and colleagues, and friends and family members. So whenever we are initiating the topic of the sex, and it is in positive manner, we have to start and we have to put paths for them to have to positively lead their question, and at the same time we have to give positive encouragement, and we have to give privacy and more probing questions. No, proceed with more probing questions, and open-ended questions are the encouraged here, and this should be given not specially, not secret manner, and we have to keep it privacy but not in secrecy, and no need to talk these issues in his ear, and we have to disclose all the topics in front of the couple, and at the same time we have to ensure them that this is the process of rehabilitation we are doing, continuing education and training, the same thing which will encourage his clinical comfort and competence in our doctor's issues. And these are the questionnaire. This questionnaire should be the use matter of the fact, tone, voice, and neutral body language should be there. Use postural echo, that maintain the same echo as here we can see the doctor is doing. And use written and scale questionnaire every time we have to further monitoring. Use open-ended questions, and they should be encouraged that the topic should be like discussion. And at the same time, we should not interrupt intermittently. And these are the things, if we encourage such things, the patient can have normal sexual life. And normal means whatever they encourage sexual life. And at the same time, we have to examine their medical aspect, what were the condition, what are the difficulties in their sexual issues. And I am the odd man out here, but most of the sex physicians, they know how to take the case history and examination, and just I am briefing from my side from the theory part. And at the same time, we have to take their previous sexual relationship and the partner abuse and gender orientation, culture and religious taboo in account. The partner should be encouraged and embrace sexual modifications, whatever we are going to advise the sexual modifications. At the same time, the partner also well informed. And the psychological aspects of the sexual history, how would you describe the sexuality before your injury, what was his sexual status, and tell me about the sexuality since acquiring your injury, and do you have any history of sexual abuse by the partner or somebody else, and what is your sexual orientation, and current status and compared to previous experience, the first time masturbated patient and with partner since your injury. Recently we had operated one spinal cord injury in a young patient. After seeing this all questionnaire, I would like to ask such question to him, and I haven't bothered till date, but such questions should be encouraged, and the masturbation part should be asked for the unmarried couple or if living single. And coming to how much concern this for you, if they are concerned about sex or not. If they are not at all concerned, just give a positive thought, but don't indulge, don't pressurize for the having sex. And coming to the physical examination part, and their genitalia should be regularly examined, and female male part genitalia should be examined in thorough. And coming to the neurological examination part, and their motor, sensory, and everything should be evaluated. And in literature showing if fine touch and if sensory pathway is maintained, they have the good orgasm, they have the good arousal situation, and at the same time the patient bulbocavernous reflexes means S2, S3, S4 is intact, not or have to examine by pinching on the penis, and in female patients we can do this bulbocavernous reflex by the pulling of the Foley's catheter, and we have to limit their sexual false beliefs, like they have the patient, I have no feeling, therefore my sex life is over, I am not expecting pleasure, orgasm anymore, sex is pointless, why should I bother, my partner is left me, cheated on me, avoiding having sex with me, hence I am not available, I am not capable of partner, no one will want person with disability in lower, I should be thinking about the sex right now, I should be focused on these doubts should be, we have to rectify, and we have to limit these doubts in their mind, and we can encourage positive sexual aspect by giving sex arousal, dark shades, and creating the dark room and light shades and the flowers, and at the same time if we have to maintain the genital hygiene, bladder, bowel, and to take care so that they can indulge in sexual practice whenever they want if a situation is encourageable. And at the same time so many articles, books are available, videos, discussion, and such things are available, so many things in we have to tell the spinal cord injury patients they can have the good erection, arousal, and gratification, and the treating confounding factors like neurogenic bladders and spasticity, and at the same time pressure source should be addressed, and at the same time the maintaining of these things has to educate properly. And the medications, so many medication discussion has been done regarding the, yes, we can use sildenafil medication in the spinal cord injury patients safely. So much of literature is showing here the sildenafil and such PDE5 inhibitors are very well prescribed in these patients. And if the patients are not enough doing with PDE5, and we can give the vacuum erectile devices and these bands and such things we can give, and but proper education should be done, such bands and such vacuum devices that one should not use, and one for more than 30 minutes vacuum band, such things are sexual therapists they can tell and better than me, and few invasive procedures are processes are present, and now these are the malleable immalleable processes are in present nowadays, and at the same time female partners should be treated at equal, and if they have sexual pains, and as gynecologists they know well, and as the sex therapist also they know well, local hormone therapy, counseling, pelvic physiotherapy is also very encourageable for them, and the low desire, if they are coming with low desire, hormonal therapy will be beneficial. And coming to the low arousal, and hormonal therapy, counseling, and PDE5 inhibitors are off label, and this is still not encouraging in India, but PDE5 inhibitors, the sex medical people and psychologists, they can tell better rather than me. Organic dysfunction, mindfulness, and physiotherapy, and at the same time buprenorphine like drugs which will encourage the sex and increase the libido things. And coming to the spinal cord injury, after to the spinal cord injury, degenerative spine, and which we come across day in day practice, and we usually operate, and we will usually we don't concentrate on the sexual aspect of these things, and we treat them for the back pain and neurological disorders and loss of power and such things. But these are the important aspects, sexualities, and also is a very important aspect of them. And the disorders of the sexual function and cause serious deterioration of their married life, couples, and the sexual behavior between the partners. And sexuality is not only an important physiological need to promote the continuity of human species, and as I told, it increases the self-esteem. And the Asst disability index is the one of the disability index we usually follow in the spinal disorder, spine assessment, and the spine surgeries. In that disorder is that ninth part is which usually related to sex regarding the spine. The questionnaire in the Asst Disability Index is what about the sex life is unchanged or changed before back pain or after back pain, before surgery and after surgery. My sex life is unchanged but causes more pain during sex. My sex life is nearly unchanged but it is very painful. My sex life is severely restricted by pain. My sex life is nearly absent because of pain. Pain prevents any sex life at all. Unable to answer does not apply to me. This is the important aspect in the Asst Disability Index for the sex during the spine assessment. And the most of the more is the spine journal, which shows the sex life and sexual function in the men, women after the total disc replacement compared to posterior lumbar fusion. In both the conditions, the patient's sexuality is increased, sexual desire is increased because of lack of low back pain. Here the usually impaired sex life is equal to proportionate to chronic low back pain, and sex life is improved after the surgery like PLIF, OLIF and whatever the fusion surgeries. And here the another paper which shows the assessment of sexual dysfunction after the surgery, lumbar disc herniation, which shows the physician inform and advise the immediate positional adjustment during the post-operative surgeries, and patient can have good sexual life as soon as possible their surgical period. And so many papers, they are encouraging that the sex life is increased after the spine surgery, usually spine surgery fusions, if the patient provided low back pain free. And here some is a beautiful paper, the Spine Journal, and which is a good class journal, which shows the male spine position adjustment according to their pain. If patient is flexion intolerant, the patient should not be encouraged for this M side, and they have depicted the M side, FMS and quad side, FMISS, F quad. And if the patient is extension intolerant, the patient should not be encouraged to have the last one, M quad one. If patient having the motion intolerant, if the limited motion also leading to problem, the middle one should be avoided for the male partner. And at the same time, in the European Spine Journal, it has been depicted that the female, whoever have the flexion intolerant and they are not encouraged in the flexion position, if the female partner is extension intolerant, the such quad position should not be encouraged. And these are the things they have to teach, and the encouragement should be done accordingly. And this is the motion in the female, if they are afraid of motion, and the last one, F quad one, movement should be avoided. Thank you. After the not only spine surgery is important, and at the same time encouraging the sexual life is also important for the partners. Thank you very much.
Thank you, Pramod Suvesa. If anyone having any questions? Okay. I would like to invite Dr. Namdev Jagtap sir to felicitate.
I have two questions, not for Dr. Surve, but for the chairpersons. Dr. Anand Katkar, first question to you. Have you ever think of sending your patient after spine surgery to someone specialist? This is one. Another thing, what precautions can we take during the spine surgery to prevent sexual disorders, or to prevent especially erectile dysfunction or premature ejaculations?
To answer your first question, we treat a lot of head injuries also. Yeah, and in spine, most of them, because of the Indian scenario where it's still people think it's a taboo to talk about sex, even when they come for an OPD basis. those patients where one of the speakers showed those connections of the brain where there's the inhibition and the arousal, yes, we do get those patients where we need to refer them to a psychiatrist for hypersexuality. It's the opposite way. One of them is it's very common, we see, it's the Clover-Bussy syndrome in our language, but which is a very common thing which happens with post-traumatic. And there are few examples, yes, I had some couple of patients, the wives were most of them are males actually, the wives were very concerned because of the hypersexuality and the irrational behavior. That time, yes, definitely we have sent those patients. Coming to the talk now, but post-spinal injury patients, very rarely the people or the relatives or the spouse, whoever is there, they come for this kind of question because they are more concerned about his physical well-being rather than his psychological well-being, till now what I've seen. So I would say ki yes, now because after the talks I have just heard, yes, definitely I would refer them, but I don't know what exactly how early to be referred, because by the time they come for its rehabilitation goes on for 6 months. Then after 6 months, when to start, because in between if someone suggests ki you go and meet a psychiatrist, the meeting of a psychiatrist when the board also sometimes they are afraid of. So it's become a bit difficult for us to refer so many patients. Yes, but we have got a lot of patients to refer, definitely. And coming to a second question, yes, there are now, we've got neuromonitoring, we've got gadgets, we've got navigation and all, where we can monitor it, almost all the procedures which are done under, especially intramedullary tumors. As the spine surgeon, even Dr. Pramod will be, nowadays with the latest technology, it's very difficult to have complications with nerve root injuries. But yes, for intramedullary tumors, we do neuromonitoring before, to give them a good, leave them without any deficit.
Thank you.
But it was a good talk by Dr. Pramod, I would suggest, yes. And there are many chapters which have to be opened to eyes, yes, because post-spinal cord, but I would suggest, like in Indian, it's very, very difficult for us to convey or convince them to go around meet a psychiatrist because the word has to change to a sexual therapist or something, then they will feel better than the other way.
Yes, sir. For this, as a sexologist, the word is not a psychiatry. The word is sexologist or sexual behavior changing person.
Yeah, but most of them...
So we can give that therapy.
The visiting card, they have to change it, I suppose.
Next question to Dr. Kadlag. So, have you ever treated such patients for any sexual problem, sir, after spine surgery or spine injury?
We have come across such type of patients many times, sir. Though I am practicing in rural part of Maharashtra, like in Sangamir, most of the times people hesitate to discuss such issues. We come across the post-op laminectomic patients in most of the times spinal cord injury. As just now sir said, we had many traumatic brain injury patients nowadays in our area also due to RT and all. These people, the main concern first, initially 6 months, those are very much a crucial period to rehab them and to get the power and all these things. The second part comes with the sexual rehabilitation purpose. That time we have to discuss with the patient's family, the main goal of the patients. Once they stabilize with all these things, then we can start with all this sexuality part. Once I have come across one patient who has undergone the surgery for OPLL, ossification of posterior longitudinal ligament. After the operation, he was a completely paralyzed quadriplegia patient. We started rehabilitation for him. It took almost 6 months to stand him on his leg. We started him walk on walker and all these things. During the sessions and once the rehab was going on, he used to discuss with us, yeah sir, I have such kind of problem, not able to erectile and all these things. In that period, we have tried to give such exercise which can encourage and give confidence to him so he can get back to his all sexual life after the completion of the this rehab part. And we get success in such cases also. In that, our physiotherapy role is that not only work on the Kegel exercise, but nowadays we have to come across the global aspect, like all his pelvic floor, his posture, his thinking of the activities, his positiveness, all these things comes into the matter. If you work on all these way, it definitely helps to patients and patients' lives also. Thank you, sir.
Generally, in urology, whenever we are dealing with such surgeries that can lead to erectile dysfunction or some sexual problem, we start penile rehabilitation immediately after the surgery, and many a times we start penile rehabilitation before the surgery, telling the patient that these are the problems post-surgery. So you need to do these many exercises, some drugs like PD5 inhibitors. So all these things we start pre-operatively, and then the same things are continued post-operatively. This improves actually sexual life and the satisfaction of the patient.
This pre-op rehabilitation and pre-op communication is also very important. As you said, it's rightly important.
Just a last comment I would like to have with Dr. Pramod. You have mentioned about degenerative disc and post-traumatic spine, but one of the very common causes we come across in young patients is cauda syndrome, which does affect the males especially, yes, and they are incapacitated for life. And that is where, Dr. Sanjay, that is the time where we need your urologist as early as possible so that they go back. Most of them are males. And by the time they come and they get operated, the time is gone. The cauda equina is one of the cases to be mentioned where we are very much concerned about, because they are all young males. Male, females mostly, very rarely, but there are all males who are affected by this cauda equina syndrome. And where the urologist, we definitely need them at the earliest. So that is one comment I would like to make. Yes. Thank you.
Thank you, sir. Dr. Namdev, sir, to felicitate Dr. Pramod Surve, sir. Dr. Namdev, sir, is a physician. He is a full-time consultant in medicine department. I would request Dr. Namdev, sir, to felicitate Dr. Anand Katkar, sir. Thank you, Anand, sir. I will request Sandeep sir to be seated for his next session also. Thank you, Anand Katkar, sir. Thank you, Surve, sir. The next lecture will be by Dr. Sachinananda Lakshatwar. For this session, the Dr. Sandeep Kadlak sir will chair, and I will request Dr. Sushant Shinde, sir, to come on the dais to chair for this session. Dr. Sushant Shinde, sir, is a physician. He has completed his MBBS, DNB medicine, and ADCCM in critical care specialty. He is working as a full-time consultant in medicine department. He is a teacher for ADCCM seats and DNB medicine.
Thank you, sir. I'm introducing Dr. Sachinananda Lakshatwar. He is a consultant physiotherapist at VishwaRaj Hospital, Pune. He has completed his bachelor in physiotherapy in 2013, has completed his IFT program. He has also completed his certificate in Pilates training and yoga instruction. He is expert in handling musculoskeletal and neurological condition with the experience of 10 years. He is a part of VishwaRaj Hospital since 2017. So here, please start, sir.
Hello, good evening everyone. First of all, I would like to thank VishwaRaj Hospital and especially Dr. Dhangar sir for giving me opportunity to speak about exercises and yoga in the sexual health. So, okay. Kamlesh. Okay. So for exercises in yoga, here are a few types of exercises that I would like to introduce before going to speak in the effect of exercises and yoga in the sexual health and how will it have good impact on your sexual health and sexual dysfunctions. So there are aerobic active exercises, strengthening exercises. In strengthening exercises, especially core stability and pelvic floor strengthening exercises, and yoga and meditations. So aerobic exercises. Aerobic it means with oxygen. So we are doing these activities with the rhythmical and repetitive movement of our big muscles group. So while doing these activities we use the oxygen, and this aerobic activity will lead to increased oxygen throughout your bodies. So aerobic training, aerobic training also has a parasympathetic effect on parasympathetic nervous system and sympathetic nervous system. So there are types of aerobic exercises: running, cycling, swimming, aerobic dance, rope skipping, jogging, rowing, brisk walking, etc. These all are the exercises which we can continue as aerobic activities. So there are many benefits of aerobic activities. Out of this, there are increased heart rate and respiratory rate to fuel your body with oxygen-rich blood, improve strength of cardiac muscles, as well as improve cardiac lung function. It also helps to decrease your blood sugar level, cholesterol, and triglycerides. So, and reduces stress hormones such as cortisol, adrenaline, and also it stimulates the happy hormones. We can say dopamine, serotonin, oxytocin, endorphins. So now we come to the strengthening part. So for strengthening, there are two strengthening things I explain. The first is a core stability or core strengthening. So core is your muscles around your trunk, that is abdominal and your back muscles. Also pelvic floor muscle is also core muscles. So I'm going to focus on that pelvic floor muscle activities as well. So for doing core stability, these are the activities we can help. It will help us to stabilize your core and strengthen your core muscles. So plank, bridges, flutter, side planks, and all. So why core stability is important? Because if your core is strong, then you can while doing any other peripheral activities, your core muscles has to be strong. Sex is also a peripheral activity and that's why your core muscles should be strengthened enough to do your sexual activity also. So pelvic floor is also a trunk core muscles. So I am focusing on here on pelvic floor. Pelvic floor consists of muscle connected tissues which support your organs such as bowel, bladder, internal reproductive, and the pelvic floor is made up of these all muscles, especially vulvocavernosus, ischiocavernosus. I'm not going to dictate all these muscles, but these all other muscles are combinedly form a pelvic floor that will help to protect these organs, and it has many benefits as well. So these all are the muscles, especially these vulvocavernosus. These are the pelvic floor muscles which has to be strong for your improving your pelvic floor, improving your sexual activity, as well as it has a good impact on your erectile dysfunction and premature ejaculation, such type of other sexual disorders also. So there are functions. What are the functions of the pelvic floor? So it helps to breathing. It helps in pregnancy and childhood. Pelvic organ support. It controls the bladder, bowel, as well as it helps to passes urine and feces. Another one is that a sexual function also is the function of your pelvic floor muscles. So we know that pelvic floor muscles. Everyone heard that pelvic floor muscles are there, but how to know that this is your pelvic floor muscle? So localize your pelvic floor muscle to know your pelvic floor muscles. What to do? That you just have to try to stop your pee and passing gases, and also inserting finger in female vaginal and ask patient to contract the pelvic floor muscle. That time you feel the just pressure and the contraction, and that is your pelvic floor muscles. So for every assessment as we pelvic floor, for your urinary as well as your sexual conditions, you have to, even spinal cord injuries also, you have to assess your pelvic floor muscles. So these are observation, palpation, examination, and there are other methods are also there to assessment of your pelvic floor muscles. So I'm not going to go into details about that, so everyone maybe know about it. So observation, that is nothing but you, when the muscles, when you ask patient to contract the pelvic floor muscle, then you feel the contraction. That is your observation. And for palpation, you can put your palm on the perineal area and ask patient to contract, so you feel the pressure and contraction, as well as there in inserting your finger into the vagina or anus, that also helped. When you ask the patient to contract, you feel the pressure. These all are the tests for palpation you can say. So what are the indications for pelvic floor muscle strengthening exercises? So urinary incontinence, frequency and urgency, pain in pelvic region, genital, perineum and rectum, sexual dysfunctions including erectile dysfunction, pain or numbness in genital during after sex, sexual dysfunctions after prostate cancer, pelvic organ prolapse, chronic low back pain unexplained by other sources. So what are the Kegel exercises? Actually, Kegel exercises was first described by the Arnold Kegel in 1948. So Kegel exercises are the exercises performed by any gender to strengthen their pelvic floor muscle. It involves the repetitive and sustained and rapid voluntary contractions of the muscles that usually especially treat urinary incontinence, improving sexual functions. How to do Kegel exercises? The first best thing is to ask patient to tighten your pelvic floor muscles and hold it for 3 to 5 seconds, then release it. This is the one repetition. So the same repetition you have to do for 10 repetitions in a set. So the same way you have to do it for twice a day or thrice a day, and gradually you can increase the sets of repetitions and duration of holding as well. So this is a squeezing a wrist. This is the image is just indicating that while squeezing, what happens when you're squeezing your pelvic floor muscles, there is a movement of your muscle, that is inward and upward movement will be observed when you are doing observations. So during rest, it is just downward movement of your pelvic floor muscles, we can see it. So these are the manually exercises. These are a patient has to do actively, but there are also a few devices which will help to improve your pelvic floor strengthening or pelvic floor exercises, such as this Kegel weights. Kegel weights are the weight, these different shapes. They has to put in the vaginal cavity and vagina, and it has to hold for an hour and 2 hours like that. So it will help to improve your contraction and the strengthening in your pelvic floor muscles. This is the Kegel trainer. This is a device which is usually with the mobile app. You will have the application on your mobile, as in or you have to just sit on this pad that will vibrate, and it will help to strengthen your muscles. And you can check. You can monitor the strength of your muscle, as well as you can monitor the intensity and how you are progressing in the strengthening as well, with the help of this application, mobile application. So another one device is that a magnetic chair, also available in the market. And magnetic chair also, you just have to sit on the magnetic chair, and that magnet will help to stimulate your pelvic floor muscles, which will improve the strength of the same. And the vaginal stimulator as well, it is battery operated, which is help to stimulate your pelvic floor muscles. And this external electric stimulator, this is even physiotherapy department we have that electric stimulator. With that there is electrodes, anal electrodes and vaginal electrodes. With the help of those electrodes, we stimulate the pelvic floor muscles. So these are the external devices which we have to stimulate. And we seen before that the Kegel exercises. Now we are here to understand the reverse Kegel. As the Kegel exercises, in Kegel exercises, you have to contract your pelvic floor muscle, you have to tighten your pelvic floor muscles. But in a reverse Kegel, you have to reverse the action. So it is is a technique to mindfully relax and fatigue hypotonic pelvic floor muscles. Your meta attention to the pelvic floor muscle and voluntarily tries to relax the muscles. So how to do reverse Kegel exercises? Start before doing, first of all, we have to start the gentle contracting the pelvic floor muscles and try to relax and release the tension in pelvic floor muscles. First we have to contract the muscle, then try to relax it, and contraction and relaxation, you just have to feel the difference between both, and then try to visualize the muscles between the pubic bone and tailbone, lengthen the gentle movement, moving the pubic bone towards the ceiling and gently moving your tailbone towards the surface you are lying on. Imagine that the pelvic floor muscles are getting longer. As this happens, creating more space in your pelvic floor. So during these all techniques, you have to breathe normally and you have to be calm. So it is quite difficult to understand right now. So it will you can learn this with the repetitive sessions or repetition. If you do repetition under observation of physiotherapists, you can learn that better. So now the third thing is the yoga. Yoga is also important part in the sexual disorders, as many speakers told about the psychological therapy and the psychobehavioral therapy. Along with the psychobehavioral therapy, yoga is also has a good impact on our sexual disorders as well as improving our sexual functions. So what is the yoga? Is nothing but a Sanskrit word that is yoga, that means union of body, soul connecting to the universal consciousness. So yoga is a group of physical, mental, spiritual practices which is we are practicing in India since ancient India. What is the aim of the yoga is to calm your mind and increase your concentration. So there are many types of yoga for the sexual dysfunctions and for the improving your sexual functions. We take a three part from the Ashtanga yoga, that is the asanas. There are many limbs in the 8 limbs of Ashtanga yoga, but out of that we take 3 points, that is asanas, pranayam and meditations. So now I am come to the point, erectile dysfunction. How exercises and yoga will help you to reduce erectile dysfunction or support you in the treatment of and rehabilitation of erectile dysfunctions. So there are many causes we have seen since we are having understanding since the morning: erectile dysfunction, premature ejaculation, and many other sexual disorders as well. So these are the causes. So first approach would be the aerobic activities, as I told earlier, that aerobic exercises, how will aerobic exercises have a good impact on your erectile dysfunction. So aerobic exercises improve your overall cardiovascular health, which has a direct impact on your ability to achieve and maintain erection. Aerobic exercises reduces your blood sugar level, and it also has good impact on diabetes. When erectile dysfunction is due to diabetes, aerobic activities are very helpful in that, to reduce your blood sugar level, and it also helps to burn your fats in obesity, which is one of the cause of the erectile dysfunction. So aerobic activities will help to reduce your obesity and enhance your sexual functions. Aerobic activity also help to reduce your high blood pressure, help to improve. There are few exercises, aerobic exercises, static cycling, water exercises, and there are many more exercises, I told it earlier. So core strengthening exercises are also very helpful in erectile dysfunction, as it is the core of our body, and along with that for erectile dysfunction as well as to improve erectile function, your core muscles will give you strength to do your physical activities like physical intercourse, sexual intercourse, and other activities. So aerobic activity also improves blood circulation to the penis. Strengthening exercises will help to improve your blood circulation in the penis, and Kegel exercises or pelvic exercises have proven to be effective addressing erectile dysfunction. Kegel exercises target and strengthen the bulbocavernosus muscles, which is related to your erectile dysfunction, that is, it is present on the base of your penis. So this muscle allows penis to feel blood and during your erections and hold it for the downflow of blood, hold it, and backyard core muscle strengthenings. And now come to the yoga. There are few yogasanas which has a good impact on your erectile dysfunction as well as improving your erectile functions. So those are the Paschimottanasana, Garudasana, Halasana, Baddha Konasana, Ashwini Mudra. That another speaker was telling about this Ashwini Mudra. Ashwini Mudra is nothing but a Kegel exercises. This mudra is you have to contract your anal sphincter and other pelvic floor muscles. While there are many positions in which different asanas, you can do this Ashwini Mudra. So pranayam as a breathing exercise is nothing but a breathing exercise. There are many types of pranayama, Brahmari pranayam, Ujjaini pranayam. These all pranayamas help to make yourself calm and you will increase your concentration. So then meditation also help to increase your concentration of work. Normally when you are doing any activities, you have to concentrate on that. There are very psychological aspects of sexual dysfunction. So meditation is helpful in that to make you calm and concentrate on focusing on the particular activities. So now come to the premature ejaculation. So premature ejaculation is ejaculation happens sooner than man or his partner would like. So these are definitions, everyone knows about that. So I would like to explain one point here that is important. Contraction of epididymis, ejaculated ducts and seminal vesicles believed to be because of sympathetic nervous stimulation that causing ejaculation of semen. Maybe it's earlier premature ejaculation. So the causes of premature ejaculations are lot of causes are related to your psychological and related to your personal, emotional and mental causes are there. So what are the effect of exercises? Aerobic exercises will release happy hormones, as earlier we heard that, we understood that earlier. So aerobic exercises will release happy hormones that help to reduce your stresses and improve confidence, improve your balancing in hormonal level. Kegel exercises help to strengthen pelvic floor muscle and improve blood circulation in the penis. So yoga, parasympathetic stimulation through yoga practices is beneficial in enhancing ejaculatory control. Yoga also has a positive effect on relieving stress, anxiety and depression. Pranayam is controlled breathing techniques that is part of yoga, and deep breathing can help in delay sexual responses. So these all are the aerobic exercises and the Kegel exercises. These are two positions which are beneficial in the premature ejaculations. So any sexual position in which a male partner don't has to give a lot of effort, that position definitely helpful for the premature ejaculation in cases of premature ejaculation. So another topics, that is vaginismus. Vaginismus is the condition in which a female has the fear and painful intercourses because of maybe there is tightness and hypertonicity in the vagina and the pelvic floor muscles. So it is involuntary contractions of hypertonic state of pelvic floor. So exercises in yoga, as everyone knows about that, pelvic floor muscles exercises are definitely helpful to each and every dysfunctions and sexual dysfunction as well as urinary dysfunctions. But in this condition, first of all, because this condition is not a relaxed, this condition has a hypotonic state of pelvic floor muscles. So our first approach should be relaxing and reducing the anxiety in the females. So after that, reducing pain and hypotonic state, desensitization, pelvic floor muscle exercises, then core stabilizations. So relaxation, for relaxation, aerobic exercises, pranayama, meditation will help to keep mind relaxed and reduce anxiety. One diaphragmatic breathing exercise will also be useful to reduce anxiety and relaxation. Reverse Kegel exercises and massage with gentle pressure help to reduce tension in the pelvic floor muscles. So reduction of pain and hypotonic state, we can use transelective nerve stimulation to reduce your pain in the pain. And there are different type of stretches you can use to relieve your pain, such as piriformis stretch, adductor stretches, pelvic floor muscle stretches will help to reduce pain and the tone in the pelvic floor muscles. Also yoga asanas will help to reduce tone. Desensitization, tissue desensitization with the gradal vaginal dilators are there in the market. With the help of the dilators, we can stretch the vagina as well as pelvic floor muscles, and that will help to reduce the tension and desensitize the vaginal pelvic floor muscles. But always remember that whenever desensitization techniques we are using, it should be with along with the relaxation technique as well. So vaginal dilators, bands, such type of dilators and bands are there. It will help to reduce. It will help to desensitization. And this is the deep squat stretch, which is helpful to give stretching to your pelvic floor muscles. It will help to reduce pain as well as the tone in the pelvic floor muscles. Again, the Baddha Konasanas, Bhujangasanas, happy baby pose, child pose. These all poses, your asanas are helpful in the vaginismus as well. So now there are other sexual activities disorders like a desire disorder, arousal disorder, orgasm disorder, pain disorder, vaginal drainage. These all conditions will also has a good impact with the help of aerobic exercises, core strengthening exercises, pelvic floor exercises, yogasana, meditation, pranayama, breathing exercises. It helps in every conditions of the sexual health. So sexual health after spinal cord injury. So spinal cord, just Pramod Surya sir explain about the spinal cord injury, sexual health after spinal cord injury. So I am just here explaining the physiotherapy approach after the spinal cord injury. As after spinal cord injury, there are motor and sensory loss may or may not be there with the depend on the severity of the spinal cord injury. So first physiotherapy approach should be firstly we need to assess the pelvic floor muscle with power, tone and sensation. According to that, our physiotherapy treatment can be changed, or according to that we'll consider how to approach and how to start the physiotherapy rehabilitation with such kind of patients. So muscle power, hip zero, there is then we have to activate the muscles. We need a few stimulator. We stimulate the muscles to activate. As normally muscle power 0 to 5, we have to increase that power. So if patient having 0 need a stimulation as well as a few stretches, and it will help pelvic floor. Then if muscles are not 0 but it has a power, but power is less, like grade 1, 2, 3 like that. So pelvic floor muscle exercises you can start over there, so it will improve the power and core stability. As we already in spinal cord injury, as a physiotherapist, we are doing a lot of exercises, doing rehab patients with other body part like legs and patients passive movement stretches, like other activities we are giving to improve strength in the muscles of upper limb, lower limb as well as core stability. So along with that, need to focus on the pelvic floor muscles as well. So breathing exercises, yoga, asana, meditation also will help to improve power in pelvic floor muscle. After spinal cord injury also help to psychological and help to make patient happy and conscious, concentrating and calm after the spinal cord surgery. So last point is the sex itself is a exercises. Sex is a really great form of exercises. It won't replace other type of exercises like aerobic activities, strengthening exercises and physical other activities, but it can be considered as the best aerobic as well as the best strengthening exercises. Sex uses about 4 to 5 calories per minute and 100 to 150 calories per calorie during sex. So what are the benefits of sex? As like other activities, sex also has a good benefits like reduces stress, improve sleep, improve heart rate, lower blood pressure, better heart healthy possible including lower risk of heart disease, decrease depression, anxiety, increase libido, natural pain reliever, also help to reduce dysmenorrhea or pain during the menstruation. And thank you so much.
Thank you, Sajjananand. Any audience, any questions? Okay. Now I'd like to request Dr. Bajrang Kale sir to come on the dais, please, and felicitate Dr. Sajjananand.
Sir, one question to Dr. Kadlak. Sir, would you like to add anything in this?
Nice talk given by Dr. Sajjananand sir. I would like to add one thing only. Along with all these things, we can more concentrate on the breathing pattern, the inhalation and exhalation while doing the pelvic floor exercise, because diaphragm also plays very vital role in such cases while doing the Kegel exercise. Plus, including the abdominal pressure also helps to give more activation to the pelvic floor muscle. If you concurrent and synchronize with diaphragm and with the pelvic floor muscle, it gives more result to the patients and give faster result also.
Dr. Bajrang Kale sir, I request you to felicitate Dr. Sajjananand. Dr. Bajrang Kale sir is a consulting physician practicing in area of Kedgaon. I request Bajrang Kale sir to felicitate Dr. Sandeep. Sandeep sir, please. Dr. Bajrang Kale sir to felicitate Dr. Sushant Shinde sir. Thank you, Sushant sir. Thank you, Sandeep sir. Thank you, Bajrang Kale sir. Thank you, Sushant sir. So with this lecture, we'd like to end our today's session. The day tomorrow we'll start our lectures from 9 a.m. and the breakfast will be served at 8 a.m. Thank you everyone. Thank you.